And this is the picture of a Stryker 1788 system. So it has a monitor, the fluorescence imaging, 1788 camera, which is very good. There is a SPY portable handheld imager to use during open surgery. Like if you are resecting the bowel, we need to know the vessel supply. So we can use this handheld imager. There is a connected OT hub, pneumoclear all-inclusive insufflator, including the heating, humidification, and the smoke evacuation, all combined. Also, there is a powerful and versatile camera control unit. The light source is very good, and it can visualize CytaLux, which is a new dye for use during cancer surgery. There is a video processor and illuminator, connected OT card, and a printer to print during surgery. And the smoke evacuator of Stryker is very good, because we all know that surgical smoke is very dangerous, and most of the nurses as well as doctors feel more comfortable if the smoke is not there during surgery. The third one is VISERA 4K from Olympus. It has come with a new innovations that it has included narrowband imaging in technology in its camera system. The cost is in mid to high range. And this is the system. It has a xenon light source, ultra telescope, camera head, camera control unit, 31-inch monitor as well as 55-inch large monitor. And this is the camera head. The camera head is very good. It has, and the camera has CMOS sensor, so there is less noise with no delay in transmission. There is a one-touch autofocus and electronic zoom with no blurring of vision if it is enlarged, and the design is very ergonomic. Richard Wolf has come with Endocam Logic 4K. So the camera is very good with very high resolution. There is a video recorder along with it. And the camera head is there, which is autoclavable, as well as it can be replaced in the hospital by the technicians. And the endolight is there. They claim that it can last up to 30,000 hours and with constant illumination. And the energy efficiency is very good. It consumes 80% less power compared to xenon lamps. This is the PanoView Ultra Telescope and the 4K monitor. So to compare, Karl Storz is the most advanced in terms of innovation, but it has a very high cost. The Stryker is robust. It also provides most of the features. Olympus has narrowband imaging included, and Richard Wolf is a study with it has a good balance of quality and cost. The cost is least in Richard Wolf among these four. Now coming to Indian brands. These are the Indian brands: Unilabs, Cara Mediclus, TSC Medicams, Mindray, GTB Surgical, and Deves Meditech. There are many others. However, I will be talking about these. Unilabs is there. This is the latest one. It has a 4K resolution with 3-chip technology, user-friendly interface, and it has compatible with all the 4 systems I talked earlier. This is the Uniflator of Unilabs. It has mechanical and electronic safety valve to create the safe pneumoperitoneum. Preheater and smoke evacuator are included, and there is a ULPA filter for microorganisms. This is the LED light source, which is noiseless and can last up to 50,000 hours. Now coming to Cara Mediclus, it also claims that it has a 4K system with 3 chip, and there is a full HD recording system. Its LED light has 120 watt power and can last up to more than 60,000 hours. And there is a homogeneous lighting with maintenance free. It is free of maintenance. They claim that. And this is the insufflator with maximum flow rate of 30 liters per minute. This is the ESC Medicam system. It is also 4K with inbuilt recorder and large monitor. There is a 4 times pixels power, and multiple monitor view in the same monitor can be there. It has a CMOS chip sensor, and its price is approximately 6 lakhs. This is the light source along with the ESC Medicam system. This is the laparoscopic CO2 insufflator, 30 liters. So which one should you buy? Refurbished international or Indian or new international? The advantages of refurbished international are they have a very high quality, since they are already made of they come up from the international brands which have a tried and tested record. And they include all the advanced features. Cost savings is there because they are definitely cheaper than the new international ones, and they have a proven reliability. However, the disadvantages are the warranty is through a third party, so it may not be reliable, and the maintenance support is also not very reliable. And even though they have been refurbished, they must be having some wear and tear which may affect the long-term durability. And the availability of parts also becomes an issue. Since the original company does not provide the parts, then we may have to contact the third party, and there is a delay. Coming to the new Indian made cards, the advantages are they are cost effective. Sometimes they are even cheaper than the refurbished international ones. And see, there is a local system, so they give full warranty and support. And the local manufacturers can customize according to the surgeon's specific needs, and they are usually compliant with the local regulations. However, the drawbacks are they may not include the latest technology, the features may be less, the brand's perception is definitely lesser compared to the international ones, and the build quality, even though they are coming means better, but they are still lag behind the international ones. So what should be the general budget allocation for a laparoscopic surgical suite for a new system? So 40 to 60% of the budget should be given to laparoscopic instruments like trocars, graspers, scissors, cartridge, insufflators, and light source. 20 to 30% to vision cards, cameras, monitors, recording systems. 10 to 15% to OT integration systems as well as data management systems. And 5 to 10% each to ancillary equipment and furniture like OT table, sterilization unit, training the staff. If we have to bring a proctor for a new technology, then that cost should be included in 5 to 10%. And 5 to 10% should be kept for contingencies, or if the maintenance has expired, then we need to get the maintenance done by ourselves. So if you are allocating 1 crore for the cart, 40 to 60,000, 60 lakhs should be for surgical instruments and equipment, 20 to 30 for imaging and visualization systems, 10 to 15 for operating room integration system, and 5 to 10 lakhs each for ancillary equipment, training and support, and miscellaneous costs. So when is the right time to upgrade? The right time is if they had. So just these are the two last slides. So the right time to upgrade is when there is a technological advancement. Like if a new feature has come and we cannot do our surgery without this feature, or if integration capabilities have come which are not the system is not being integrated with our own OT system, then we may need to upgrade the system. Second is performance issues. When the instrument is out for the maintenance most of the times and we cannot do our surgery, or if the technology has become obsolete in today's time, we may need to upgrade the system. If the clinical needs are there, if the surgeon is going from basic to advanced procedures, he may need new systems. Like if he has started doing radical prostatectomy, radical cystectomy by laparoscopy, he may need a 4K system or 3D system. Cost of maintenance is a big factor, and budget availability, like if he has got a grant from CSR or from a donation, this is the right use of that grant. Last one is regulatory and compliance. If the compliance of a previous device has expired, then a new device is required. Also, it has an advantage that reputation and attraction. That means if you buy a new system, the top surgeons get attracted to that center. The patient will also come. The patient outcome will improve. And if the surgeon and the staff working there always complain that the system is not very good, then we may need to upgrade the system. Thank you.
Thank you, Dr. Naveen. For short of time, we'll skip questionnaires to the end. Next,
thank you, sir.
May I invite Dr. Vikas Agarwal, difficult hilar dissection in anomalous renal anatomy. We request speakers to stick to time of 5 to 6 minutes, please. Thank you.
Thank you, Abhishek and organizer and NPS team for giving me this opportunity, and really pleasure to be on this desk at JPAC. So I will be talking about difficult hilar dissection. He has given me the topic on this. So as we know that hilar dissection, as since morning we are seeing, it's a really important step whenever you do the nephrectomy. And generally single renal artery and vein is considered as anatomy, but it is not always. We found double renal artery in 20 to 30% cases, 3 renal artery in 1 to 2% cases, and sometimes we came across up to the 4 renal arteries. So I will be talking about to study the anatomy preoperatively before dissecting your plan, and assess how difficult is preoperatively. It is important to assess which case is really difficult, and what all instrument can help you dissect the hilum, and how to reach safely up to the hilum, and then lumbar vein dissection, the multiple renal artery and renal vein anomaly, and sometimes the troubleshoot. So to see the anatomy is very important. Nowadays we have very good 3D angio, and we can see what are the number of the arteries in the vein, what is the relation of the vein to the artery, and what are the accessory artery, then what is the lumen? Then it really need to sacrifice, or we have to preserve it. And what is the early branching? If there is a renal artery early branching, then we have to see how early and the late confluence of the renal vein. Then right side, if we have to take, then we have to really assess where is the IVC, because if we see this, it's looking like 2, but once you will take the IVC here, it will can become 3, or you have to dissect in between the aorta and the caval dissection. And then to look for the venous anomaly like retroaortic renal vein, pre-caval renal artery can be there on the right side, or the double IVC sometime, or the situs inversus. I will be talking this. So which case you are really difficult to start? So infected or pyonephritic kidney, you can think of that they can have a nephrogen hilum. Xanthogranulomatous pyelonephritis, large renal mass in which all the anatomy is distorted, and this is compressing of your renal vein or the artery. So large renal mass are difficult to operate, and previously operated patients, or sometime in the previously operated cases, you have the urinoma. So there will be dense adhesion in the hilum that will be difficult to operate. Malrotated or the horseshoe kidney, and to me, the simple nephrectomy is most of the time is not simple. We call it as a simple nephrectomy. So what all instrument we have discussed, energy source, suction is my one of the favorite instrument when we do the dissection. Maryland dissector, right angle dissector, clips, back clips, 5 mm, 10 mm, Liga clips, or Satinsky clamp for your safeguard you if you have any problem. So how to reach safely? So it's very important to dissect the bowel appropriately, the plane in the morning we have seen, and then to lift the urotogonadal packet, so that this is your guide that you can reach to the hilum. It's very important to lift the urotogonadal packet adequately, and that is a guide to reach to your hilum. So once you are reached to the hilum, the first thing on the left side you came across is the lumbar vein. Since in the morning we have not seen any patient who's having lumbar vein, but it is very common finding. So lumbar vein are really covering your renal artery. So it's like a bodyguard. Until unless you will dissect the lumbar vein, you will not be able to see the renal artery most of the time. So now you see this is the anatomy, but you can get the variation of the lumbar vein. So this lumbar vein is the straight one. So I always dissect gently, and because once it starts bleeding, so it may get retract, or it can lead to difficulty and dissecting further. So you dissect it, and I always clipped it. So previously you have seen someone that who is doing with energy source, but I really prefer to clip it by, and then in between you have to cut it sharply. I don't use harmonic in between, because otherwise the stump will be get damaged. So it's important. And now this is another variation. Here you can see small renal lumbar vein, and then it's bifurcating. So you have to be very gentle when you are dissecting the lumbar vein, otherwise it can lead to the bleeding. And then you come across the multiple renal artery. So this is the renal artery, and here whatever you will do is avoid any energy source near to the renal artery if you have to, like, donor nephrectomy. Otherwise you can go ahead. And now you see you have to have double clip and cut, and there has to be, you have to hear the sound of the click, and you have to keep some space before cutting to the renal artery. And this is the case of early branching, and which is supplying to the lower pole. And once you reach there, then because when you will apply the clip, it will become 2. So that you have to assess preoperatively, and because it's going to the lower pole, then you have to save if you are doing the donor nephrectomy. And this looks like very early branching, but now you see when we dissected it appropriately, you can see that you can get this good stump. So you can apply the 2 VAC clip easily, because in the preoperatively you see that it was very short stump, and you can apply the 2 VAC clip here, and then you can cut, and you can get the common stump, and there is no need to do the band surgery. And sometime you came across 3 renal artery. Practically it is a 2, but it's very early branching, the upper one, and finally it will be once you will apply the clip, it will become the 3 renal artery. So preoperatively CT angio to read and to assess that where you have to do, and how it is going to affect your surgery, you have to be very sure before proceeding. And finally these are the 3 renal artery that you have to do the band surgery, and you have to reconstruct. This is again 3 renal artery. Here it is important to see, because the lower pole artery is very far away from the hilum. So once you are lifting the urotogonadal packet, you have to be very gentle, because this is the lower polar artery which is very far away from the hilum. So you have to be very cautious when you are dissecting it, because otherwise it can be damaged, or you can unnecessarily coagulate it or clip it. So you have to know the anatomy, because it is going very far away from the hilum. So once you will start lifting the urotogonadal packet, so you have to be very cautious, and then only you will be able to save this part. And it was bilateral triple renal artery. So here you can see all is completely dissected, and this is 4 renal artery. On the CT angio, it looks like three renal artery, but once you will go and see the other planes, there is very early branching on the upper side. So this is the smaller one, the lower one, and finally we get the four renal artery for the transplant. So after this, we get right side. There is a different anomaly like double renal vein, and normally in the right side we get the renal artery which is retrocaval, but sometimes pre-caval. So this is a pre-caval renal artery at the lower pole. So you have to dissect it, and it is a double renal artery, double renal vein, and finally you can get with this clip and you can manage it. And these are the some anomaly like double IVC. You have to be known this anatomy because you can't think it is like a large lumbar vein. So it's simple like that. It is happening on the right side, but it is a double IVC. So you have to be very conscious and you have to clip your renal vein as you do on the right side. And sometime you came across this kind of the design. So this is previously operated patient. It's really difficult to assess its LUTS. And then to get the access, it's difficult. And then to dissect, it's again a problem. And but with experience and with all your precautions, you can reach to the hilum and you can really dissect where is the renal artery and the vein. So these are troubleshooting. I will be just skip because of the time. So you can, but main important thing is whenever you have a bleeding, just pack it and wait for some time, and then you can have an extra help or extra port, and that will help you. Thank you. So with JPAC, enter to learn and exit to serve. That's it. Thank you very much.
Thank you, Dr. Vikas. Yeah.
Left side tumor, you are saying? So whatever you will do, you have to follow your plane. Until unless you will follow your plane, like if the left side, you have to follow on the aorta. So because your patient is the lateral side, so the anterior branch will become lateral, and your lateral branch is seeing to you. So it's very not very common to see that supramesenteric artery until unless you will go deep. And if you take that plane of the aorta and remain into your plane, and I think you will can avoid the catastrophe of dealing with the supramesenteric artery as a misleading as a renal artery. Thank you, sir. Sir, as far as possible, we do not do the stapler, both the artery and the vein. If you have really difficult, then you can attempt, but I personally do not prefer to do it. It is better that you do the dissection in pieces so that you make some space and apply the clip, and it at all you are not able to progress, then it may be the choice, but so far I have not done as a complete stapler and remove it.
Thank you, Dr. Vikas.
Thank you.
Next, I'd like to welcome Dr. Pavan Survasi to give a talk on laparoscopic management of undescended testes.
Undescended testes are most common congenital anomalies of genitourinary tract. Incidence is 3% in full-term babies and up to 30% in preterm babies. Of total undescended testes, 30% incidence is of impalpable testes. What it means, 70% times you can palpate testes in the inguinal region, but 30% times you cannot palpate. So these testes either at internal ring or intra-abdominal, and there is a role of laparoscopic approach in these cases. Good morning, everyone. I am Dr. Pavan, and I'll be speaking on laparoscopic approach of undescended testes. Nothing to disclose. So what is the basic principle? Identify the location. There are a lot of imaging modalities are available to identify the location. Ultrasound, CT, MRI. But whenever we are talking about intra-abdominal testes, the best modality for the diagnosis and treatment is laparoscopy. Identify the syndromes, placement in the scrotum, prevent the damage to the testes, and proper fixation. Testes may descend up to 3 months of age. So ideal age of fixation is between 6 months to 12 months. As all we know, it is laparoscopy is minimally invasive. There is a shallow learning curve and magnified view of vessels and spermatic cord, best seen in laparoscopy compared to any other approach. High dissection, peritoneum over vessels preserved, and early discharge from the hospital. These are the advantages of laparoscopy using in these cases. So what is the anatomy? Once you identify the testes, remember three things. First, testicular vessels. These are arising from the aorta going into the testes. Next is spermatic cord. It is exiting from the testes going towards the pelvis. And third one is gubernaculum. So testes and along with these three structures, your job is easy. Remember this anatomy. If you, in this picture, okay, so we can see the testes. Okay, so now it has gone. Some fancy transitions. So this is the testis. We can see here. These are the external iliac vessels. These are the testicular vessels. Cord structures are exiting here, and the structure going into the inguinal ring or towards the inguinal canal will be gubernaculum. So once we are clear with the anatomy, this surgery we are divided into 7 steps. First 3 steps are about port position, positioning, pneumoperitoneum, then port placement. After that, diagnostic laparoscopy, then mobilization of the vessels and spermatic cord. This is the most important thing in undescended testis management. Scrotal port placement and delivery of testes, and then dartos pouch creation and fixation. Position, supine position. Pneumoperitoneum can be created with the open method, depends upon the age and the weight of the child, and varus needle. This port placement again depends upon the age and the weight of the baby. First port, camera port, we can place at the umbilicus, and then working ports, right and left ports, depending upon the camera port, will be approximately at the 30 degree angle to the camera port. Surgeon will be obviously standing towards the head side, either on right or left, depending upon the testis. This is the normal anatomy you will get. Can you see here? These are the external vessels. This is the spermatic cord going toward the pelvis, and these are the testicular vessels. What are the variations we can get during the management? Patent processualis vaginalis. So once normal testis in the scrotum, there is no communication with the peritoneal cavity. If the peritoneum enters along the cord into the scrotum, it's called processus vaginalis. So again, it can present with the hydrocellular hernia. So this patent processus vaginalis, then intra-abdominal testis, obviously. This can be high abdominal testis also. Peeping testis. Testis will be present at the inguinal ring. Once you press, they can descend into the inguinal canal, and hence vice versa. And vanishing testes or blind ending vessels. Here testes are atropate. Same, everything is depicted in the picture. Patent processus vaginalis. These are the peeping testes. Then this is the intra-abdominal testis. And these are blind vessels. We can see here internal ring is completely obliterated, but we can see the cord and the vessels, but their testis is not there. So testis is absent or atropate. Mobilization. Again I'll emphasize 3 important structures: testicular vessels, testes, spermatic cord, and gubernaculum. That's all. You need to dissect over the peritoneum over the testicular vessels. Go towards the testes, try to identify the gubernaculum, then extend this incision towards the spermatic cord. Dissect the vessels and spermatic cord. The most limiting, rate limiting step here in management is testicular vessels. Sometimes we get very short length. That time we need to follow the Fowler-Stephen procedures. Scrotal port placement usually will be at the base of the scrotum and medial to the epigastric vessels. Dartos pouch. So scrotum has a skin, dartos fascia, and then external fascias. So just below dartos, after skin dartos, just below dartos, create a subdartos pouch. This is a small video presentation. Pneumoperitoneum is created at the umbilicus with the varus needle.
Dr. Pawan.
Yeah, sir, 1 second. Yeah. So this is just a summary. Again, start incising the peritoneum over the testicular vessels. Proceed your dissection towards the inguinal region. try to identify the gubernaculum, you can clip it, or directly you can use energy source to cut the gubernaculum, extend this incision towards the spermatic vessels. You can pull this testis toward the opposite internal ring just to see the adequate length. So for pelvic surgery, those who want to start pelvic surgery, this should be considered as you should start with the undescended testis procedure. This port we are placing from the base of the scrotum, 12mm port, catch hold of gubernaculum and then pull it, and we can fix the testicle into the subdartus pouch. Thank you so much.
Thank you, Dr. Pawan, for a wonderful demonstration. Next, we have Dr. Chandrakant Munjeva talking on laparoscopic adrenalectomy step by step.
A very good morning to all of you. At the outset, I would like to thank the organizers for giving me this opportunity. My talk is on laparoscopic adrenalectomy step by step. Yes, so I'll be talking on laparoscopic adrenalectomy step by step, starting with this man. He did first laparoscopic adrenalectomy in 1992. I'll start with the surgical anatomy that one should be aware of while doing a laparoscopic adrenalectomy. The right adrenal gland. The right adrenal gland, which is located in the just superior to the right kidney, upper pole of right kidney, is a triangular shaped gland. It is medially bounded by IVC. Laterally, it is by the upper pole of the kidney, inferomedially by the duodenum, and anteriorly by the bare area of the liver. It usually has a single vein which drains into the IVC and is fed by multiple arteries from the inferior phrenic aorta and the inferior renal artery. Both the adrenal glands usually weigh around 5 to 6 grams, and they are around 5 in the longest dimensions. So, coming to the left adrenal gland, this is a crescentic shaped gland, and it is bounded medially by the aorta, laterally by the upper pole of the kidney, inferiorly usually the renal artery. It has an adrenal vein that drains directly into the renal vein, or there can be a variation with a inferior phrenic vein draining into the renal vein separately or into the adrenal vein. It is also supplied by arterial branches from the inferior phrenic artery, aorta, and the left renal artery. One important point that one should be aware of while doing adrenalectomy is variations in the adrenal venous drainage. It has been well reported around 10 to 20% of the cases have a variation in the venous drainage, especially on the right side, where you get a adrenal vein that is draining into the accessory hepatic vein or into the hepatic vein, or you might get multiple adrenal vein draining into the renal vein and into the IVC. Similarly, on left side, the variation that one can get is there could be a 2 adrenal veins, or there could be a separate inferior phrenic vein draining into the renal vein. It's well reported into the literature. Around 13% in this series of 546 laparoscopic adrenalectomies, there was a variant venous anatomy, and more so common on the right side. It was associated with more estimated blood loss, and so it's they concluded in a way that understanding the variant adrenal venous anatomy is important to avoid bleeding during laparoscopic adrenalectomy. Similarly, in this study also, they did this is basically for the adrenal venous sampling in patients with Conn's syndrome, where they found around 20% of the patients, they have a right adrenal vein formed a common trunk with the accessory hepatic vein. We had one experience of a case this is a case of Cushing syndrome, where a right adrenal vein was draining into the accessory hepatic vein that was draining the caudate lobe, and they formed a common trunk draining into the liver, draining into the IVC. So this was the particular case. Here you can see the adrenal vein is draining, forming a common trunk with the accessory hepatic vein, and they are draining into the IVC. So in such cases, you need to be aware about the variations that you can get and to deal with it intraoperatively. Now, coming to the indications, we all are aware about the indications for laparoscopic adrenalectomy. Only one point that I want to add here is in laparoscopic, particularly in the initial part of career, one should avoid taking the large cases, especially the large more than 6 centimeter or 8 centimeter functional tumors. Coming to contraindications, its absolute contraindications are ACCs, large and invasive, and a severe cardiopulmonary disease. There could be some relative contraindications like large tumors, as I said, 8 to 10 centimeter, small localized ACC, and a morbidly obese patient. We had one patient of Cushing syndrome. She was morbidly obese, and since after creating a pneumoperitoneum, she was not able to tolerate it. Her peak pressures were rising, so we had to do open surgery with such a large incision for such a small tumor. Now, coming to pre-op preparation, the adequate preparation that involves is blood pressure control and correction of electrolytes, especially in the functional tumors, IV corticosteroids intraoperatively and early postoperative in cases of Cushing syndrome, adequate alpha and beta blockade for pheochromocytoma, preoperative antibiotic prophylaxis, antithrombotic measures, especially when you're doing bilateral adrenalectomies, long duration surgery, or in cases of Cushing syndrome, Foley's, Ryle's tube, and a cross-match blood. Very important when you are attempting a right adrenalectomy. There are chances to nick the IVC, so be prepared with it. Coming to the instrumentation, a Varys needle, a 10 mm 30-degree telescope, 2 10 mm 5 mm trocar and cannula, a non-traumatic grasper, energy device, very important, harmonic ligashore or a thunderbeat, a Maryland forceps, locking as well as non-locking, a mixture, lap scissors, a hook, liver retractor fan shepherd, a suction cannula, and a clip and a hemlock applicator. The patient position is same as we do it in lap nephrectomy. It is a lateral that we prefer doing and around 45 to 60 degrees oblique. Port position for right. The important part about port position is this is the one camera port that is usually medial to the midclavicular line, 10 mm camera port, and a left 5 mm and a right 10 mm port. This is the number 4 is a liver retraction port, and at times when the liver is quite big enough, you can use a 5th port for holding the liver from falling down with a fan-shaped retractor. For left side, you usually don't require a 4th port. However, the 3 ports that we use are port just lateral to midclavicular line, that is a camera port, one right 10 mm port, and a left 5 mm port. Now, just a video of right as well as left adrenalectomy. I'll just sum up with the video. This is a case of a small adrenal tumor causing a Conn's syndrome to this patient. And the first step is incising the triangular ligament and incising the posterior parietal peritoneum. So after incising the parietal peritoneum, you get an adrenal gland. Here it was a small adrenal gland, so we had to use 2 retractors. One to avoid falling the liver with a fan shepherd, and other right hand retractor just to retract the liver at the upper margin of the adrenal gland. This is the adrenal vein. On right side, it is usually a short and wide, so you just don't need to dissect much enough to cause bleeding. After clipping of the right adrenal vein, one should always look for adequate length of the vein that has been clipped, and rest is the dissection of the adrenal gland. Coming to the left side, on left side compared to right, the left adrenalectomy is quite easier. This is a case of pheochromocytoma, a 5 to 6 centimeter tumor. Colon mobilization is required on left side, which is not usually required on a right side. Here, after colon mobilization, a spleen need to be medialized so that we can easily create a plane between pancreas and the medial border of the gland. Here, one important point is coming to the hilum, identify the renal vein, and then trace the adrenal vein. Clip
Sir,
the
can you
adrenal vein.
conclude, sir?
And rest is to dissect out the adrenal gland. Yeah, one more variation that you can get on left side is a left inferior phrenic vein, which can drain into the adrenal vein that you need to clip. So to conclude, my take-home message would be well versed with the surgical anatomy of adrenal gland. CT should be well read before the procedure to identify the adrenal vein drainage and variations, if any. One should avoid large masses more than 6 centimeter in the initial part of career. For functional tumors, adequate medical management in the perioperative period under endocrinologist guidance should be done. Also, adequate blood products and vascular set of instruments should be kept arranged, especially for the right adrenalectomy. Thank you.
Thank you so much.
Thank you, sir.
Okay. Thank you so much. Thank you so much, chairpersons, for the session. Now I would like to call upon Dr. Santosh N for the session Practice Changing Publications.
Very good morning to all of you. I request the chairpersons, Shailesh sir, Prashant sir, and Anil sir to please come on stage. So you can come and-
Good morning, friends. Actually, we are running behind the schedule, so without wasting much time, I call upon the first speaker, mini versus standard percutaneous nephrostomy in pediatric population.
Sir, I'll just take a minute.
Yeah.
Thank you, sir. So we have 7 speakers. The time for each speaker is 5 minutes for the presentation and 2 for questions. At 4 minutes, you'll get 1 bell. And then at 5 minutes, you'll get 2 bells. We should be able to squeeze in 1 or 2 questions. Please be interactive. And you have markings for the time and the questions. So try to finish in time. All the best.
Yeah.
Thank you, sir. So I am Dr. Naveen Kumar, and my article is on mini versus standard PCNL in pediatric population, a randomized control trial, which was published in the December issue of Journal of Pediatric Urology, which has an impact factor of 1.92. Next. So we all know that mini PCNL has gained popularity in adult patients since it reduces the complication with comparable stone-free rates. However, PCNL is done by standard techniques as well as by mini PCNL. There is no level 1 evidence regarding the non-inferiority of mini versus standard PCNL in the pediatric group, and this was the first randomized control trial on this topic. So we performed this randomized study to compare mini PCNL with the standard PCNL for management of renal calculi in patients less than 18 years of age in terms of safety, efficacy, and stone-free rate. This was a prospective single-blinded randomized control trial conducted between June 2015 to March 2021, and all the pediatric patients who underwent PCNL for renal calculi were included. The randomization was into 2 groups in 1:1 ratio using simple randomization with the software randomization.com, and group 1 had mini PCNL with seat size of 16.5 French, and group 2 underwent a standard PCNL with seat size of 26 French. Prone PCNL was done in all cases with bullseye technique puncture. Double J stent was placed in all cases and nephrostomy in most cases, except in very few simple mini PCNL patients. Primary outcome was a stone-free rate as well as hemoglobin drop. And secondary outcomes were operative time, pain score, need of analgesia, complications according to Cleveland classification, and length of hospital stay. Sample size was calculated using the settings of type 1 error of 0.05 and power at 80% based upon the outcome of hemoglobin drop. As mentioned in the study by Zhong et al., we did not base this sample size on stone-free rate since it had come to 1,000 patients for both groups. which was not possible. Minimal sample size was 16 cases per each group. Unpaired t-test and man whitening U-test were done, and p-value less than 0.05 was considered significant. This is the consort diagram. It means 54 patients were assessed for eligibility. However, 4 were excluded due to prior interventions or renal anatomic abnormality or renal insufficiency. 50 were randomized, 25 in each group. No patient was lost to follow-up, and 25 were analyzed in each group. These were the preoperative characteristics. The stone size was comparable in both groups, and stones were located in all the calyces as well as in pelvis and upper ureter. There were multiple or staghorn calculi in 9 and 10 patients in each group. Means all preoperative parameters were comparable in both the groups, including mean age and mean BMI. Supracostal puncture was done in 8 patients in both groups. 7 in the mini PCNL group had supra 12-3 puncture, and 1 had supra 11-3 puncture for a upper calyceal calculus with narrow infundibulum. So coming to the intraoperative and postoperative parameters, operative time was significantly higher in mini PCNL group. However, hemoglobin drop, hematocrit drop, visual analog score on POD0 and POD1 evening, IV paracetamol requirement, and complications were lower in mini PCNL group. One patient had nephropleural fistula in the standard PCNL group. This case has been reported, and hospital stay was comparable between both the groups, and the stone-free rate was also comparable between both the groups. The limitations of this study was, it was a single center study. There were a small number of participants, so a priori matching of characteristics was not done before the study, and supine PCNL was not practiced in our institute at that time, so it was not a part of the study design. To summarize, mini PCNL provides equivalent stone-free outcome with lower complication rate compared to standard in pediatric population, and the size of tract is proportional to the nature of complications like hemoglobin drop and postoperative pain. Operative time is longer in mini PCNL, since as the tract becomes narrow, the retrieval of the we have to break the stone into smaller pieces, and the field of vision is also narrow. However, it did not translate to any adverse effect in the safety profile. Further trials with more patients are needed to corroborate the findings and strengthen the evidence. Thank you.
Thank you. Very good. So, Naveen Kumar, yeah. The study was started in 2015
Yes,
onwards, and at that time, most of us knew that bigger the implant size or a sheath size, the more is the bleeding. And
yes,
in pediatric, most of us were using inner sheath. So I'm surprised that you have a 25 cases with 26.5 French sheath.
yes, sir.
And none of the patient had a significant bleeding in that.
Means significant bleeding was there, sir. Hemoglobin drop was more in the standard.
You didn't require any transfusion, you said.
No, sir, no transfusion was required.
So that is contrary to whatever data is given, or in practice when we see in a pediatric patient, because the volume is less, and if you use a 26.5 sheath, the bleeding is expected to be more, unless you are.
No, the bleeding is more, sir, but transfusion was not required. Means I do pediatric PCNL still also, and sometimes I do with 26 French sheath. The bleeding is slightly higher, but they don't require transfusion. I have done 4 or 5 cases with 26 French sheath in pediatric. Now also.
Okay. Yes, sir. Mike, sir.
Sir.
Can you speak in mic, sir, for us?
What is the mean age in your both?
So mean age
is 9 to 10 years.
9 to 10 years.
Yeah. So the issue is, if you want to see the pediatric population, you need to subclassify.
Yes, sir. We did not subclassify.
So some of these 9-10 will be something like close to adult.
Yes, sir. Definitely, sir.
And number 2, what you have not told is, you are dealt these with the instrument that we use in adult or pediatric instrument. That means smaller implants, smaller guide wire, smaller sheaths. That is not mentioned. You got my point?
Yes, I got your point. So definitely.
So when you talk of pediatric patient, we are.
There may be variation. Some patient may be 2-year-old, some patient may be 16-year-old.
Yes.
But sir, we did not classify because the number of patients was small. So
Thank you.
sample size was small.
Dr. Naveen.
Yes.
You started the study with the calculated sample size with the power of 80% and alpha of 0.05.
Yes.
And you needed 16 cases in each group.
Yes.
and you have 25 cases in each group. So you cannot say that the sample is small.
Sir,
You already surpassed the sample. That means the criteria that you decided
Sir,
at the
the
start of
sample
study
size-
already been surpassed.
So the sample size is small to sub-classify into various groups.
But in the limitations, you said that the size is small.
Yes.
Yeah.
Thank you, sir.
On to the next.
The next speaker, Rohit, he'll be presenting on intraoperative low-dose epinephrine infusion in TURP, a double-blinded RCT. Rohit.
Good afternoon, everyone. Greetings from AIMS Bhubaneswar. I would like to speak on a double-blind randomized trial which was published in Urology Gold Journal in the February-March of 2024. So, the treatment of benign prostatic hyperplasia has gone subjected to multiple novel innovations and interventions. And most of these innovations are limited by high cost and limited availability. And even till today, the TURP remains as a standard of care, but still the blood loss requiring transfusion rates, although are given as 0.4 to 7%, it is less than the usual practice. So one novel intervention which we can perform is giving intravenous or local administration of epinephrine, which was being performed given in spinal anesthesia surgery such as knee replacements and other things. And a study was done in 2019 by Lira D et al. They have given intraprostatic epinephrine injection with which they have seen a reduction in the blood loss. So we had given low dose epinephrine infusion to these patients, and we wanted to see intraoperative blood loss and hypotension and postoperative bleeding in these patients. It's a single center study. Ethical criteria was performed, and patients with of 40 to 85 years of age with the BPH, based on AAU guidelines, who are eligible for TURP were selected. Patients who had metastatic disease, uncontrolled hypertension, and on coagulation were excluded. Block randomization of 4/6 were performed, and electrocution concealment was performed using Snow's technique. They received intravenous epinephrine 1 milligram and 50 ml NS at 0.05 micrograms per kg per minute. Group B received normal saline with similar infusion rate. So based on the blood loss during TURP, based on the literature, it was around 80 ml. With an anticipated reduction of around 10%, we have calculated the sample size of around 35 in each group, 1:1 allocation. So before starting the procedure in the irrigation band, 1 ml of heparin is put, and 5 ml of representative irrigation fluid was taken, and hemoglobin was assessed. So at admission and post-operative periods, these are the parameters which were assessed. And this is the consort with around 36 patients analyzed in each group. There's no loss of follow-up, with just 30 days of follow-up. This is the baseline characters, the duration of symptoms, and other things. Everything is comparable in both the groups, and the prostatic size were around 40 cc in both the groups. Larger glands were subjected to enucleation in this particular center. As we can see, there is a significant reduction in the AUO symptom score and an increase in the Qmax levels post-surgery. And as we can see, the output parameters here, there is a significant reduction in the intraoperative hypotension. See, all these patients are elderlies, and whenever we give a spinal anesthesia, most of these people will have a fall in the blood pressure. And whatever reduction in the blood pressure we can see, for which it requires an intravenous fluid bolus, or maybe any such sort of pharmacological intervention, is considered as clinically significant in this particular case. And those particular intervention levels have come down in the epinephrine group when compared to the control group. But as you can see, all the blood loss levels are little less in the epinephrine group, and there's no statistical significance as such. So the particular strength of this thing is it's a robust approval was there. Everybody has completed their study, and intervention is cheap and easily available, and all the residents have performed the surgery. So it's a real life scenario. Coming to the limitations, with single centered patients, and 5-alpha reductive inhibitors patients have taken for varied periods these things, and no stratification was performed based on the prostate size. So coming to the conclusion, it's a first of kind study. This intervention has never been performed before. Low dose epinephrine did not reduce intraoperative bleeding, but still it significantly reduced intraoperative, clinically significant intraoperative hypotension in these patients who are elderly. Thank you.
So the positive finding that you have is reduced incidence of hypotension.
Yeah, clinically significant intraoperative.
The one of the most important parameter that is described in prostate surgery is the resection efficiency or enucleation efficiency. That is the amount of tissue received resected per unit of time that you have not calculated. That is very important.
Sure.
No, efficiency or not. The two different parameters were shown. So efficiency is
So
the
that
ratio.
particular
Ratio has to
value
be-
was not calculated, sir, but
Yeah.
separately resection time and resected weights are comparable in both the groups.
How this study will change the practice, medical
So-
practice? What is your suggestion?
In case of hypertensive patients who are undergoing this particular TURP patients, if the patient is de novo diagnosed with hypertension and they have subject to they want to be subjected for spinal anesthesia, there will be a profound fall in the BP, which will limit the which is difficult for an anesthesia point of view. With for this particular intervention, maybe we can combat that fall in the blood pressure.
No, that is not your conclusion.
That's my
You-
secondary objective, sir.
No, but you have not concluded in your study. I'm asking, what is the practice implication of your study?
So
You said it is not significant. Ultimately, there is a
blood
hypo.
loss is not significant, sir. Blood loss is not significant, or the resection times are not significant. Surgeon is not facing any difficulty, but maybe anesthetist will be.
Okay, thank you.
comfortable.
Yeah, yes, sir.
Rohit, I worked with Professor Howard Lau. He used to give this epinephrine locally.
Yes.
Don't you think that intravenous systemic infusion can be associated with more side effects other than what you are taking is less hypotension as compared to local?
Yes, sir. So
Wider indication, less side effects.
So there was a study by Lira Day et al. In the year 2008. That was a randomized control trial. It actually showed a reduction in the blood loss levels and the resection time improval with the local injection. But the point was, while doing the resection, there is no blood loss. Post-operatively, the epinephrine, epinephrine effect will wear off, and the small bleeders might actually pop off, and that might cause secondary bleeding in the later periods. So that's what we wanted to combat it.
One final question. Apart from hypertension, did you encounter any topics or irregularity which you didn't mention?
No, sir. Actually, that was no, sir. We did not find any.
But that was something significant which we are giving epinephrine. The
Yes,
possibility is pretty high.
That's what we have thought.
And
sir,
then
but it's a
there was
very
no
low
mention
dose.
of the pre-op cardiac evaluation for giving that.
Yeah, exclusion criteria was mentioned.
This study was mainly related to the spinal anesthesia and its effect. It was not related to the prostate surgery. Any spinal anesthesia and giving IV epinephrine leads to increase in the rate of intraoperative hypotension.
Yes, but that's not a primary objective. That's one of the secondary objectives. Thank you.
Okay, we go for the next presentation now.
Yeah, thanks. The next is Lalit. He'll present a review article on urinary extracellular vesicle encapsulated mRNA signatures.
Good morning, respected chairpersons, faculties, and all the delegates. Today, I am presenting a systematic review on urinary extracellular vesicles, encapsulated microRNA signatures, a new paradigm for urinary bladder cancer diagnosis and classification. This was supported by Institute of Eminence BHU grant. Next slide. So, as per the standard literature, bladder cancer stands as prevalent malignancy of the urinary tract with high morbidity and mortality. At now, cystoscopy and histopathological biopsy are the current standard for the diagnosis. Cystoscopy has sensitivity of around 60 to 84% and specificity of around 43 to 98%. Another investigation is urine cytopathology, but the problem is the low sensitivity, especially for the low-grade tumors. So there is a clear need of the urinary biomarkers which can help in early diagnosis. Why urinary biomarkers? Because urine's proximity to the bladder cancer makes it ideal for the biomarkers. These extracellular vesicles are double-layered lipid biostructures which contain the molecules which helps in non-invasive detection of the bladder cancer. So we can see here, this is the bladder cancer epithelium. They discharge the urinary extracellular vesicles into the urine. So objectives of our systematic review was to evaluate the extracellular vesicles and their encapsulated microRNA as non-invasive biomarkers. Second objective was to compile the existing microRNA biomarkers, assessing their variability and discrepancy in the current research. Third was to assess the potential for early detection, risk stratification, and diagnosis of bladder cancers. We followed the PRISMA guidelines. So initially, we identified the 456 article, and after exclusion, finally, we included the 14 studies. We synchronized the PubMed search with the EndNote library and excluded the duplicate articles. We also manually excluded the articles like systematic reviews and which are not full text articles. So there were 4 steps. Like first, literature search was done with the mesh terminology and keywords and Boolean terminology like and. Then we included the articles which are of our interest and excluded reviews, systematic review, and duplicate articles. Then we extracted the data regarding the microRNA biomarkers, their expression, their isolation methods, and clinical significance. Then data analysis was done regarding variability and discrepancy in the existing search. We also prepared the binary heat map using the gene card. So we identified the 12 significant and repetitive microRNA. Like microRNA 21 has sensitivity of around 75% and specificity of around 95%. It helps in early detection of the bladder cancers. So other key findings were, we identified several microRNA. They help in regulation and assist in the early detection and tumor classification. When you use the panel of microRNA like combination 26 and 93, they help in improving the bladder cancer diagnosis. This was the binary heat map we generated with the help of gene cards of all the organ and tissue having microRNA. These microRNA also helps in prognostic significance like risk stratification of the tumor and correlates with grade, stage, and metastasis. There were challenges regarding to the inconsistency regarding to standardized protocols. This is from my interim analysis of microRNA studied by the RT-PCR analysis. In this, 99A showed the significant results regarding the bladder cancers. So they have clinical utility, and also future research should target cost-effective bladder cancer detection protocols. There were challenges also like variability in the techniques and isolation. Sample size was smaller in few studies and diverse studies. So to conclude, these are promising non-invasive biomarkers. There are challenges regarding to address these for effective use of microRNA in bladder cancers. There should be structured approach and standardized protocols for isolation and collection of the samples. Thank you.
How does it make a change in the practice?
Sir, at present, the biopsy like histopathology and urine cytology are current standard, but they have their limitations. Like biopsies they are invasive in nature, and especially for flat tumors, satellite tumors, and non-papillary tumors, they have limitations in the diagnosis. And urine cytologies have good specificity and sensitivity for high-grade tumors, like 90%.
What is the availability and cost?
The cost is not too much. For one sample, it takes around 2,000 rupees. But as they will advance in the future, the cost will gradually come down. They are non-invasive urinary biomarkers. Sample is very easy to collect. And I think later this will help in personalized treatment and medicines of bladder cancer.
Lalit, any conditions where you will have false positives coming with this?
Yes, there are. Yes, rightly pointed out. They may also have the false positive, like in benign inflammation. If there are benign condition with hematuria, So there are some complement factors are related that may show the false positive results. So that's why there are studies are available, but with various discrepancy in the results. So that is the problem at present. So there should be, because of the variation in the sample collection, various different techniques for isolation. Some use the RT-PCR, some use the microRNA, some use NGS. So there are no standardized protocol at present.
So we will be stuck where we are.
Yes, we are stuck where, but research is going on, and that's why the research in the medical.
Thank you.
Only PubMed database was used.
Right.
Only that's
Right.
not required. At least you require 3 to 4 databases to be included in a systematic review.
Right. Yeah, it's not must we have to include the 3 data reviews. We are doing 2 systematic review more, in which we have included the 3 data search engines, that is PubMed, Scopus, and Google Scholar. We have also submitted 1 meta-analysis.
And did you register this review with Prospero?
Yeah. Yes, we have registered for the Prospero. Right.
Thank you.
Thanks, Lalit. The next one is an original article by Dr. Yashasvi Singh. It's on intratumoral heterogeneity, chemoresistance, and lymph node landing zone prognosis in testicular tumors based on histopathological characteristics. Yashasvi, please.
Thank you, sir. Honorable Chair and respected dignitaries. Published this article last year in Journal of Surgical Oncology, primary impact factor 3.7. What we started with is we tried to group the non-seminomatous germ cell tumor into 4 categories. E stands for embryonal carcinoma, Y stands for yolk sac tumor, S for seminoma, and T for teratoma. So pure embryonal, then YCS, EYS, and EYST. So these were the 4 subgroups with which we started. The aim and objective was to correlate the intratumoral heterogeneity with the chemotherapy response and to check the overall survival. Since our goal was to assess the survival, it was a prospective open label study. These tall buildings, the blue one stands for the EYS, the red one stands for the EYST. So these 2 tumors, these 2 subclasses of tumors, they were the most, I would say, associated with complications, poor progression-free survival, and poor overall survival. In this, we can see the lymph node landing zone for both the groups, mostly intra-aortic cable on the right side and para-aortic on the left side. The response was evaluated both serologically and radiologically. Progression was seen in the EYST group, 5 patients, and in the EYS group, 2 patients. Pure embryonal and YCS group had 0 progressions. 15 patients had complete response serologically in terms of the tumor markers. The number of lymph node stations, both pre-chemotherapy and post-chemotherapy, the maximum response was in the pure embryonal group and the YCS group, and the least number of response was in the EYS and EYST group. All the histopathological characters, interstitial invasion, lymphovascular invasion, testicular hilar invasion, they all were assessed. Tumor bulk, retroperitoneal tumor bulk was assessed. The largest and the shortest diameter of the lymph node landing zone was assessed. Among all the different serum tumor markers in the study, serum AFP and LDH was significantly associated with the histology, more in the YCS and the YST group. A higher stage was associated with the EYS and the EYST group, defining our claim that the prognosis and the response to the tumor chemotherapy, the primary chemotherapy BEP, was not that good at all. The progression-free survival and the overall survival for the entire duration of the study, which was more than 18 months, was taken. The progression-free survival was maximal for the pure embryonal group and the YCS group, and it was on the lower side for the EYS and the EYST group. Similarly, the overall survival was also maximum for the YCS group and least for the EYS group. So, to conclude, for the practice changing scenario, we advocate that EYS and EYST combination had a poor upfront response to BP regime, whereas the pure embryonal and the YCS group had the maximum complete remission. Maximum number of lymph node stations were involved in the EYS and the EYST group, and there was a stark absence of S3 stage and poor risk stratification for pure embryonal and YCS group, thus proclaiming that it has a good response. In our series, the 2-year progression-free survival and overall survival was nearly 80% and 50%. Salvage chemotherapy had a good response in the EYS clinical stage 2 and 3 groups. The response rate was 41%. So final recommendation, we since it's a single center study, but upfront RPLND for the EYST group clinical stage 2 and 3, based on the lackluster performance of the primary upfront BP chemotherapy.
Thank you. Yashasvi Singh, you are the first author of this article, right?
Sir.
Why you have to read so much? Your slides are also crowded, and you don't know you have to read while presentation. What is the reason?
Sir, few data regarding, I wanted to present specifically of the progression-free survival and the overall survival and the number of cases. So I had to be deliberate and precise in presenting. That was the point, sir.
Okay. Anybody? Any question? Yes.
Keval, Mike.
So, Dr. Yashasvi, according to your study, like traditional teaching goes that all non-seminomatous tumors, if they are operated, they should be subjected to RPLND, right? So now you are trying to postulate that even in non-seminomatous group, there is a group exists which has a very good response to chemotherapy, and they should be subjected to chemotherapy like seminoma. Like in seminoma, everyone, they have very good response. And so we are trying to reduce that subset from our RPL impact. This is what you are trying to say?
We are trying to communicate that in that subset, when the entire group is comprising of pure embryonal or minus the teratoma, so the response to chemotherapy is better. And if there is a grouping of EYST, all the 4 subclassification, then upfront VIP chemotherapy or RPLND would be a better thing.
And how much of the patients in your study had complete remission amongst EYST group?
EYST group, 5 had progression and 5 had complete remission.
So it's 50%.
50%, yes.
Thank you.
Thanks, Yashasvi. The next presenter has not been able to attend because of unavoidable circumstances. We're trying to connect her by Zoom. We hope the IT and logistics work.
Madhuri is present. Santosh.
Hi, Santosh. Can everybody hear me? Dr. Santosh?
Madhuri, can you hear us? Could you please share the screen?
Yes, I can hear you. Can you hear me?
Probably you're muted.
I'm not muted. Santosh, can you hear me?
और उसने 20 प्रेजेंटेशन में से 7 सिलेक्ट किया है, तो मेरे को तो 15 दिन से ये संतोष पीछे।
Yeah, speak up now.
आर्टिकल पढ़ लो सर।
Unmute. Hello, Santosh, can you hear me?
Okay, until we sort out the audio visual, we'll just move on to the next one. Next is Dr. Sabartha Kumar Pratihar from Rajiv Gandhi, Delhi. He'll be presenting on prostate cancer detection using MRI and transrectal fusion biopsy. Dr. Sabartha, please.
Good afternoon, respected chairperson, my senior teachers and friends. So our article regarding prostate cancer detection using MRI transfusion biopsy, which got published in Indian Journal of Urology, October 2023. So it has some important key insights which I believe can be practice changing. So traditionally systematic 12-core prostate biopsy has been done, which has potential to miss about 80% of the cancers. Particularly the anterior zone lesions. And when I was searching the data, there is huge scarcity of Indian data over the fusion biopsy. So what we did is a single center study I collected data from 2016, and all the patients who had a doubtful DRE or elevated PSA underwent MP-MRI, and fusion biopsy was done in patients with Pirates 3 onwards. So we do it transrectally under periprostatic block in left lateral position. First, radiologists mark the prostate and the lesion by Profuse software. Then we do the targeted biopsy from the suspicious lesions. Next, from the same patient, systematic 12-core biopsy is being done. We consider for our study purpose Gleason 3 plus 3/6 as clinically insignificant and higher Gleasons as clinically significant prostate cancers. So coming to the key results, 450 patients were total. Among 120 patients were excluded because they had no proper MRI data. Among the 330 patients, cancer positive was found in 187 patients only. So with increasing the Pirate score, you can see there is increased detection of the overall carcinoma prostate and also the significant prostate cancer, which is marked by maroon bar. And you can see that there is huge amount of prostatitis among all the Pirates group. We often say that the higher PSA in Indian patients because of prostatitis. No paper has till now reported this, but we found significant prostatitis among our patients. So when we are substratifying our patients, any Pirates group or not, because PSA European guidelines already saying that in Pirates 3 less than PSA density 0.15 you can avoid biopsy. So we substratified our data, and we can see with Pirates 3 with PSA density of less than 0.15, only whereas if we avoid biopsy, 47 patients would have been not undergone biopsy, and missing only 6 cancer positive patients, out of which only 1 was clinically significant prostate cancer. That was only on the targeted biopsy alone. We subjected this data to receptor operative curve analysis to identify a new PSA density cutoff, and we could found a PSA density cutoff of 0.22 among our Indian patients. If we avoid biopsy in Pirates 3 below with PSA density less than 0.22, then we will be missing only 11 cancer positive patients. Among them, only 3 were clinically significant. We compared our systematic biopsy versus the targeted biopsy, and the clinically significant prostate cancer was similar between the two groups. So here the question is, can we avoid one biopsy like we can avoid systematic biopsy or targeted biopsy? The question is a big no, because in this table you can see that systematic biopsy alone detected around 17 patients and target biopsy alone detected 19 patients with prostate cancer. If we avoid systematic biopsy, it would miss only 8 clinically significant prostate cancer, but adding the targeted biopsy detected around 6.67% more clinically significant prostate cancer, and the difference is, the p-value of this difference is huge, 0.009. So we tried to identify if there are any subgroups whether we can avoid the systematic biopsy or target biopsy. So we divided the subgroups like in terms of PSA density, prostate volume, index lesion diameter, Pirates category, and we could find no subgroups where we can avoid the systematic biopsy or target biopsy. So based on the results of our study, there are some key practice changing updates, like you can very well avoid biopsy at all in Pirates 3 patients with PSA density of 0.15. In our data, we have found a new PSA density cutoff of 0.22 in Pirates 3 patients we are now doing more study with this type of PSA density cutoff, seeing our results whether this is a viable cutoff or not. And as of now, in Indian patients, we could not avoid either systematic biopsy or target biopsy. We have to do both the biopsies. So I have made the audience aware of this thing. Next thing is the acceptance. We could accept this. Thank you.
Very good.
Yeah.
This is a retrospective study.
Yes, sir.
So you had in a 1915, you had a magnetic MRI fusion.
So
and-
we had
yeah.
the fusion machine installed in our hospital in 2015, and we have been carrying out regularly 2015. But I collected this data since 2016.
No, but it requires a special software.
Yes.
And which is very expensive.
Our is the Artemis system, and the software, the Profuse software which radiologists use, which is a trial version software. The software they run, it is a free. They have some crack
Okay.
that.
So you don't own it right now in your hospital?
Yes,
because-
we in our hospital we own it.
Okay.
So, Partha, your article, the title was prostate cancer detection using fusion.
Yes, sir.
But your conclusions are based on PSA density. So there's a mismatch in what you are stating and what your conclusions are.
No, sir. Actually, you are right. I have not presented all the data. The practice changing data I have just presented here because the session is like that only. I have more data in the discussion which I can present, but due to lack of time, I have just presented the practice changing data only.
Say I have a patient whose PSA is between 4 to 10.
Yes, sir.
And PSA density is less than 0.22. I do not have access to MRI. Should I do a biopsy or not do a biopsy?
You have no access to MRI.
No access to MRI.
Sir,
that's India.
Yes, sir.
Yeah.
Sir, as of now, if you have PSA more than 4 and doubtful DRE, you have to do the biopsy. And if you are suspecting any lesion in any imaging, you have to do the systematic biopsy. Plus, you have to do some form of cognitive fusion. Like if you have felt any hard nodule, then you have to take extra
But
course
I will
from
just
that.
add to it. Obviously, if there is a clinical evidence, you will anyway go it. I think his question was in a where the DRE or there is no other
So
factor.
anyhow,
just DSP.
anyhow, if a person having a PSA more than 4, we are doing systematic biopsy based on suspicion. So you cannot avoid biopsy as of now.
One thing which you mentioned in your introductory statement, I'm just curious whether you have analyzed that or not, that 85% of the biopsies of a malignancy which are located in anterior zone and anterior that are missed on so have you evaluated that in your study or just
yes
so
yes.
I'm interested in knowing the results of that.
So I have shown that the our targeted biopsy exclusively detected 19 patients which were not detected in systematic biopsy. Yes. So target biopsy detected more anterior lesions. Among them, around I think 10 patients have anterior lesions which are detected only by target biopsy among 19 patients. And in the systematic biopsy, it was only 2 out of 17 patients. Yes.
Thank you.
Thank you, sir.
Thanks, Abartha. We're just going to try once more if we can work with the audio visual.
Hi, Dr. Santosh, can you hear me and see me?
Yeah, please go ahead.
Yeah, can you all ask the audiovisual team to allow me to share?
Yes, please. Yeah, please share your screen. And you're muted right now.
Unmute. Can you hear me?
Yes. Yes,
I
loud
can-
and clear.
Yes, please. Go
Okay.
ahead.
Good afternoon, everybody, especially to the chair people of this particular session, the delegates who made time to be here, and the organizing team for recognizing a paper. My name is Sadhanala Madhuri. I'm an associate professor at CMC, and this is a paper titled "Is Low Dose Tadalafil Better Than Tamsulosin? A randomized controlled trial in shockwave lithotripsy and solitary upper tract stones." This was published in BGUI last year. So the study was done to ascertain whether low-dose tadalafil of 5 mg is more efficient than tamsulosin to facilitate stone expulsion in those patients receiving or planned for lithotripsy in solitary upper tract stones. So tamsulosin, like we all know, is the most popular medical expulsive therapy, but because of its mechanism of action, it is known to work mostly on the distal ureter. Tadalafil has been showing up as a contender, though data is still clinically equipoised, but it's a phosphodiesterase inhibitor, and because of its mechanism of action, the biological plausibility that we hypothesized was that it works on the entire length of the ureter as opposed to just the distal end. So methodology was this. This was a triple-blinded superiority design study that was conducted over 3 years to acquire a sample size of 250 patients. It was a stratified block randomization with 1:1 allocation, and these were the stratifications according to size: small, medium, and large. And we randomized them to 2 groups, those to receive tadalafil 5 mg and tamsulosin 0.4 mg. The drugs were given for 30 days or till the stone was cleared, whichever was earlier. These were our exclusion criteria. Patients who had radiolucent stones or recent urological interventions or past lithotripsies, patients with CKD or untreated UTIs, or if they were on medications that had similar effects as the drugs that were being studied or contraindicated to the study drugs, and children. So this is a consort diagram. We had 853 patients that were assessed for eligibility, of which 603 people were excluded because they declined to participate or did not meet criteria. 125 patients were allocated to each arm. 1 patient was lost to follow-up in the tamsulosin group and 5 in the tadalafil group, and 5 each discontinued treatment due to various reasons in both groups. The large stone category size patients, we accrued only 3 in each arm towards the end, and because the number was too small, we did not include them in the analysis towards the end. This is our table with baseline characteristics looking at the basic demographic details, that is age, size, location, comorbidities, and number of sessions, and they were equal as one would expect in a well-randomized study. So this is a primary outcome was calculus expulsion rate. And over here, we found that it was 81% and 80% in the tamsulosin and tadalafil group. The calculus expulsion rate is the proportion of patients who had expelled stones by the end of 30 days. And the secondary outcome that we looked at, amongst others, was number of days to expulsions, and that was also pretty equal, 13 days in both. When it comes to adverse events, the patients in the tadalafil arm did not tolerate the drug as much as tamsulosin, and the most common ones were headache, myalgia, and gastrointestinal symptoms. So, like I said earlier, tadalafil is a contender, but it is not particularly superior, and the literature is not really hard on that. But this was a study based on which we calculated our sample size. And this particular group looked at 207 patients, and they found that the expulsion in the tamsulosin was 68% as opposed to 84% in the tadalafil group, but that was not our observation. Their observation was a lot more significant. And they also found significance in the number of days to expulsion, with 2 days earlier in the tadalafil group. Of course, this group had a slightly different cohort. They did not include, this was not used as adjunct to lithotripsy. Also, the stones were within 10 mm in the distal ureter, and they also used a higher dose. So to conclude from this study, we can say that adjunct low-dose tadalafil does not ensure superior calculus-free rates when compared to the current standard, which is tamsulosin, when used along with lithotripsy. Also, even if tadalafil is used, it apparently may lead to non-adherence due to intolerance to symptoms. Coming to limitations, some may argue that placebo might have been considered, but tamsulosin as an adjunct to SWL has robust literature to support it, so that was why we did not include it. Also, there is some literature to suggest that the effect of tadalafil 5 mg meets 10 to 20 mg effects only at 12 weeks, while our follow-up was only for a month. And finally, we also like to point out that Tadalafil, even at low doses, is more expensive than tamsulosin, so cost analysis may have added value to the study. Thank you.
Madhuri,
Yes,
as
sir.
for LUTS, did you consider combining the two drugs? That could have been a third arm that could have been used, where you could use both the drugs together.
Yes, so that's an
That
interesting
is a
option. That is something that we can do. That is an interesting follow-up research question. We could probably design a study for this, but we did not plan this at the beginning.
Can you, Madhuri, tell us from after doing study that why perhaps Tadalafil did not work? Are we having enough experimental evidence? We have only one publication in which it is written that in vitro ureter has an effect by PDE5 inhibitor.
Yes, sir.
Whatever studies are there, they are more for the prostate and bladder.
Yes, sir.
Are we having enough evidence for the ureter as far as
Yes, sir. Actually, if you go through the literature, sir, there are actually in vitro and in vivo studies. But like I said earlier, it is divided. Some studies have showed that there is clear superiority, while some studies have showed that there isn't. But actually, there is literature to support that this is there. The study that I projected earlier was the only randomized, well-conducted randomized control trials. That was why I compared our reports to them. The other ones were not as great. After doing the study, what I can say is I'm not completely convinced that it is superior to tamsulosin. Or I'm actually beginning to question if even tamsulosin has a role in medical expulsive therapy, even with lithotripsy.
Madhuri.
Yes, sir.
For my ignorance, can you please explain me what is triple blind study?
So triple blinded study is the participants don't know, I do not know, and the person who is the primary investigator does not know, and the person who's analyzing this data also does not know.
The person who is analyzing the data would know.
The person who is giving the treatment, so the person, like when we are giving it, the patients do not know, the person who's treating does not know, and I also do not know. I am working with the statistician. I mean, I'm not the one who is particularly analyzing the data. The statistician is also a part of the study group.
Okay. Okay. So you mean to say the bias comes during analysis also? Yes, sir. How come? No, this is a news.
Before we finish, Madhuri, I have a question.
Yes,
Do
sir.
you take 24 mm stone for lithotripsy in CMC Vellore?
Well, that's a very, very good question. So I'm glad you brought it up. The study was started in 2017. At that time, there were still some people who liked to give lithotripsy, but like I said, even after that time, during that time, we realized that minimally endoscopic patients started to go on to have operative intervention. And that was why we could not continue including them in the study. We just did not have enough number of patients. So as a study design, we started it, and then we realized that it was not something that we could stick with.
Okay, thank you very much.
Thanks, Madhuri.
Thank you so much.
The last presentation, Dr. Nitesh Kumar from Ford Hospital and Research Center, Patna. He'll be presenting on monopolar transurethral enucleation of prostate, feasibility of modified Nesbitt's enucleation with apical release. Dr. Nitesh, please.
Good afternoon, everyone. Thank you, Youth Conclave, for giving me this opportunity. This was published in Journal of Clinical Medicine with impact factor of 3.9. So we all know that URP is still the gold standard, and in this era, also with laser enucleation and mesh, URP holds the highest ratio of prosthetic surgeries which is being done. But still there are concerns regarding the complications, especially the TUR syndrome. But we know the incidence is quite low. But with the modern day optics and the electrosurgical devices, we can achieve the morbidity of monopolar TURP has reduced and we have a comparable results. The morbidity is mostly due to the incomplete removal of adenoma, multiple bleeders, absorption of fluid, and poor apical resection. And the transurethral enucleation can overcome these drawbacks. So we have holmium, thulium, and bipolar energy in the era of enucleation. But in India, not every urologist and not every center have these advanced equipments. With this first description was made by Hiroka, and because we perform POLEP at our primary center, we get the mantra of that enucleation is enucleation is enucleation without regardless of the energy source. And this we developed that simultaneous enucleation and resection with most easily available energy source, that is a monopolar. So this, in our technique, we preserve the sphincter better. We have less blood loss, very good relief of obstruction without the need of postoperative traction. And our primary objective was to evaluate the outcomes of this new technique. With this, a prospective observational study was conducted in our hospital for around 18 to 20 months duration, and the patients who were subjected to TURP according to guidelines were included. These patients were excluded from our study, and standard protocol and procedure with the instruments were used. Coming to the technique proper, we start our resection at 1 o'clock, and then we start dropping the prosthetic log. First we do the left one till the 5 o'clock position, and then we go retrograde from the paraapical tissue, and we start enucleating it distally up to the around 1 to 2 centimeter, mostly up to the mid gland where the adenoma starts going up. After that, we go to the another lobe, and we start resecting and dropping the right lobe from 11 o'clock position, and then we drop it to the 7 o'clock position. Again, we go retrograde on the right apical region, and then we enucleate the prostate, and we can see that whole lobe is enucleated and falls onto the floor. After this, we go to the bladder neck, and we resect the bladder neck tissue and the median lobe. So after this, all these steps, we have all the prosthetic tissue which is lying in front of us on the floor, and it's devascularized from all the sides. The 6 o'clock tissue strip is resected at last, and thus at the end of resection, we have a good apical preservation of mucosa and over the sphincter, and a very good fossa which is looking like this. For this, our results were, we have resected around 240 patients, mean prosthetic volume was 55.3, and we had around 28 patients which were more than 100 gram of prostate, and those patients mean prosthetic volume was 132.65 grams. The resection efficiency which we could achieve in whole study was 1.36, a surprising result that in prostates more than 100 gram, the resection efficiency increased to 1.80. Very few catheters needed attention, and duration of catheter was less than 48 hours in most of the study. There was a good reduction of the prostatic volume at the end of 1 year, which was 12.8. The most of common complications were 1 and 2, only 15%, and SUI was 0 at day 90, and we could achieve a very good reduction in IPSS, good improvement in QMAX and PVR, which was sustained at 6 months and 1 year follow-up. So there is an unmet need for cost-effective enucleation in the world of transition, and we have shifted from a good open enucleation to the incomplete resection. Many people have studied this, but we have achieved a greater resection efficiency and better improvement in QMAX and reduction in IPSS. So why it will change your practice? Because we preserve a strip of mucosa at 12 o'clock, which helps in early fertilization, reducing the bladder neck contraction and decreasing the SUI. We enucleate only up to the midgland to the prostate on the floor, and antegrade resection of the bladder neck tissue is done. It reduces the learning curve, no capsular perforation, no subtriagonalization, no ureteric injuries, and it avoids the two most difficult areas of enucleation, that is the apex, the bladder neck, and the 12 o'clock, not the apex, bladder neck and 12 o'clock. All the adenoma is brought to the center. It helps in a very rapid resection. There's no rotation of the hands during the bulk resection, and it's more effective in larger glands. The adenoma is attached with a 6 o'clock strip, which keeps it stable, and no risk of adenoma falling into the bladder. So it's a rapid, relatively bloodless resection of the adenoma. Thank you.
Nitesh, what you have done is the first part is a classical Nesbit's resection, and in Nesbit's also you go half the way in resecting it. So when you are enucleating it from the at 5 and 7 o'clock, how do you ensure that the tissue doesn't wobble around even while resecting or doesn't fall off? How, what is the thickness of tissue that you would consider as bare, and how do you make sure that inadvertently either the tissue will start wobbling when you're resecting or will fall? So how do you ensure that?
Tissue wobbling into the blood is problematic. Earlier I was not doing. Earlier I was connecting the the one side incision to the other side, and then I found that the tissue was wobbling. But now, after 5 to 10 cases, I learned that the 6 o'clock strip, which is left intact, that keeps the tissue intact. And when we usually resect retrograde, and it doesn't wobble at that time, and because the tissue is fixed at the midline, usually come from the bladder base or from the lateral to medial, it doesn't wobble. Even if it wobble, it stays there on.
This follow-up question on this is the idea of doing a Nesbitt's technique is you are taking care of the Alcock vessels at 5 and 7 o'clock, which you have already taken care of when you are resecting it. So by a retrograde what you call an enucleation at that step, how are you going to, you could start resecting from the bladder neck right there. So how is that step which you have incorporated is helping you in otherwise doing a standard Nesbitt's?
It's helping because I get a very clear margin of the apex of the prostate. I preserve the mucosa earlier, and then the apical tissue, which is many cases I have seen redo cases, which is left intact, and there's a very slow resection at the apex. Many times we can overshoot, and we are sometimes a finger in the prostate technique is also described to resect the adenoma at the apex nicely. But we can achieve a very good resection, and with this technique, we have a level of tissue because the prostate is a boat shape. When we resect from the bladder neck to the apex, we cannot. Most of the times, we leave the tissue in the midway. But when we have planes at the bladder neck and plane at the apex, we can make out the tissue is remaining in between, and we can dissect it very nicely. And we have achieved a very good reduction in the prostate residual volumes with this.
Thank you.
Thank you.
Thank you very much. Can I please have a big round of applause to all the participants and the chairpersons? They've spent a lot of valuable time to print out the papers, go through all the papers. Thank you very much for your enthusiastic participation, and Abhishek and the team for the opportunity.
Long time back when we were in a medical education, to write down a paper, to get the paper, subnis will say that first 5 to 10 years, no residents were interested to get a paper done. But the amount of the research and now the papers involved by the young generation is phenomenal. Whether you get prize or not, I think I congratulate everybody. And Dr. Santosh has selected all the good papers out of all big junk. And he kept on reminding that you must read all papers. Just don't come and see the slides. So main thing is that everybody has done very well, and some of the subjects are really changing the practice. He wanted to say something.
Yeah, if you're reading all the papers for the criteria, I think you need to be congratulated. You have read everything. And he was checking it. Yeah, he was checking all the papers in between, whether what is being presented, what is being shown is there in printed version. So Shailesh bhai needs a round of applause from all of us.
Good afternoon, everybody. May I call upon stage the next chairpersons, Keshamurthy sir, Anil Elan sir, Vijay Bora sir, for the session Dilemmas in BPH Decision Making, Getting Around the Corner. It's a case-based discussion.
So we move on to this next session, which is dilemmas in BPH decision making. Is Tejas still there? He's not there. So we'll move on to the next presentation on BPH with Parkinsonism by Devil. Over to you.
So very good afternoon, Chairperson, and to everyone, my seniors, colleagues, and everyone over here. I thank you for this opportunity for me to present this topic. So today I'll be presenting a topic which produces a lot of dilemmas when a person deals with a patient with BPH who has always Parkinsonism associated. So let's start with the case scenario. It's a 64-year-old male who basically has storage symptoms, who presents with urgency, frequency, and poor flow. He's a known case of Parkinson's, and he has been having progressive rigidity over the last 5 years. His USG suggests of an 85 grams prostate with an obstructed flow. So when we talk about LUTS in patients of Parkinson, it is basically about storage symptoms that most of the patients present with. So its incidence ranges from 25 to 64% anytime. And main symptoms basically are nocturia, and others are basically urgency. So what is all important is, do the LUTS progress in patients with Parkinsonism? Like as Parkinsonism advances, do the LUTS also increase in severity? So then the answer to that is no. But indirectly, there is definitely an increase, perception of increase in LUTS because of the impaired mobility, the tremors that the patient develops, there is gait imbalances that the patient develops. So these are all indirectly that the patient experiences the increase in the LUTS that he experiences. So as a clinician, what do we need from the history? Why are urologists scared and comes to offer definitive treatment to the patients with Parkinsonism? Is basically Parkinsonism is a broad umbrella which encompasses multiple diseases. Parkinson disease is one of it, and also multiple systemic atrophy is at par with it. It is very difficult to differentiate among the two, but it is very important to do so because the management changes drastically when we deal with both the diseases per se. So when we talk about MSA or Parkinsonism, the symptoms that are over Parkinsonism favor that Parkinsonism is basically urinary symptoms that develop before Parkinsonism, erectile functions, urinary incontinence, high PVR, and open bladder neck. So why does all this happen in patients with MSA? Because of the involvement of the on-off nucleus, which controls the external sphincter, and hence the patients do develop severe DSDs rather than those who do not have MSA. So to differentiate, definitely the neurologist is the one who differentiates it clinically. But from a urologist point of view, how do we differentiate? Then what the most important investigation for us is basically a urodynamic study that we have to offer. So what do we see in the classical symptoms is basically the storage and voiding. The most common storage symptoms that the patient experiences is overactivity, and who has a functional capacity of less than 200 ml is what we tend to see most commonly. And voiding phase, we do see dactylular underactivity. And the most dilemmatous question that we experience is there something as a DSD that is present in the patients with Parkinson's? So when we come to it, there is spontaneous swearing in patients with Parkinsonism. So there is no true detrusor sphincter dyssynergia, but definitely there is something entity called as pseudo dyssynergia that exists. Pseudo dyssynergia also called as sphincteric dyskinesia that the patient develops. The sphincteric dyskinesia is basically the lack of coordination between the muscles. So this can be judged either by urodynamic study or clinically. How do we judge is basically ask the patient to contract his sphincter during a rectal examination. So the slowness of the sphincter that closes around your grips your finger is basically somewhat, but that is still a little subjective. So it is also important to differentiate Parkinson's with a patient with a benign prostatic hyperplasia. So the most important thing that we like to see is basically the post-word residue in patients with Parkinsonism is basically generally insignificant as compared to the patients who have benign prostatic hyperplasia. Second, so when it comes to treatment, does Parkinsonism, dopaminergic treatment for Parkinsonism, does it help improve the LUTS of the patient? So the answer to it is yes as well as no. In an acute setting, definitely there is worsening of the symptoms that patient do experience when they started on levodopa or carbidopa. That is because of the involvement of the D1 receptors which act, that is basically on the spinal level. So there is an increase in overactivity that we see during initial treatment. But as time advances, as the chronicity of the treatment increases, there is also involvement of the D2, which is basically in the brain and in the basal ganglia that causes relaxation of the bladder, and over a period of time the symptoms do improve. As we see, the most common presenting feature is basically an overactivity. So, is there any role of antimuscarinics? So, what do we prefer as an antimuscarinic? So, basically, do we prefer a quaternary compound or a tertiary compound? Those do not cause the cross the blood-brain barriers are the one who is generally accepted by the EUA guidelines and help. So, trospium as a dose of 20 milligrams BD is something that is recommended by the EAU. With regards to mirabegron, although it has been demarcated to be safe in patients with CV strokes or CV history of cerebrovascular incidents and Parkinsonism, there is a possibility of increase in dyskinesia that experience. Now, when we come to voiding symptoms, is there any role of alpha blockers? So, alpha blockers, it has been shown in a number of studies that tamsulosin actually has a higher potential of exacerbating the Parkinsonism features in almost 1.5% of the population as compared to the zosin groups of drugs. So those are terazosin, alfuzosin, which do not show that exacerbation as compared to the tamsulosin. So now coming to the question that everyone is generally in the dilemma is, do we need to offer TURP to these patients or not? So the answer to it is yes. So there have been studies who have safely told that PRP definitely can be administered. However, it is very important to differentiate between a Parkinsonism disease patient and a patient with multiple systemic atrophy, because the patient with an MSA is not likely to improve with a TURP that you offer. So an intractable overactive bladder in cases of Parkinsonism, do we offer him Botox? The answer to it is yes, but it is generally after trying all the possible antimuscarinics that we have given, and if it does not respond to it, then definitely 100 unit of Botox does help. And currently the modality under study is basically neuromodulation that helps. The posterior tibial nerve stimulation over a peak of 12 to 16 weeks have shown to have beneficial result in terms of curbing the overactivity in such patients. What do we take home from this is basically it is very important to differentiate the LUTS that due to Parkinsonism or it is due to the multiple systemic atrophy. And urodynamic is the key that helps us in as a urologist, as a clinician, to judge between the two. Prostate surgery, we should not be afraid to offer to this patient if our diagnosis with regards to Parkinsonism is true. And definitely antimuscarinics, mirabegron, as well as Botox does have its good role in controlling the overactivity and storage symptoms. And thank you so much.
Thank you, Devil. That was good presentation. It's key to differentiate between MSA and Parkinsonism before we offer surgical intervention. So what I do is I send it to a neurologist to give us an opinion to rule out MSA, because it's very difficult for us to differentiate between Parkinsonism and MS.
The key points he has already mentioned, but one of the key is the simplest thing which as a neurologist we could help, because MSA is something that we need to keep away from, is that in MSA the duration of LUTS is probably in Parkinson there will be LUTS and Parkinson would be around for a long time. In MSA is the other way around. The patient may actually present with LUTS rather than with a neurological problem. The other thing is obviously incontinence is much more there. But you mentioned urodynamics, but I think the key is a video urodynamics here, because you need to see a persistent open bladder neck and a sphincteric obstruction. And a spot film on an MCU might be misleading because of bradykinesia, which you mentioned. So spot film and MCU might not help us. So video dynamics is what will actually help us differentiate MSA from Parkinsonism. But in case there is Parkinsonism, the patient is obstructed and the urodynamics shows it, then I think going out for surgery is a very valid option. Yes, of course. Of course. I am talking of surgery would obviously when the medical therapy doesn't do well, and in Parkinson's, it's antimuscarinics which will work. But Deval did say that you would give him medical therapy. Yes.
If it is surgically indicated, yes.
Yes.
If there is a surgical indication,
Sir,
can
it
do
is a
it.
surgical
And
indication.
beyond trospium, you can move to darafenacin or even solifenacin. But yes, the drug of choice would be trospium there. Thank you, Deval.
Yeah, we move on to the next paper, asymptomatic enlarged prostate, MOSIN.
Morning, respected chairpersons. Good morning, dear delegates. Myself, Dr. Mohsen. I'm from as assistant professor in Guntur Medical College. So the topic is given to me is asymptomatic enlarged prostate. Most of us have encountered these in our OPDs regularly. So I'm discussing a few of the case scenarios which I have encountered 3 years ago when I was in corporate as a consultant. So here's a subject, a gentleman, Mr. A, who is a 45-year-old male. He's a senior executive in oil company. He, as per his company policy, he underwent an annual health checkup. In that, 60-gram prostate was an ultrasound, and he was referred by a general practitioner to me. And he was on taking history, was asymptomatic with IPSS was 0. On clinical examination on DRE, it's a grade 2 and benign field. When I did a Euroflow, it's a good flow with the 26, Qmax is 26 and average flow is 16. With he's voiding within less than a minute and 420 ml is emptying. And residual is also at 20 ml, is less to the complete, and CU and RFT are normal. Coming to my second gentleman, who is a 58-year-old, he's a hotel manager. He presented to a general surgeon with a mild upper abdominal pain. So on ultrasound, there was a cholelithiasis, but incidentally a prostate of 80 grams, and the general surgeon referred to me. On taking history, he had occasional nocturia, not a regular one, two times occasionally, and his IPSS was like 3. And digital rectal examination is again grade 2 prostate with a benign field. His Euroflow is also is good with minimal residual, and CU and RFT are normal. And the third gentleman, who is a general physician, he is a 64-year-old gentleman, and he wants to travel. In front of his foreign travel, he did just a master health checkup. In that, the ultrasound was the 110 cc was his ultrasound prostate. And he was referred to me, and again he has absolutely no symptoms. Occasionally he has some nocturia, and again his IPSS is 2. His grading of the prostate is grade 2 benign field, and his Euroflow is also almost good with the 16 is Qmax and average flow is 12, but residual is less. So I faced this head scratching scenario whether to treat this gentleman or not. And most of the, as I said, most of the incidental detections, like during health checkups, master health checkups, and for any other problems in ultrasound detection, and in some cross-sectional imaging like CT and MRI, these glands are getting detected. No, going in as we detect mostly in ultrasound, going to a radiological classification, a normal prostate is 15 to 20 grams. Which is a small prostate is considered to be 20 to 40 grams, and 40 to 80 is a medium-sized prostate gland, and more than 80 grams is considered to be a large prostate gland as per this classification. And most of the prostates might be symptomatic, and sometimes they might be asymptomatic also. That's the idea of this talk. And most of the patients who come to us OPD, maybe they are having a big prostate, but they are not aware of the symptoms as well. They present bit late. So as we all aware, we evaluate, like we do a self-assessment by giving IPSS chart, which is the native language as well in English, and we do a DRE, a complete urine examination, renal function test, post PVR check, and uroflowmetry, and serum PSA is after only shared decision making with the patient. As we all aware, let's classify in 3 types: storage, voiding, and post-micturition symptoms. And this IPSS symptom score is very essential in initial evaluation of such individuals, as well as in a follow-up after treatment or without treatment on follow-up. So men with large prostates will have, of course, we have a present with LUTS, and they sometimes present with acute or chronic retention. This veteran affairs cohort study showed men with more than 30 grams are prone to be AUR, 3 times more prone to AUR. And this Olmsted County study showed that men with prostate more than 50 cc are 3.5 times more prone for a moderate to severe LUTS. So this historic paper we all aware, it's published in 1993 in Journal of Urology. So the study was done by Barry and colleagues. So this paper shows the relationship of prostatic symptoms with anatomical and physiological considerations. And in this, they showed little correlation between prostate volume and severity of LUTS, because the majority of the gland, which is around the periurethral region, that chokes, not the whole size of the prostate. And the similar thing was explained in this paper as well. This is also a historic paper that is a natural history of the prostate, as done by German and colleagues, which is published in Journal of Urology in 1995. In this also, there was a little correlation between LUTS and the size of the prostate. And this Olmsted County study shows that there are more than 3 times more men are more risk if prostate size is more than 50 grams. This is one of the thing. And based on this basis, we try to treat and shrink the prostate. If he is symptomatic, based on this basis, more than 50 grams, we try to shrink the prostate and to reduce the LUTS and improve the IPSS score. And this is another significant paper published in New England Journal of Medicine in 1992. This is a famous finasteride study done by Gormley. It's by 895 subjects. It's a randomized controlled trial comparing the finasteride 1 mg, 5 mg, and with the placebo. So in this study, at the end of the study, the prostate gland is 19% reduction in the 5 mg and 18% in 1 mg and placebo. It is 3%. That means a significant reduction, like almost 5 mg, 1 mg is the same reduction in the volume is 19-18%. But finasteride 5 mg is has improvement in LUTS over a period of 1 year compared to 1 mg. This is another paper in New England Journal of Medicine is published in 1998. This is a famous study that there is a long-term efficacy safety study that is called Proscar study. This here 3,000 subjects has been tested. It is also a randomized control study, finasteride or placebo for a period of 1 year. In this, while using the finasteride for there is an improvement in the flow rate as well as there is a finasteride reduce the risk of needing for surgery and development of AUR for this percentage. And going for this EAU guide, this flow chart, the algorithm management of LUTS, the subject who is here with no symptoms at all straight away goes to watchful waiting category. If at all, if he's having a large prostate, there he fits into a, because he's not having any symptoms, he fits into a education and lifestyle modifications. Coming to EAU guidelines, what EAU guidelines says is, so offer men with mild or moderate symptoms which are minimally bothered with only the watchful waiting. That is a strong recommendation. And similarly, LUTS, men with minimal LUTS, lifestyle modification should be advised. If you want to start, even if you want to start a medical management or prior to it, you need to give a lifestyle modification. Is a strong recommendation. And alpha blockers are reserved for men with moderate to severe LUTS, which are bothersome. And if gland size is more than 40 ml, then 5-alpha reductase can be combined. And we need to counsel the patients about the slow onset of 5-alpha reductase inhibitor, which is also a strong recommendation. Coming to American Urology guidelines, here it's almost the same. So the clinician, based on the for minimal non-bothersome LUTS, lifestyle modification, and for moderate to severe LUTS, alpha blocker should be started. And now what can be done in these subjects, what I have discussed. So main thing is education. We need to really educate them. So what's the prostate, how it grows along with the age. It's just like hair will gray or bones will weak as we grow. Similarly, in that fashion, we need to educate them. We need to reassure them really that it doesn't cause anything to you. We need to have a proper follow-up. And we need to, if they are having a little bit LUTS, or we can advise the proper lifestyle modifications, bladder training, everything. And we need to make him understand that he need to come for a periodic monitoring, periodic checkup regularly. So how I follow is like after 6 months or 1 year with IPSS score again for monitoring, and Euroflow to document proper flow, how the flow with the last time, and residual urine, and to complete with complete urine examination and renal function tests. My take home message here is medical management is only for bothersome LUTS. So, and treat the LUTS, not the size of the prostate. If there are no LUTS, no need of tablets. Size alone doesn't matter, and just wait and watch. And he's not a patient, he's our guest. Ask the guest to visit again to the clinic. And at the end of my session, the patient, it's not patient, he's our guest. He knows that he's not having any symptoms. His prostate is enlarged, so he will come back again for follow-up. Thank you once and all. Thank Abhishek sir and UAV Council for giving me this opportunity. Thank you for the patient listening.
Mohsen, you rightly said a patient, we don't treat the size, we treat the symptoms. Since he is symptomatic, we're not treating, reassuring him. Right. So in a patient, like you mentioned, the third patient, 64-year-old medical going abroad. Yeah. So what lifestyle advice would you advise him? This is for wider dissemination. What lifestyle advice would you advise him, especially on his travel abroad?
So actually he is not having any symptoms. So he has occasional nocturia sometimes. So I asked him to fluid restriction after say 8 p.m. or 8:30 based on his fluid intake, and I hear what is his fluid intake per day, and I asked him to regulate the fluid intake, and I'll advise him to do a timed voiding every 3 hourly. Timed voiding, and I ask him to do a double voiding. Whenever he goes for a void, wait for a 10 step. He's having very minimal, like 20 ml. Even to ensure him, we can tell that will be a good to maintain his bladder health over a long period.
Dr. Mohsen. Dr. Mohsen. 30 years back, the indication, apart from ultrasound, apart from IPSS, the bothersome score was the indication for operation actually.
Yes, sir.
I think in today's scenario it is
Arun.
Yeah.
So the scenario will differ based on the age of the patient. A 60-gram prostate in a 55-year is going to be different for 70-year male who is going cardiac evaluation and found to have 60. Age is important, how the symptom will come in the period. But common scenario we encounter is when these prostates are on blood thinners and they come with hematuria. Number two, when they have a PSA which is between 4 to 10, then you calculate PSA density, then you calculate PSA transitional zone index and all that, and then we get into conclusion.
One of the important criteria of progression of BPH is asymptomatic
PSA.
side there. So there are studies where they have followed those patients more than 6 years, 7 years. The patient with larger prostate have higher risk of adult.
You mentioned all
yeah. So at first presentation, you have to tell them that if you have drugs, you will shrink the size of prostate. If you want to take this drug, well and good. If you do not want to take the drug, well and good. So this option of medical treatment should be more for those patients at the first visit that this option is available.
At the cost of deterioration of his sexual function.
That is his.
So in most of the scenarios where we practice, our physician colleagues who they elderly patients look after all their comorbidities, they do not hesitate to start both the drugs with only being seen this size in ultrasound. And most of the times, rather than watchful within it, we have to at least reduce their medications during their treatment. Most of these patients, they already come with this medication for months and months together. Actually, they were not reduced. So rather to make them remanipulate the things, and we need to stop those both the drugs. And they are do not hesitate to start it.
Thank you, Mohsen.
Thank you, sir. Thank you.
We move on to the next paper, relatively young male with LUTS, Dr. Soumya.
A very good afternoon to all of you, and of course to our expert panel over here. So we have a small case discussion. Beginning my case. Yes. So we have a 53-year-old school teacher. He's been complaining of having voiding LUTS primarily since the last 2 to 3 years. Poor flow, straining, incomplete emptying, but was managing somehow. This has now worsened since the last 6 months, wherein associated storage LUTS have now come into play. He's having increased frequency, almost 10 to 12 times during the day and 1 to 2 times at night, and occasional periods of urgency. He's constipated. He also had a history of right inguinal hernioplasty done 1 year back. He's a known case of diabetes mellitus. His examination were normal. The prostate was around grade 2 firm. So how would you like to go about it, sir? Do you want me to give you all the investigations, or
the way you want?
IPSS of this.
Yes, of course.
What's the IPSS of this?
So he was moderately bothered. His IPSS was 19. As you can see the indices. His urine routine micro was around normal. And
What's his
PS was
Euroflow?
around 3.1.
What's his Euroflow? Euroflow and ultrasound.
So this is the ultrasound image. The kidneys were okay. The prostate was around 50 cc in size, and there was no median low projection. This was his Euroflow on presentation. So he had voided around 153 ml, lot of straining, and a poor flow.
I would want his voiding chart.
So, sir, this was his voiding chart. One thing of significance is that he's taking a lot of fluids in the evening period. Apart from that, the maximum voided volume was also around 200 ml. So he has not voided more than that. His nighttime voids are reasonable, just woken up once.
No, that I asked it. No. I asked it purposefully is because his uroflow showed only very small voided volume.
Yes.
So that's the reason I asked. I would have asked the patient even at the first visit. No, even if the first visit, if the uroflow had shown like this, and if he says that this is my capacity, I will ask for a voiding chart. No, I will definitely ask for a voiding chart. He can come back to me with all the other investigation. We start medication after.
Dr. Keshav, more than the flow rate, the pattern was important.
this
I would
exactly.
have repeated.
Yeah,
the
seeing
flow.
that Euroflow, I would rather be worried about that. And his background of diabetes, his background of having a hernioplasty a year back, I'll be more concerned about his detrusor function at this point of time, seeing that abdominal straining kind of.
Reducer function versus where the dysfunction wide. Two things
Right.
closely similar.
Yes. So, but when he asked the patient, he said this was quite representative of how he normally voids at his home also. Yes. So what next?
I would put him on medical line of management initially and see how he progresses. Reassess him after 6 weeks or 8 weeks, and repeat his flow and repeat his IPSS after 8 weeks and see how he has progressed with medical line.
So any particular medicine you want to recommend?
While recommending, agreeing with what Keshav said, I would also but warn him that there is a possibility that he might not respond well with these drugs.
Right.
There is a possibility that he has got something much beyond just a simple bladder outlet obstruction.
Right.
Among the drugs, at 53, depending upon he didn't have any significant comorbidity, so choice, I think we could start off with the tamsulosin at that age. I would give him a trial of at least 3 to 4 weeks with an alpha blocker. See, and then tell him that he might, if he doesn't respond, I will ask for an urodynamics is in my mind the minute I see that uroflow. But I would still like to give him. I mean, it's an invasive procedure. I would rather. It's an invasive procedure. No, but why would I want to do an invasive procedure right up front? Give him, let him have. He has not had drugs. He has not had any drugs. That's a fair point. But as Soumya mentioned, he did say it is a representative flow. She did mention that.
So the repeat flow also was quite similar. So I've not put in that for the sake of time.
So my two questions I want. Yeah. So I just want to know erectile function and constipation.
The guidelines also say this.
What about
you do not
erectile
go
function and
straight away
constipation?
into a surgical option for a patient who has an IPSS of just 19. His IPSS is just 19, is in moderate. So you always give him a medical line of management, reassess him after 6 to 8 weeks, and then see. If he is not responding, you will obviously, before thinking of any surgical intervention, he will require a urodynamic study if he is not responding to medication. But telling a patient as soon as it comes that because you see a uroflow like that and you're suspecting something, to do a urodynamics without starting medical line of management is not the correct way of doing things. You can do anything you want. You can do any number of investigation, but you can always give him. There is no harm in trying alpha blockers for some time. If he responds, my argument is you put him on alphazosin. If he responds very well, why do you want to do a urodynamic study at that point?
Sir, I slightly differ.
Yeah, it is.
No, sir, UDS is their own indication in a patient presenting with non-urinary LUTS. That is for
Sir,
sure. But what we missed was rectal function and constipation,
Yes,
which I
I'll be
want.
coming to that.
Sir, the IPS score and the uroflow is not matching right now in this patient.
Okay.
So I'll start with Elfusin and Tadalafil combination,
Right.
along with 25 milligram of mirabagrone for 10 to 15 days,
Right.
and then ask him to repeat the uroflow.
Yes. So I wanted to know that when we are starting medical management, is there a role, like he has a 50 cc prostate. So we know there's a cutoff of 40 and some studies 30 gram of prostate for starting a combination treatment. So is there a role of starting combination treatment right upfront, or do we just start with a simple
You
alpha
could
blocker?
choose to, you have to talk to the patient and tell that if I use combination, there is going to be some side effects on the sexual function. If he's agreeing for that, there is a role for combination therapy upfront.
Yes.
But if he says, no, I don't want, the plain alphazosin also would work similarly as much, because you're not looking at decreasing the size for assessing 6 to 8 weeks. There wouldn't be much change in adding a reductase inhibitor.
Right.
Yeah. What was just mentioned, since I'm given his Euroflow, I would not really be looking at dutasteride or a 5-ARI at this point in time, because in 3 or 4 weeks, I don't expect
Much
it to
effect, yeah.
much effect from
Right.
that. Yeah.
Yes, so the guidelines say that if the patient is bothered, like our patient with a 19 IPSS, with a predominant voiding LUTS, with a prostate size more than 40 cc, we usually start with some education, lifestyle management, and we can start with or without the combination therapy. And then subsequently we can follow up, and if need be, if he does continue to have storage symptoms, we can add an antimuscarinic as well. So for this patient, we gave him a trial with silodosin. He was taught fluid management. His constipation was addressed, and then he was followed up after 1 month. So on 1 month, this
At
was
no
his
point of time
Euroflow.
is sexual behavior or activities
Yes, sir.
coming.
So I missed it in the history, but he's a sexually active male. So at 1 month of follow-up, this was his flow chart now. So we have a flow rate of 8, and yet again he has voided only 133 cc. So this was almost his second or third Euroflow with the same volume of void. Post void was around 70. His IPSS has now come down to 15. The frequency still remains the same. Rest of the parameters have come down. So now for this male, to summarize, he's a relatively young male. He's sexually active. His LUTS have improved. Voiding LUTS have improved. Frequency is still somewhat bothersome to him. His voided volume has been less than 200 cc even with the treatment. He's somewhat bothered by the retrograde ejaculation because of the silodosin, and he's not entirely happy. So how do we go about for him
So
now?
this is the actual time for a voiding diary now, because his flow has improved somewhat and he's bothered some. So a voiding diary now would give us some information again.
Right, because yet again, even in the UFR also, he has voided less than 200 ml.
I wouldn't have
So-
started him with silodosin. I would have opted to do
For, alphazosin.
alphazosin, which would have addressed his bothersome with retrograde ejaculation,
Right.
because the incidence is much less with alphazosin. So upfront starting with silodosin was not the first option.
Right.
You could have tried with alphazosin, and
Okay.
then if it does not, if he is not responding and if his bladder capacity remains to be the same, if it's representative, I would do a urodynamic study at this point
Right.
of time.
So the response was there, but then again, the patient was not very happy. So do you still feel with this treatment profile, do we need to offer him something more?
What you have given for, I mean, this frequency and all these? Nothing?
So again, the frequency, he's saying it is still 10 times a day. So is there a role of adding an anticholinergic at this point to him?
He
already
wanted
said-
upfront he wanted to put, there is a role for adding anticholinergic if his frequency is bothersome,
Right.
and if you find that his flow has improved a bit, you could add an anticholinergic at this point of time.
I would say a beta 3 because he's anyway constipated. So
Yes.
beta background would probably
Yes. So in spite of the medical management, the patient is not entirely happy. So hypothetically, we did shift him to alphazosin, and even that, for the sake of this case discussion. So in spite of the alphazosin, he is not very happy. His LUTS have improved somewhat, but he still wants, is there some other option that he can be off therapy? So is there something that you can offer? Or do you need a urodynamic study before going for something more invasive?
If you are taking us towards mist,
Yes.
I would still do an urodynamics before I'll venture.
I was sweating. I was, oh my God, they're not taking the hint. Okay. Yes. So, yes, so we did, of course, a urodynamic. This is his urodynamic picture. Again, avoided volume of 140. This was on alpha blocker. His maximum flow rate is around 7, and his PVR is around 80 ml. So now we have his hysteroscopy findings as well, that the urethra is normal. He has grade 2 lateral lobes. There is no median lobe. There are mild trabeculations in the bladder. For such a patient, do you want to go ahead for someone who's sexually active, bothered with the retrograde ejaculation.
If he's concerned about his sexuality, then mist is going to be the offer. If he's
Right.
not responding to medication, you can give one of the options of mist.
Yes, because mist as well is going to improve his LUTS only as much as the medical management is going to improve. So that was the dilemma in this patient. Like, he doesn't want to stay on drugs. Like, his drugs the medicines gave him a good response, but then he wants to be off drugs. So for such a patient, do we go about recommending a mist procedure, or do we go for something more traditional?
Since he was bothered with the his ejaculatory function, so a traditional surgery, and he was not very symptomatic, and his symptoms are primarily on the storage side.
Right.
So a traditional surgery won't be my choice for him at this point of time.
Right.
And missed Eurolift kind of procedure would be option. Obviously, you will have to be told about what are the pros and cons of that. And yes, that's an option which, since he was not enjoying the medical management so much, that was an option which he could take, but then he has to take that call. I would not push him for a procedure because his volumes are still low and he is still frequency is high. So I would not really push a mist right for him.
Okay. So coming to this management, his prostate volume was in the 30 to 80 ml range. So the options that we have are TURP, laser enucleation, bipolar enucleation, laser, and prostatic urethral lift. However, considering he's sexually active, he's interested and quite keen on preserving the function. Of course, we know that the bipolar and monopolar TURP is the gold standard. But we also have some of the studies regarding a Eurolift procedure. They found that there is an improvement in the symptom score from 22 to 11, and the IPSS and the Qmax improves by around 4 ml per second. There was also this comparative trial between TURP and urethral lift, which of course found that TURP was definitely superior in terms of IPSS and Qmax. However, the ejaculatory function was superior for the prostatic urolift patients, with 100% of them preserving the function. Sir, do you have any other experience
Dr.
with any
Samrat,
other
please
mist
conclude.
procedures?
We are running short of time.
Okay, so I'll just hurry up. So the other studies is for the convective thermal therapy, that is the resume water vapor therapy. They found that there is a 51% reduction in IPSS and the Qmax was improved around 4.2 ml. Aquablation has shown quite promising results, at least for the short-term duration. They have found that the prostate volume decreases from 57 to 35 ml and the IPSS mean decreased from 23 to 6.8, which is quite considerable. And the ejaculatory function was preserved. On comparing it with TURP in the water trial, they found there was no significant difference in both the groups in terms of IPSS, quality of life, Qmax, and the reduction in PVR. So aquablation is given in the recommendation, but still it's a weak strength of recommendation. Okay, that will be all.
Thank you. Thank you. very much.
Look at the ejaculation preserving TURs.
It's a 50-gram prostate, so can we still
Thank you. Thank you so much.
You can do.
Next is BPH with cardiac stent pacemaker. Dr. Santosh, and please.
Respected chairpersons, delegates, good afternoon to all of you. With increasing longevity and increased incidence of cardiovascular diseases, it's bound that we're going to see these kind of complex BPH patients more often. Patients on antiplatelets, patients on anticoagulation. So it's important to carefully consider the factors for safe management. So this will be the outline of talk. We'll have a case capsule, then proceed to learning points and summarize. The index patient today is a 66-year-old gentleman, very fit, retired army officer. He had a well-controlled diabetes and hypertension. He had a recent acute coronary syndrome episode for which he underwent a percutaneous intervention with drug-eluting stent 6 weeks ago. He had no past urological interventions. He's now presented with acute painful retention with a retention volume of 750 mils after an after a catheterization. He had prior history of lower urinary tract symptoms. He had poor flow, nighttime frequency of 3 to 4, but he was not on any medications. And at the time of the percutaneous intervention, he was catheterized, but at the time he voided spontaneously after catheter removal. He had normal bowel habits. This is the current list of medications. He is on dual antiplatelets, Plavixis, clopidogrel. He's also on antihypertensives and his diabetic medications. Examination, he's a fit gentleman. He has a periuretal catheter and there is normal tone on and bulbocavernous reflex. There's an enlarged prostate, which feels clinically benign. The investigations are essentially normal. There's a normal creatinine, well-controlled sugars. After the catheterization, he's sent off and he comes to OPD. That's when we're reviewing these medications. He had an ultrasound a few days before the retention, which shown normal upper tracts with enlarged prostate, both on the trans-abdominal and transrectal ultrasound with a significant intraprostatic protrusion, as you can see in these images. He also has an echo which shows an ejection fraction of 53% with some regional wall motion abnormalities. And on asking him some further details, he provides you what he went through. Just to highlight a few important things, he had a single vessel disease, which was a right coronary artery. And also he had 2 drug-eluting stents. These are relevant. I'm just bringing these to your notice. So he was started on combination and given a trial of void after a week, which he failed. So at this point, the questions are, when would you intervene? He is on antiplatelet 6 weeks into a drug-eluting stent. When will you stop and restart them? And what are the treatment options that exist? In the interest of time, I'll move to learning points. We can have a discussion once I finish. So the key question here is to balance between the risk of an ischemic event and thrombosis, because he's had a stent, versus the risk of bleeding during the procedure. Because any surgery itself is stress, and that itself causes an hypercoagulable state, which can lead to ischemia and thrombosis. So, like I said, the key is to balance between the bleeding risk and thrombotic risks and major perioperative adverse cardiovascular events. Also, to consider the urgency and indication for the surgery and the time duration from the revascularization procedure, the type of procedure plan, and the cardiac and the functional status of the patient. So there are a few guidelines to give us an idea of what we're dealing with. So a low thrombotic risk is less than 1% major cardiovascular risk events. So any intervention within more than 4 weeks of a plain balloon angioplasty, or more than 6 months of a bare metallic stent, and more than 12 months of a drug-eluting stent. So that's the ideal combination. But the other factors to consider are the complexity of the stent itself, like I mentioned before, whether it's a single vessel involved, if it's a single or a multiple stent. Multiple stent definition is more than 3 stents, and if it's stent in a bifurcation. So these predispose them to higher risk of thrombosis. And anything within 2 weeks, if it's just a balloon angioplasty, or within a month of a bare metallic stent, and within 6 months of a drug-eluting stent, is considered high risk, which means there's more than 5% risk. However, this is not written in stone, because recent evidence suggests that with second-generation drug-eluting stents, evidence suggests that a non-cardiac surgery, even a bit sooner, is safe. Then we come to the bleeding risk. As you can see here in the first column, general urologic surgeries such as cystoscopy, ureteroscopy has been highlighted as low risk, while a prostate biopsy is intermediate risk. But traditional TURP, TURBT, prostatectomy, these are all considered high risk. But it's not so simple. Various evidences give different kinds of classification. Broadly, urological surgery is classified as intermediate risk, where it's potentially difficulty in achieving local hemostasis, as opposed to a very high-risk surgery such as neurosurgery. But again, it's not that simple, because there are additional patient factors to consider which can further complicate the bleeding and ischemia and thrombotic risks, such as age, chronic kidney disease, diabetes mellitus, the gender of the patient, and medications. So basically, we're dealing with a complex scenario which calls for a multidisciplinary approach to involve the cardiologist, anesthesiologist whenever you plan for the surgery. And whatever the evidence we saw, again, it's nothing, it's just a broad guideline and a structure, but it has to be individualized to the patient taking into account the comorbidities and the functional status of the patient. Now, if we do reach a stage when we've crossed the bridge of the 1 month for the bare metallic stent and the 1 year for the drug-eluting stent, at that time, this is the evidence suggesting that, again, the TURBT is a moderate risk. So aspirin and clopidogrel needs to be discontinued about 7 days before the procedure. And it may be restarted about 7 days after the procedure, which is when you expect some secondary bleeding and the eschar to slough off. But the good thing is we still not in a state when we're just talking about TURP. We have better surgeries in our armamentarium, such as the laser surgeries, both the vaporization procedures and enucleation procedures. This review in 2018 compared these three in patients on anticoagulations and antiplatelets. And as you can expect, the bleeding risk was less with laser procedures. However, you can see the transfusion in HOLUP is 3.5 to 8.4. That's because of one of the series, which is very early in 2006. But however, the enucleation and the vaporization had fairly big size glands, 60 to 80 grams. Very weak evidence with alternate procedures. Soumya just spoke about the missed procedures. Prostatic urethral lift has been shown in low quality studies to be an option in such complex patients on antiplatelets and anticoagulation. Also, things like Resume is coming up where a few studies have shown that it's a safe and effective option. Also, if the patient is very comorbid and not suitable for any procedure, prostatic artery embolization is something you can consider. But you have to be careful in planning to see the vascular anatomy and have a good intervention radiology team. So this is a flow chart summarizing the non-cardiac surgery timeline, which is it is safe in a dual drug-eluting stent to proceed ideally after 6 months for intervention, and for a bare metallic before 30 days and a drug-eluting stent before 3 months is not safe. Just moving on to the guidelines, the AUA guidelines, this was specifically a complex patients update in 2014 by AUA, which says the dual antiplatelet should not be withdrawn 12 months in case of a drug-eluting stent or within 3 months of a bare metallic stent, and a multidisciplinary approach is required. And when the time does come, it might be recommended to continue aspirin if the bleeding risks are acceptable. But the same guideline statement, the point number 13 says laser prostate surgery can be safely accomplished for patients with therapeutic INR who have a significant risk of thrombosis without discontinuation of the anticoagulation or the platelets. Also, the AUA guidelines, the 2023 guideline statement 43 states that laser surgery such as HOLEP, vaporization and TULEP should be considered as better treatment options for patients who are at higher risk of bleeding. The same thing is mentioned in the EU guidelines as well, where laser procedure is a preferred choice for those on anticoagulation. So to conclude, it's ideal wherever possible to defer surgery for 6 to 12 months, but this is not written in stone. With better equipment such as laser and armamentarium, we should be able to offer surgery before with cardiac input. A multidisciplinary approach is required. Urologist should take the lead. It's our patient. And pre-op cardiac and functional optimization is important. And preferably the aspirin may be continued intraop, especially if you're using a laser. And intraoperative, as we've discussed, laser procedures are better and needs good cardiac monitoring and a backup cardiac intervention in ICU. And clopidogrel can be restarted whenever the bleeding risk is low, which is usually around 7 days after procedure, with continued cardiology monitoring. Thanks.
After this finding, they gave a Brilanta, which is a new antiplatelet. And what is the guideline for that? Because they asked to stop for 2 days and then we have to give some injection. The low molecular heparin doesn't work in that.
So I think you're talking about intravenous antiplatelets.
Not intravenous. This is the oral tablet.
Okay.
Most of the patients who are on a drug-eluted stent, they all are on a, most cardiologists put them, even PMJY patients are also on this drug.
They are newer oral anticoagulants. They are called as newer oral anticoagulants.
Okay. Okay.
So in them, you can not give low molecular, you can put them on heparin because heparin has an you can always bridge it with heparin.
I think, yeah, that's anticoagulation. For antiplatelets as such, for the stents, because we're looking at cardiac stents, if patient has a stroke risk or a DVT, probably anticoagulation bridging plan works. But for cardiac stents, I think it's antiplatelets.
Dr. Santosh, you are talking about lasers, and Turis is also safe for the cardiac patients.
Sure, sir.
You have not mentioned this.
Yeah. Okay. Okay. Sure. Catheter. Yeah. Sure. To relieve the outlet. Sure. Thanks.
Thank you, Santosh.
Thank you.
We move on to the next one, BPH with bladder space occupying lesion. Dr. Prashant.
Often respected chairpersons, dignitaries, my colleagues and seniors. At that outset, I would like to thank you team and Abhishek sir for having given me this opportunity. Today, I'd like to discuss regarding BPH with bladder mass. Working as a consultant urologist in KIMS Secunderabad. So, a case scenario I want to give: Mr. X, 56-year-old male patient, having obstructive LUTS greater than irritative LUTS for the last 6 months. He's having dysuria, no hematuria, and other symptoms. He was on alpha blocker along with 5 alpha reductase inhibitors. However, he is not satisfactory on medication with little improvement in symptoms. His IPSS score was 22. So he's a hypertensive for last 10 years, smoker for 10 pack years, no other neurological illness, no history of trauma intervention. He was on medication. No family history is not significant. He's a software professional. He's on mixed diet. CUV only no pus cells, no significant pus cells or RBC. The culture is sterile. Ultrasound showed bilateral kidneys, no hydronephrosis, thickened bladder, around 2.5 into 2 centimeters mass, the right posterolateral wall with internal vascularity. Prostate is 40 cc with median lobe with a PVR of 135. Uroflowmetry, Qmax of 10 with a dynamic obstructive pattern. Creatinine was 1. PSA is normal range. So I'd like to ask how to further proceed in this patient.
Image. Can you show us the image?
Image of ultrasound. Yep. Not available. No hydronephrosis. Only a small mass is there. Very small mass without any internal vascularity.
A 2 and a 2.5 centimeter mass in order, not a small mass. So I would, before I start intervening, I'd like to evaluate the patient much more, and probably if the CT image, if ultrasound is not there, even that's not there.
Sorry, sir, images are not available for both. However, CT was done. It showed the similar findings without any other lesions elsewhere in the upper tract. Any other test would like to do, sir, other than CT, this patient with a mass in the bladder?
So I would like to primarily treat this patient as having a bladder lesion rather than as LUTS at this point of time, and he needs to be evaluated and treated for a bladder lesion.
So, however, uniform malignant cytology is negative.
That's fair enough. We'll do the cytology, do the upper tract workup, and make sure that he has got a bladder growth. But that has to be treated on its own merit without, at this point of time, really bothered about his LUTS. That's what.
However, we also
centimeter mass in bladder, solitary mass in bladder sonography. Do you consider upper tract screening without going the extraordinary?
as yes. So usually at a small mass, CT urography is not required. You can directly go for a TURBT. However, in this patient, it was done as he was very much apprehensive. So we got it CT urography done. Malignant cytology was negative.
It is not entirely the upper tract. You will see a local extension also.
No, there are indications when you do a CT in a bladder tumor. There are, when you find upper tract changes, the mass more than 3 centimeters, ultrasound showing an obvious extravesical extension. These are all without doing a biopsy, you do a CT scan. But this patient, I wouldn't do right away a CT scan because there's nothing else seen. I would do a cystoscopy and see planning for a TURBT. Look at whether it is low grade, high grade, and then plan what it's.
So of course, in this,
the point probably you want to raise is that whether you can do TURP, supposing in case if you need to do a TURP, if you do it simultaneously because of the fear of tumor cells settling over the raw fossa.
so that is what I'm going to discuss further. So that is what the point of discussion here.
So the point is that we to go for the bladder tumor resection first.
Yes.
And then we restrict the medical management for the BPH. So there are many students, I think they should get a clear message.
Yeah, the title itself suggested that whether we're going to treat both together, and I specifically said I'll treat this patient only as with a bladder mass.
Title is that only, sir, but we want to see the literature and review that whether doing simultaneously makes any significant difference or not. Whether if you're doing a single setting or not.
I don't think.
I want to give little case scenarios other than this also, sir. What case scenario, how we are going to proceed. Of course, in this patient, CT is not recommended as per a small mass without any upper tract changes and no malignant cytology is negative, no hematuria. Of course, we did it in view of patient's apprehension. So in this, I want to give, other than this, 3 more case scenarios. In this patient, bothersome LUTS on 6 months of alpha blocker and and 5 alpha reductase inhibitors, not satisfactory, IPSS 22 and flow Qmax is 10 and bladder mass. Another second case scenario is the same patient with upper tract changes without obstructive uropathy, the creatinine is normal. The third case scenario is with upper tract changes and creatinine is elevated. So in these 3 case scenarios, what we are going to do, and we want to review the literature whether doing simultaneously both TURP and TURBT is going to have any significant difference in the outcomes or recurrence irrespective of the patient case scenario. So I like to go through literature. So in this treatment dilemma, whether TURBT alone, in this case, TURBT plus TURP plus minus intravesical installation single dose, or stage TURBT followed by TURP. The present index case has a bothersome LUTS without any improvement in symptoms even after 6 months of treatment. So what are our concerns of doing simultaneously both? The safety, efficacy, what are the oncological outcomes with respect to recurrence and progression? What are the complications? Is there any difference? What are the pros and cons? So what does evidence or literature suggest? So I'd like to go through few high level evidences, meta-analysis and randomized control trial to show whether is there any clinically significant difference. So in the current study is a propensity match study where 12 European hospitals were included. Overall propensity match was done in 254 patients out of 762 patients. So retrospectively done. During the propensity, after propensity matching, we can see on contrary, there are more recurrences in the TURBT alone compared to TURB plus TURP. Along with the intravesical installations were given in this case. The p-value is significant, less than 0.001. So you can see here, initial cohort, the multifocality, with respect to multifocality, single installation intravesical therapy, it's significant. When propensity match was done, it was clinically, the recurrence-free survival was clinically significant in the combined group, TURP plus TURBT. On contrary to what we expect usually, either it should be, there should not be any difference, or there should not be any difference. But here we are looking otherwise. There is a significant difference. Recurrence-free survival is improved with the combined study. We can see this in the same representations. The other study is also a randomized control study where they are divided into 2 groups. One is tamsulosin plus TURBT alone. Other group 2 is the TURBT plus TURP was done. All were matched. At the end of the study, The symptom score was significantly better in the combined group, IPSS and Qmax, and also bladder scoring. Cancer scoring was significantly different, better in the combined group. Here we can see further multivariate analysis was done where there is no significant difference. Either we are doing simultaneously TURB plus TURBT or TURBT alone. There is no significant difference with respect to the either recurrence, whole bladder or prostatic urethral recurrence in this study. The other study, systematic review and meta-analysis done in 2021, published in BJUI. They have taken approximately around 8 to 10 studies where there is no significant difference either in the both group TURBT plus TURP or TURBT alone after a follow-up of around 20 odd months in all the studies. Here we can see in the forest plot there is no significant difference either with the combined study, combined surgeries or single surgery alone. And one more systematic review and meta-analysis where we can see overall bladder tumor recurrence is not different in the sub analysis, and in the prostatic urethral bladder neck is also not different. In all the patients, intravesical installation was given, and overall bladder tumor progression is also not different in this study. So there are few other studies where we can see the simultaneous TURBT and TURP in the presence of even high-grade urothelial bladder cancer appears to be oncologically safe in a selected patients in this, and other studies also signify the same. So I would like to ask here whether we can do a we can do a combined TURBT plus TURP, keeping safety of the patient in the mind and subjecting the patient to only one surgery rather than two surgeries.
No, I would, in my opinion, you will find studies if you find literature for everything. If the tumor is looking high grade with multifocality, I would not do a prostatic surgery. I would just deal with the bladder tumor and leave it.
Sir,
but if it is a lesion which looks like a pun lump or a very low grade tumor, there's no harm in resecting and then doing a TURP. So your studies, you'll have to look at what is the grade of the tumor which they have looked in, what is the multifocality, all these things have to be assessed when you tell that both can be done simultaneously. If those things are not addressed, then it becomes difficult for us to swallow that it can be done very safely. If the tumors are high grade and multifocal, I would not still venture doing both of them together. But if they are very small lesions, pun lump like lesions or very low grade lesions, I would definitely do a resection of the prostate and the bladder tumor simultaneously.
So in this study,
there is a bias in all these.
Yes, sir. I would like to say what are the drawbacks in this study.
Yeah, because
in this studies they have not included the patients with the upper tract changes. Upper tract changes were not included along with the mass, and they have not included patients who have recurrence. Recurrence patient previously had a
so the basic idea, we are presuming the patient has got NMIBC.
Yes, yes.
We have excluded muscle invasive disease totally. So we rather, as has been said by both almost all of us, that deal with the bladder tumor, make sure that it is not muscle invasive, because the treatment actually goes on a different tangent. So here we are presuming the patient has got non-muscle.
Oh, sir, last I want to emphasize that, sir, in the patients without any upper tract changes appears to be a normal small solitary lesion. Patient is having
upper tract involvement itself suggests muscle invasive.
Without any that lesions, we can simultaneously safely do both.
Thank you. Thank you.
So we've consumed the lunch time almost. we'll gather at 2:15. 2:15. The lunch is served in the dialysis and pathology wing, which is right across this wing.
So there is
Today the dinner will be at Boulevard Resort, which is about 5 kilometers from here. If you have a vehicle, then you carry some people with you. If you don't have a vehicle, there will be many shared vehicles going from the MPH gate. Neither of you, of course, know Dr. Tanuj and Dr. Parimam. I thought it is. No. We just you three. We just make some this one 3 chairs that side and 4 chairs this side. So take that. But so hey, boys. Results were not expected, but again, not all of them we had cystoscopy figures and maybe that will be interesting. Maybe 6 months or 3 months.
You can virtually make someone disappear. I think already we have revealed a few things. You want to do bipolar, monopolar, laser, or then you capture it. Obviously, whoever is spent 1 crore rupees will not spend 1 crore. South America.
Check, check. Hello, check, check. Hello. Hello, check. Present. Hello. check, check. Bottom floor नहीं है. Again, concern એટલે જ કહું છું એમને 4 વાગે જોઈએ છે તમે હું તમને 10 મિનિટમાં કેવું મેં કીધું check, check, check.
A very warm good afternoon to respected seniors and my dear colleagues. I am Dr. Jayaramdas Patel, and I would like to invite the expert faculty here who are present here on the dais here, please. Dr. Rohit Joshi sir and Dr. Anil Varshney sir. They are stalwarts in the field of laser enucleation of prostate. And with this short introduction, we'll start the session. Yes, sir. I'm Dr. Taif. Please join us, sir.
So, good afternoon, friends. Welcome back to the post-lunch session. It's really going to be very interesting, and because it's all surgical techniques, BPH we see time in and out. Each one of us has to master these techniques, and with this, I think without wasting much time, I invite Dr. Nirame Pathak, and he is going to show us. This is a semi-live video session, and Nirmaya is going to tell us about TURP in a large median lobe and 100 cc gland. So it's all yours. Please go ahead.
So this is a pretty interesting topic, and it makes me a little nervous to justify this topic in front of the stalwarts in the laser enucleation of prostate. So I'll start with, I have nothing to disclose. This is going to be the outline of my talk. I'll skip through the theoretical part of it, and we'll go to the case videos, which are interesting. So prostate anatomy, as we are all aware that this is how it is. Benign enlargement of prostate happens because of the enlargement of the transition zone of the prostate. In this figure, we can see that how verumontanum is the elevation formed in the prostatic urethra, formed by the opening of the utricle and the ejaculatory ducts, and how the membranous urethra, which is the external sphincter, is 1 centimeter distal to the verumontanum, and how the sphincteric fibers are arranged in a horseshoe fashion with the ventral fibers a little proximal compared to the distal fibers. So this is the vascular anatomy. We can see how the prostatic artery arises from the inferior vesical artery, and how it spreads into the capsular and urethral branches with perpendicularly supply the prostate, with minor contribution from the middle hemorrhoidal and pudendal vessels. We are all aware of this acronym RUSHES, which tells us about the absolute indications of TURP. Now we'll go to the challenges of large prostate. It is challenging because the gland size is larger, the resection time will be longer. There is higher risk of bleeding, and there is a higher risk of incomplete resection. The image that is there on the right side specifically shows this point, that how the enlarged lateral lobes project inside the bladder intravesically and also project beyond the verumontanum distally and distort the anatomy of the sphincteric fibers. Now in a large median lobe, it is basically an intraprostatic projection of the prostate. It impacts the surgical approach, meaning the Nesbitt procedure is out of the question because we need to resect the medial lobe first to create a good channel, and then only we can go ahead with the procedure. It obstructs the bladder neck, and there is difficulty in assessing the urethral orifices and also with the actual resection. So in this figure that is there on the right, it shows the same thing, and how if accidentally we start resecting from the center, it results in bivalving of the medial lobe and subsequent bleeding and further difficulties. This is how we routinely do the preoperative evaluation. The surgical technique, low pressure for large prostates with medial lobe is preferable, because the prostate chips, we want them to fall away from us, and the blood also will flow away from us, making the resection times shorter, and there is lesser risk of fluid overload if we are using bipolar TURP, and lesser risk of TR syndrome in case of monopolar TURP. Bipolar TURP would be preferable because we want lesser risk of TUR syndrome in view of the longer resection times which are going to be anticipated with this procedure. And it also helps in increasing the speed of the resection because the chips are easily separated while the resection. The main steps, as we all know, consist of anesthesia, scopy, and initial assessment, followed by the resection strategy, which starts with identification of the landmarks, removing the bulk of the tissue, and tidying up an apical robe resection. This figure also shows the same. Here we can see that how the resection of the lateral lobe continues. And if we do a tangential resection of the lateral lobes, the intraprostatic projection of the lateral lobes tend to form a flap, which will, which if not recognized, can cause obstruction to the urine flow by causing a flap valve mechanism. Similarly, in a large medial lobe, the medial lobe, it projects in an hourglass kind of fashion because the interurethral meatus is narrow in size, and it needs to be carefully resected. Plus the vessels that are supplied in the medial lobe, they mainly traverse through the side of the prostate at 5 and 7 o'clock positions. So they also need to be controlled to create a better channel and to devascularize the medial lobe so that the resection is better and faster. So this shows that how we need to do the angulated resection by creating grooves and not tangential resection of the medial lobe. And the figure on the right shows that how after resection of the medial lobe, the lateral lobes fall towards the midline. So these are the Badenoch vessels which are there at the 5 and 7 o'clock position, and how these vessels supply the medial lobe, and once these are controlled, the medial lobe resection will be easier. At the end of the resection of the medial lobe, we should be able to see from the bladder neck to the veru level. If lateral lobe resection is started from 12 o'clock position, as in the Nesbitt procedure, we have to take care to avoid this kind of situation. Similarly, there is a risk of perforation if the size and we are not careful while resecting the median lobe. Bleeding which is there, which can be encountered, needs to be controlled, because as we know, this is a large prostate and it is bound to be vascular. The bleeding points as discussed, 10, 12, 5, 7. This image shows that how the bleeding needs to be controlled, either by point coagulation or by proximal and distal activation of the coagulation mode. This image shows the same, and this image shows that how we can use finger guidance to aid in our resection. We can use finger for creating compression from above to aid in the resection at 12 o'clock position. We can use it for aid in the resection of the apical tissue, and also we can use it to compress on the medial lobe projection. So we are aware of the common techniques, which is Barnes method, starts with resection from 5 to 7 o'clock position, followed by Nesbitt's technique, which starts with resection from 12 o'clock position, followed by Mohr-Mayer. These are the three commonly used techniques. Mohr-Mayer is a technique which is to be followed only in the absence of the medial lobe. Post-operative care is as per standard. Complications, we are aware of it. This is what the literature suggests. The AUA 2023 guidelines does not even suggest TURP as an option for prostates more than 80 cc volume. The EU guidelines provides level 1 recommendation for only the 3 established techniques and does not recommend the TURP, though it is mentioned. But this is a recent UCNA article which mentions that how for bipolar TURP there is no size restriction, and it quotes various studies to support the same. We'll go straight away to the case number 1, which is a 72 years old male, hypertensive with polio, had urinary retention, and Foley was inserted, and a patient was planned for the TURP procedure in view of the very large volume. You can make out it is 120 cc with a large medial lobe projection. So in this video, we can see that how the lateral lobes are enlarged, they are kissing in the midline, and we are also able to see that how big and vascular is the medial lobe. We were able to see the bilateral uretral orifices with slight difficulty. And with the cystoscopy procedure itself, we can see that how the hematuria, how the bleeding has started. So in this, the mistake that was done was the resection, which was started from the 6 o'clock position, which resulted in sort of bivalving of the medial lobe, which had to be taken care afterwards. And we could salvage the situation because of the expertise of the operating surgeon. Now I'll go to the next case. This is a 77 years old male with hypertension and diabetes, had acute urinary retention, had to be catheterized. The operating surgeon could not go ahead with the procedure, and he referred the case to us. This is a rather interesting case. When we tried going inside with the cystoscope went just few centimeters proximal to the verumontanum, and we could not take the cystoscope inside. This patient happened to be my relative, and he was not willing to accept the morbidity of open surgery, nor was he willing to pay for the robotic case, robotic simple prostatectomy. So what the ingenuity of doctor who was operating on this case, he decided to use a modified approach in which, if you can appreciate, he created a suprapubic cystostomy. He put a 26 French implant sheath, and he resected the median lobe, which was projecting inside and preventing the entry through the perurethral route through suprapubic cystostomy. 26 French implants, 24 French monopolar resection resectoscope was used to resect the projecting median lobe and the projecting lateral lobes. The Foley was kept as a landmark at the just distal to the just proximal to the verumontanum, and it helped to provide a landmark and for irrigation. After the resection of the medial lobe perurethraly, we could proceed as per standard and resect the whole prostate. Not recommending this, but just this is for a knowledge that this is also an option. So to summarize, TURP in large prostate with large medial lobe is definitely challenging because the anatomy is distorted, the landmarks are not clear, vascularity is more, complication risk is also there. How to be safe? We can be safe with, by empowering ourselves with adequate knowledge, using low pressure procedure, using bipolar resectoscope, creating a channel first, and coagulate simultaneously, especially the arterial spurters, and limit the resection times. These are my references. Thank you for a patient listening.
Yeah, excellent. I think Nirame, you have shown how you deal with such a challenging cases, and the bottom line remains that first you have to make the whole thing avascular. That is important because until and unless you are, as you showed, that if the bleeders are pumping and you are struggling, that should always be avoided. That is number one. Number two is anatomy is the most important thing because if you do not respect the anatomy, you will be in a soup. So whenever you are having a large gland, the third thing is that when your third case, the urethra may not, always you will not be able to reach to the neck, and therefore another option is the perineal urethrostomy.
Correct, sir.
So many times we have to do, not many times, rarely, we have to do a perineal urethrostomy to deal with a situation like this.
Yes, sir.
So I think any questions from the audience?
Niramai, see, the issue of not being able to reach into the bladder could be either of, a large or long penis, wherein the perineal urethrostomy can focus. But if it is because of the acute angulation, many a times you have an access to laser, you always identify the groove. There is always a natural groove. Once you, incise that groove, you'll be able to follow that groove and then reach the bladder. Yes, if the penis length is large, then either of two options, either you do perineal urethrostomy or now we have extra long enucleating element. So there is an adapter and your device an extra long enucleating element. So then we can reach.
Yes.
So not always we need to do that suprapubic trocar and all that.
I agree, sir. So we.
Yeah, that's what.
Yes,
that's
sir.
what. So yeah.
So we don't have
It's
an
available.
extended length resectoscope with us. We had counseled the patient regarding the option of perineal urethrostomy and going ahead with the procedure. He was not willing, and we don't still have.
Perfect.
for
You perfectly did the what could be, bailing out the patient. Nice presentation. Thank you.
Thanks.
Taif, you will be now enlightening us with, how a beginner can start his whole adventure. So let us listen from Taif. All the way.
Good afternoon, everyone. Thank you for this opportunity. So, before a beginner ventures into starting a HOLUP, these are some of the questions that he or she decides for themselves. Why do we need to do an enucleation? Obviously, it is the efficiency and safety. What are the options for doing enucleations? Amongst the plethora of options, energy comes secondary. And why opt for HOLUP? It is obviously the ease of dissection and the efficiency that it gets. So once one is decided to start off with HOLUP, the first step is the instrumentation. Well, yes, the endoscopic equipments remain basically the same except for the working element and the accessories. The laser and its accessories would remain the same for any other thing. The additional thing that comes up is the morcellator and the morcelloscope. So without digging further detail into these technicalities of instruments, as per the theme, we'll go for the simple technique for a beginner. The first thing is assessing of the gland and the landmarks. The landmarks being the veru and the sphincter, and proximally the ureteric orifice. For a beginner, I would suggest to start off with a two-lobe technique. The first step being a incision at 6 o'clock. The 6 o'clock incision, once started, has to be deepened, and this is the distal inverted U incision on the mucosa to mark the distal extent of that incision. So once that incision is made around the veru, that is deepened to lift off the lateral lobes slightly and the median lobe also. So that would give a depth perception when you are trying to deepen the groove at the 6 o'clock, and you do not undermine. So you already have the proximal distal extent and even the depth defined. And then you further come back to the bladder neck and deepen the 6 o'clock groove now. So the incision which was started at 6 o'clock has to be converted like a groove, roughly covering between the 5 and 7. And at this point, you can see the gland which has been lifted up acts as a landmark so that we don't dig and cause a subtrigonation very early in the procedure. So widen the groove further so that the incision is actually a groove, and that will aid in half of the dissection being done and the advantage of better visibility. Once this is done, the next step would be making the incision at 12 o'clock. So you come at the veru, reflect up at the roof, just go slightly inside and make your landmark of the distal extent of the 12 o'clock incision. So once that distal mark is made, beyond that you incise at the 12 o'clock. This is at the roof. So the principle remains the same. Incise, you don't have much of a gland at the roof, so be careful. The fibers come very quickly, and once the fibers are there, you again make it wider. Once the 2 incisions are made, we proceed with dissecting and enucleating the lobes. The first is the distal mucosal incision. One thing that you can help out is lower down your energy settings or use a coagulation settings to mark the mucosal incision so that your oozing is less. And once that is done, all you have to do is connect the grooves which you have made at 12 o'clock and 6 o'clock systematically, proceeding from the distal and progressing towards the bladder neck. Go step by step. Once you reach the proper plane, then you will realize and enjoy the procedure of enucleation that much more. One thing to be kept in mind when you are dissecting and lifting of the adenoma is you have 3 areas where you can fire your laser, either at the exact junction and the fibers which are stretched, or be slightly towards the capsule or towards the adenoma. As far as possible, be in the mid zone. If you are scared about a perforation, you can be slightly towards the adenoma. Venturing too much on either side can cause the problem. Once you do, in the 2-lobe technique, all you have to do is just keep swiping around and make sure that you are connecting the 2 grooves at the roof and the floor. And if at all there is any discrepancy, often which is noted while they are joining the 2 grooves, that can be joined in between. And once you reach towards the bladder neck, care has to be taken. The landmark of ureteric orifice has to be assessed, and then be careful not to dig and undermine, and at the same time keeping the adenoma away from the surgical capsule, we will be able to enucleate. Being slightly away from the actual tissues gives us proper hemostasis in the first pass, and the shock wave plasma bubbles which are created helps in proper dissection. So this is where when you reach at the bladder neck, you are incising the bladder neck fibers without going very deep and maintaining the same principle of joining the grooves at 12 and 6 o'clock. So once this is done, when you reach at the bladder neck, make sure the small vessels which come from the bladder mucosa, the varices, are properly coagulated so that the visibility is improved. After this, the same steps are replicated on the opposite side. You make the incision, use low energy at the apex, hemostasis the mucosa, and then again deepen it and start proceeding now to join the groove at the 6 or rather 5 with the groove which you have widened up till probably 1 o'clock. So going step by step again, make sure the fibers are always visible and you are in the proper plane. Again, if at all there are any nodules which are dipping into the capsule inadvertently, you can either opt to modify your plane or leave it behind and come back at the end to just handle that isolatory nodule later on. And keep proceeding at few areas. If the previous episodes of prostatitis are there, the adenoma would be stuck, and make sure if that step comes across, you utilize the other areas where the plane is properly dissected and come towards the area which is relatively stuck. So come from well defined to less defined areas, and as we come across, the movement has to be from both the sides, and rather than just proceeding distal to proximally, this would prevent the common issue of subtrigonation. So keep proceeding step by step and make sure the intent is to join the 2 grooves, and most of the time we'll be able to complete the procedure without major hurdles. Once you start completing this, hemostasis has to be perfect before you venture into morcellation, otherwise you risk major injuries. Before you proceed to morcellation, make sure that you have identified and respected what you wanted to preserve, which is the sphincter region. So this has to be assessed, and then you proceed to the morcellation. For a good morcellation, first and foremost, proper hemostasis and visibility is key. Second one, the bladder has to be distended so that make sure your inflow is pretty good. And third thing is the blades have to be towards the center of the cavity so that the which can be achieved by dipping the scope relatively, and the bladder mucosa is not sucked into it, and the suction and the morsolator has to be working properly. If we face a scenario like Niramya showed with a fairly large median lobe, we can modify this technique and use a 3-lobe technique, wherein the principle remains the same. Instead of one incision, we make now a 5 and 7 o'clock grooves. Something what was being discussed with TURP also. Same thing, now make an incision at 5 o'clock, deepen it. You will come across the feeding vessels which can be very easily coagulated, and the adenoma can be devascularized, and make the distal and inverted U incision, that is the distal limit, and make a groove at 7 o'clock. And all you have to do is connect the grooves at 5 and 7 and making use of the plane which is already available there. So proceed from the Veru, connect the grooves at 5 and 7 systematically. One issue you might face is the cleavage plane might not be well defined in some areas, wherein you have to incise the connecting adenoma in between. That is one area which looks pretty uncomfortable, but yes, that is not the end of it, but it might take relatively longer time. Eventually you can just push it across. Make sure the ureteric orifice is always visualized and respected. To conclude, I would say the apprehension and skepticism for HOLEP has to be cleared, and I would feel that HOLEP is the best suited modality to ease the proper application of surgical principles of enucleation endoscopically. Methodical approach and perseverance is essential for any beginner to complete their learning curve of HOLEP. Thank you all for your patience.
Thank you, Sai, for a wonderful videos and explanation of the technique. But a lot of enthusiastic people are sitting here, want to learn HOLEP. The message is that you shouldn't venture into HOLEP with large glands. It is always said that HOLEP is for large glands. So there is a catch that most of the times you will be given a large gland for doing a HOLEP. Learning HOLEP means you have to start with a 40 to 60 gram gland. And the other thing is you must observe the mentors very carefully, because very nicely Taif said that you stay in the correct plane. And I have lot of people who come to me and I am standing behind them, and they usually and invariably miss the correct plane. Either they go deep or they go enter into the prostate. Both ways it becomes so troublesome. If you enter the prostate, it keeps bleeding, and if you go deep, it perforates. The moment you perforate, there is extravasation, and the anesthetist will tell you that patient's abdominal distension has taken place. Doctor, stop the procedure. So you get disheartened. Similarly, if you have entered the prostate, then it starts so much bleeding that again the operator is disheartened. So this is why the procedure has got a bad name and not bad name adopted. So my message to all of you is that do observe 5 to 10 cases with a good person like Taif and all operators, Rohit here, and many people now, more than 500 people are doing good HOLEP in India. So I think that that message should go.
A very quick, brief surgical point. See, whenever we do a 6 o'clock incision, it is always preferable to widen it across the ureteric orifice on both the sides. So if the orifice you see it is at 5 o'clock, you lateralize both the things, so that when last you are joining the incision, you don't need to take care of looking at the ureteric orifice all again. Second thing, in a large median lobe, rather than cutting both the side, it is preferable once you attain certain experience that you only cut at one groove and join with the other lobe, because with holmium cutting a lobe is a very difficult task. So your most of the time 20 minutes will be wasted in cutting a tissue because it doesn't cut well. It dissects well, it doesn't cut well. Thank you so much, Taif.
We appreciate holmium when you are in the plane.
Absolutely, yeah.
Yeah, excellent. And with this, I invite Dr. Tanuj Bhatia. And now the thing is thulium fiber enucleation of the prostate. And I am sure that Tanuj has good experience and will tell you how to start with flap.
Thank you, sir. For a change, I'll be talking about flap instead of HOLEP. It was a challenge for me also. But luckily, I do visit some centers where people have acquired thulium fiber laser. So I have some experience with thulium fiber, and I will just share that. So again, this is a beginner's guide with the flap. A lot of things will be similar to what Dr. Taif said. Yes, there is a learning curve with the enucleation. That's what we have been discussing. The learning curve is steep. That is why you need mentorship. You need to see some cases. You need to have someone at your center when you're doing the initial cases. You have to do at least 20 cases in a short duration to understand the correct plane, the correct technique. And the difficulties one faces are loss of plane, bleeding and hemostasis, the technique of proper morcellation, vision during morcellation, and risk of bladder injury. We know now that all the differences between the holmium YAG and thulium fiber laser. I will just skip this. These are the instruments we use routinely. The resectoscope sheath is the usual 26 French sheath that we use at our center. There is a 24 French available from Wolf. There is a 22 and 18 French available from RZ Medic, what is now referred as mini laser enucleation. They are easily available, so they prevent the extra cost and they enable continuous irrigation during the procedure, which is important for vision. So different types of working elements are available. One is a very inexpensive Gopinath & Co, which was developed by Vaishnav sir and the pioneers of HOLEP in India. And then these are the ones available from stores, Wolf, etc. Morcelloscopes also, earlier we had only from Karl stores. Now Wolf also has and the RZ also has. It attaches to the usual TURP sheath. It enables the passage of morcellator blade into the bladder after enucleation. Different types of morcellators available. Some are to and fro, some are different types. So they enable the cutting and sucking of enucleated prostate lobes. They are oscillatory or to and fro type, as I mentioned. So be it HOLEP or THUFLEP, ultimately it's a combination of enucleation and morcellation. So we should know which type of enucleation to do for which type of case. So the most commonly done technique is a 3-lobe technique, and I would, on the contrary to what Dr. Taif said, I generally encourage youngsters to start with 3-lobe technique because we are used to giving those bladder neck incisions during our TURP. So we know the 5 o'clock incision and the 7 o'clock incision. So I encourage to start with laser incision with 5 o'clock and 7 o'clock in your routine TURPs. Then you can do the median lobe enucleation, and then maybe the rest of it you can complete with TURP. So that's what we do in 3-lobe technique. We give incision at 5 o'clock, 7 o'clock, and 12 o'clock positions. Then we do retrograde enucleation of median lobe and the lateral lobes. It is used for larger prostates with large median lobes. 2-lobe technique is preferred for smaller prostates with smaller median lobe. You give incisions at 6 and 12 o'clock positions. And again, we enucleate the right and left lateral lobes. For en-bloc technique, the experienced surgeons, like I also prefer en-bloc for most of my cases now, but generally it is preferred for smaller prostates, and it is to be done after a certain level of expertise only. It is proven that the en-bloc and 2-lobe techniques are faster as compared to 3-lobe technique. So what is important to understand in enucleation is this differentiation, the demarcation between the capsule and the adenoma. Whatever is shiny and silverish is the capsule, and whatever is cotton wool like is the adenoma. If you know this differentiation, you know the plane that you have to get into, whether it is with thulium fiber or bipolar or holmium, and then you can do a good enucleation. This is just a simple animation of a 3-lobe technique. So after a cystoscopy, a 5 o'clock incision from bladder neck till the verumontanum. Then a 7 o'clock incision from bladder neck till verumontanum. And these two are joined in just proximal to the veru, and the median lobe is lifted. When we come back to the veru, we make a marking there anteriorly, which is our distalmost marking because there is no natural marking there. And then we give the 12 o'clock incision. It is preferred to give an antegrade incision as compared to retrograde, what is shown here. Then we release the apex from the sphincter all around at the level of veru, and then we start the lateral lobe enucleation. For that, we go below above, and we come from below above, and above below, and the two incisions join and in a sort of a U shape, and then we go about enucleating the adenoma on either side. For morcellation, already Dr. Taif has mentioned, excellent hemostasis is must. Bladder should be full. We should not hurry. It should be a slow and steady morcellation. Quickly, can you mute this, please? Yeah, thank you. So this is a THUFLEP which we did at Dr. Ayush Ketrapal's place just 4 days ago. So there's not a very large median lobe. It's a little faster video, but you will be able to catch the major steps. So nowadays, first we mark this just proximal to veru. We mark this place where the incision should stop, and it's also the best place to identify the capsule because there's not much tissue here. So this is done. Then we go to the bladder neck, and in the 5 o'clock groove, we start from bladder neck and we come till this particular point. We make an incision. Initially, it is a superficial incision, and then we deepen it till the capsule. Personally, with thulium fiber, I find a little challenging compared to holmium to see the capsule, but you will see it at those one or two places, and there will be a guide as to how much should be the depth. Then we make the 7 o'clock incision from bladder neck till the verumontanum. Again, we deepen it further. Once this is done, we connect these two incisions just proximal to veru. We already have the marking there. We connect it further, and that's how we start the enucleation of the median lobe. Of course, there's not a very large median lobe in this case, but because I was doing this at a center where we are starting enucleation, I always encourage to start with this technique so that one understands the technique, how to get into the right plane before venturing to the lateral lobes. So gradually the median lobe is lifted. We have to be more careful near the bladder neck because we can do undermining. Near the bladder neck, we prefer to go inside the bladder and make a J-shaped incision to come under the lobe so that you don't do the undermining. And if at any time you feel you're going deeper, just make it a little superficial plane so that you don't cause too much undermining. After this, we come back to veru. We make the 12 o'clock incision, and it is extended to bladder neck. This is also a retrograde incision, but this is me doing it. I don't recommend this for beginners. For beginners, should be from the bladder neck till this point. And then we do what is called as apical release. By doing this, we separate the adenoma from the sphincter. This is what has been found to decrease the stress incontinence, because during your enucleation, there won't be much stretch over the sphincter. So the incidence of stress incontinence comes down. So this is what is apical release. All around at the level of veru, we make the incision. Then with the same incision, we deepen it till the capsule. So after this point, you won't see as much charring as you were seeing during the incisions, because after this point, we are not that close to the target area. So we keep it a little away so that the laser dissects the adenoma from the capsule. So again, we go from below above and above below. And the two J-shaped incisions, they form a U-shaped incision. Then the lateral lobes are enucleated towards the bladder neck. Can you just forward it a little bit? You can come till here. Then the right lobe enucleation is begun. You can come towards the last 1/3 part. Maybe 5 minutes. Yeah. So same thing on right side, below above, above below. You can come towards the last part. Last, further ahead. Yeah. That's right. So there, no, just before that, please. Just before that, little more before that. I think, yeah. Mouse is. It's not working. Oh, sorry. So this.
Tanuj, while the video is going on, what are the major differences? You have been doing HOLE for such a long time.
Yes,
now
sir.
you are training people
That's
with thulium fiber enucleation. So what is the major difference which you want to tell the juniors that one has to?
So what I have seen, when we HOLEP surgeons try to do a through flip, we still try to be in that plane and keep a very nice, clean, white or at least yellowish plane. When beginners were starting directly with thulium fiber, they tend to cut through the tissue. They are not in the right plane generally, and that is why a lot of charring happens. So when we are very close to the tissue, then the charring happens. When we are at the right distance, the charring is less, the dissection is better, and that is what our aim should be, to do a good enucleation. Otherwise, we are just making a channel. So that is what we should aim for. Yes, sir.
Yeah.
Yes, sir.
Yeah, I think thulium is a very hemostatic tool. So you can cut anywhere like a butter. And therefore, the problem is that you may tend to leave tissue. So what Tanuj is saying, that despite using thulium, you must learn to stay in the correct plane. That would give a better outcome.
Almost like a holmium. Yes, sir. So,
there
the
is,
depth of
yeah.
penetration of thulium is less. Yes.
Yeah, one more catch here is whenever any beginner starts doing enucleation with two flap, there is in certain machines you can manipulate the pulse width.
Yes.
So you try it. There are three different ways of
Yes.
pulse width: the narrow and very high, and the small and very prolonged. So if you are using very small and prolonged pulse width, there will be too much charring because that is more kind of time the fiber is in the contact with the tissue. So use it very narrow and very high, so that it will be having almost a pulse laser. Second thing is the settings. So though the customized settings are the way RIRS we have supraphysiologic setting, the same thing is here. So whenever you are starting, you should start with a very minimal setting. Like if you can use 2/20 or 4/10, 40 watt is maximum you should use. More slow you go, more you can appreciate, because in thulium fiber, by the time you realize, you're always perforated.
Thank you, sir.
So many a times I am asked this question, that what is the difference in enucleation between with bipolar, thulium and holmium. So this is to understand that holmium is a dissecting laser. If you are in the right plane, you keep on dissecting, you will always stay in the right plane, tend to stay in the right plane. It will dissect out, and the best outcomes you get without using any force. On the contrary, with bipolar enucleation, it is a mechanical enucleation where without force, it would not enucleate. So therefore, in bipolar, you are enucleating with some degree of pressure and sealing the blood vessels, whatever gets opened up. And the third thing is in between. In between is the thulium fiber laser, where a judicious combination of force and dissection has to be applied to stay in the correct plane. So this is again a learning, and you have to master this art with whatever technology you are using. How much amount of pressure, how much amount of energy, and how much is the dissection. So that balance will come over a period of time when you use it.
Perfect. Thank you so much, Tanuj. Yeah,
you,
may I invite Debanga? Please come forward and tell us something about how you can get through, when you encounter a lot of bleeding in TURP. Over to you.
A very good afternoon to the respected chairpersons. So after two beautiful laser talks, I will be talking on how to control bleeding in TURP.
Very difficult to come back from HOLEP to flap to TURP. So it's a natural justice. So by the time this gets settled down, any questions we can take from floor?
Yeah, please go ahead.
Because we need to buy some time. Once you're through, we can take few questions if at all, or if it's.
Initial experience with the urgency and urgency incontinence after the HOLEP or flap.
Yeah, you would like to take the question, Taif?
Urgency and urge incontinence might not be too different as compared to HOLEP and the TURP. It depends basically on the amount of charging. It's relative appreciation by some of the practitioners that probably post flap or thulap, if the amount of charring of the tissue is more, and especially again that boils down to how much of cutting through the adenoma you have done, probably you might have more of irritated symptoms.
Stress incontinence.
Stress incontinence, again, multifactorial, can't be boiled down to only just one energy. So I think it is it's totally different topic.
Yeah. But believe me, it is transient.
It is
and
transient.
Not,
That is the most.
Over to you, Devanga. Thank you so much.
Yeah.
Ravi.
So bleeding in TURP, how to get out of the hole. So as we all know, it is the most commonly done surgery for prostate, and though minimally invasive, the most common risk is bleeding. Now we are using bipolar energies. With that, to some extent, we have reduced the incidence of bleeding, but the risk of bleeding is there always, whatever the energy source we are using. Now there are different types of bleeding that happens in TURP. It can be intraoperative, postoperative, immediate or delayed, primary, secondary, and tertiary. Here we will be concerned about intraoperative only. So what are the factors that basically relates to bleeding in TURP? It's the size of the prostate, the weight of the prostate, the surgeon's experience is important. Preoperative catheterization is doubtful. Use of anticoagulant or antiplatelet drugs that increases the chances of bleeding, though we stop it. 5-alpha reductase reduces the chances of bleeding by decreasing the microvessel density, and the use of newer technologies like bipolar that helps in reducing the bleeding. So what are the different types of bleeding that happens in TURP? It's usually the arterial, the venous, and the bleeding that happens after capsular perforation. So in arterial bleeding, what are the things that we should always take care of? So whenever there is an arterial bleed, we shouldn't move our resection away from the bladder until and unless it is controlled. It is always characterized by a pulsatile and dark red color, bright red color bleeding. So what are the steps that we take? We should slow the resection over the areas of arterial bleeding in the hope that in the next swab it will be coagulated. If it doesn't work, if the bleeder is very big, we should place the loop over the bleeder to create a tamponade effect, and then press the bleeder coagulation pedal, and does coagulating the bleeder. Now, if sometimes what happens if we do a resection, the bleeder retracts. So we have to we have to cut the tissue up to the surgical capsule so that we can pinpoint coagulate the bleeder. Now, haphazard coagulation should be discouraged as delayed it may lead to secondary hemorrhage because of sloughing of tissues later on. Sometimes the bleeders cannot be found. Then what we should do? We should look at the anterior wall or the opposite wall, which is known as the ricochet bleeder. We should be concerned about. There are small clips that I have collected. So this is the first video which is showing here. I'm using a bipolar technology by which definitely the amount of bleeding is less, as it is doing both coagulation as well as cutting at the same time. Then how the typical arterial bleeder looks like? It's very simple. It will be a pulsatile bleeder that will be there with bright red color bleeding is happening, and just the surface coagulation or point coagulation will stop it. Next is when there is a bleeding inside the tissue and we get a bleeder in between, then what we do? We usually resect the tissues in and around the bleeder. The tissues which are around the bleeder, we should resect it. Then we manipulate our loop just over the tissues where bleeder is there, and we reduce the speed of the resection to some extent so that it gets coagulated in the next one. Now, whenever we encounter a bleeder, which is a very big bleeder, what to do? Here, what I'm doing is I'm putting the loop just over the bleeder, creating a tamponade effect, and then just pressing the pedal, and thus controlling the bleeder. Next is the same. I am using a monopolar loop here. The amount of current, the sloughing is more in compared to bipolar. The previous one was a bipolar one. Creating a tamponade. And thus the bleeding stops. So this is another way. Now, when we sometimes resect and the bleeder gets retracted inside the tissues, what we do is that, as I have told you, we resect it up to the surgical capsule and pinpoint the bleeder there. So here the bleeding is happening. So we have resected up to the surgical capsule and it stopped. Now coming to the venous bleeding, how to deal? Venous bleeding is always characterized by off-screen bleeding, which is dark in color. and it is temporarily stopped because of the hydrostatic pressure that is present, that is because of the full bladder and because of the irrigation that we are using during the resection. And venous bleeding which happens in and around the bladder neck can be facilitated or facilitated by reducing the bladder volume. So how we coagulate it? We have to do small bouts of surface coagulation only. It cannot, sometimes the venous bleeding cannot be controlled completely. So what to do? We have to start irrigation and we have to give traction because it cannot be, may not be controlled with coagulation. So this is how the venous oozing is seen when I have reduced the bladder volume or emptied the bladder. It will be dark red, and when we go near the prostatic fossa, there is nothing, but when we come out of it, there will be oozing. So how to control it? We cannot control it, but we have to look for certain areas where we can do a surface coagulation if it is possible. But haphazard coagulation should be always are always discouraged in venous bleeding. Venous bleeding in and around the bladder neck can be facilitated by reducing the volume. This is what I did here, and coagulated the bleeder which was there in and around the bladder neck. Next, how to deal with capsular perforation, that the bleeding that happens after capsular perforation. Mostly the capsular perforation, the bleeding happens because of the injury to the venous sinusoids. So aggressive coagulation of these venous sinusoids should be always avoided because it may lead to increase in the capsular perforation or aggravate the capsular perforation. The most important thing is that there are certain bleeders which are present in the edge of the capsule. So that has arterial bleeders that has to be taken care. And for the venous oozing, we have to give traction and irrigation. So this is a small video where a capsular perforation will happen, and the bleeder that was present in the edge, the arterial bleeder, is taken care of. We have to take care of those bleeders, and small bouts of surface coagulation can be done with care, with caution over the capsular tear. This is another capsular perforation where there was no arterial bleeder in the edge, so we avoided any coagulation. Now, one important thing is the bladder neck bleeders. These can be troublesome sometimes because it usually retract inside the bladder along with the mucosa. So meticulous point coagulation should be done, and that should be done after emptying the bladder. So this is a video which is showing the where meticulous coagulation, point coagulation of the bladder neck bleeders have been done. Now next is hemostasis of the fossa. It should be always done after whatever hemostasis we have done, and it has to be done in a systematic manner. Start with the bladder neck, then to the roof, then the apical region, then the floors, and then the lateral walls. It will we should always look for any arterial bleeder that is present, and it is always better to use a ruler ball. So this is a small video I will not show. Next is the traction. In case of venous bleeding, we have to give traction as I am doing here. So there is some amount of venous oozing is there. So I have filled with 10 cc, then 10 cc of saline, then I have pulled it into the fossa, then I'm increasing the volume. So there is change in the color of the effluent.
Can we skip to questions now? Yeah,
Okay,
because we are already through. Yeah, one question is there is significant of venous bleeding. It's not getting controlled naturally. So if you are just through one lobe, what would you do next? Somebody encounters such problem. What would you do next? So there is only one lobe been done. The other lobe is entirely pending, and there is a diffuse venous oozing. So what would you do?
If there is diffuse venous oozing, first I will look for whether I can control it with
It's not controllable. Yeah,
it's not controlled.
Yeah.
If it is venous sinusoid is in if there is injury to the venous sinusoid, there is capsular perforation, so it's better to avoid the procedure for that.
Have you ever tried various times in laser also we do, but in laser what we do is we reach first rather than TURP where you reach last. So in the initial part, when it happens, there is a way out that we can do a traction, keep it for 5-7 minutes, and then you go back in manual time, the things get settled down. So we can try that also.
Thank you.
Yes, please.
Yeah, KP.
Have you finished?
No, sir. In the neck, sir. Neck.
Bladder neck, yeah. But the one thing which I observed was number one, he was using two-way catheter with a feeding tube.
Yeah,
Is this a routine practice
This is
from
the
your
routine
end?
practice that we do in our
Okay. Second thing, what he observed, what is the fundamental of that? What is the concept?
The only fundamental is that the
Three-way is not available?
Three-way is available, but the NS, the flow is good. Flow is good.
Fine.
Channel is better.
One more thing, what KP observed and I also observed was that, we have to probably inflate it 10, 15 ml, then you put it on traction and then you kept on
No,
inflating.
I have just pulled up to the bladder neck. Yes.
Perfect. Thank you so much, Demaga. Lovely talk. I think that concludes the session. Abhi, we are always running short. I understand you give me signals. So thank you so much and kudos to all the presenters for fantastic presentation. It will take a lot of take-home messages for all the young generation.
Yeah, I think thank you everyone and good presentations by each one of them. Thank you organizers for giving us the opportunity. Thank you.
Thank you, sir. Moving ahead, we go on to the session of ergonomics. Ergonomics is something that will help you pass your career. To moderate the session, may I call upon Dr. Rasmika Joshi, Dr. Ankit Vaishnav, and Dr. Rupesh Shah.
Yeah, good afternoon, everyone. Without wasting much time, we'll straightforward to move. I must congratulate Dr. Abhishek for innovative topics that ergonomics is quite important. There are two aspects. One is for patient aspect and one is for surgeon's aspect also. Otherwise, at your 50s, your back and cervical spine will also cry. So let's listen the expert. I invite Dr. Padmakar Singh for the ergonomics in laparoscopic surgery.
Thank you very much. Thank you to the organizing team for giving this opportunity. Ergonomics in laparoscopy is very important. With every advancement, there is always some drawbacks. So laparoscopy is no exception to it. Drawbacks are majorly in twofold. First, the scenario, the surgeon experiences the ill effect of the surgery. And secondly, the patient is the victim. They start thinking laparoscopy is not our forte. We are getting 4 or 5 cases. Let's just move on. Don't do, because it's very fatigue is too much. So the problem faced by surgeon, carpal tunnel syndrome, eye strain, as just now said, cervical spondylosis is very common even in younger age group. There is reports of thinner neuropathy with this pistol kind of grips. And how to be more efficient and comfortable? The answer is good ergonomics. So definition, as we all know, it's a Greek word derived from ergon and nomos, meaning work and the natural law of it. So ergonomics is nothing, it's a process of designing and arranging the workplace products and systems so that they fit the people who use them. It's not other way around. We should not adjust to the equipment should adjust to us. So it's ergonomics is not only in operation theater, everywhere it's important, like in our day-to-day activity also. So what are the drawbacks in laparoscopy? It is just a two-dimensional image. There is no depth perception, no tactile feedback, and the instruments are counterintuitive, only 4 degrees of movement, and the field of view is controlled by the assistant. So ergonomics was not so important in open surgery as many of the principles came naturally, but in laparoscopy it's quite essential. So I'll discuss only three of the topics in this: OT equipment, surgical posture, and port placement. So OT equipments, all the pictures are from my OT only, so please bear with the rawness of it. So the two types of table are most commonly used. The first one is the urology or the orthopedic table, wherein the pillar is at the head end of the table. So the problem with this table is that this is made for the C-arm movement, and laparoscopy, especially the pelvic surgeries, are not good suited for this. For that, we need the second OT table, wherein the center pillar is in the middle of the table. The problem, what happens, when we lift or when we make the head low position, the pelvis rises, and there is a very awkward position for the surgeon to operate in, especially the pelvic surgeries. So fix for this is we can just rotate the OT table 180 degree and then use it so that when we put head low, the pelvis won't rise, and you can still operate and manage on that table also. Other thing, the height of the table. So normally the OT tables that we have, that goes to 3 feet height. But what we need is even lower height. So how to adjust, either buy a table which goes lower down, or we can use a platform to operate so that our hands are comfortably placed and we can operate without any difficulty. So a platform, this is very important equipment. I feel this is one of the most important thing to correct our ergonomics. So it should, the important thing is that it should be of a large size wherein you can stand, move around comfortably. It should not be a very small platform, and wherein you can keep your foot paddles and easily move around. For this also, in one of my OT, what we have done, this was the laser that the box that laser came in, and the cover of that we are using as a platform. It's a huge platform, so at least 2 people can stand comfortably on it for all the lap surgeries. Now the trolley part, again, this is also very important. If again we should get this type of advanced trolley, but normally what we get is Indian trolley of this type, where the monitor is placed quite high up. Like you see in this is the worst kind of positioning that we can have. The monitor is almost 6 feet height or even more, and operating on this is very difficult. So for this, what fix I have been using is a ergotron monitor arm. So I've removed the what company provides monitor arm. I have placed it on this ergotron monitor arm. So how does this help? So in this video, you can move the monitor as in wherever you want comfortably. You can bring it down. You can even bring it lower for your laparoscopic surgeries, and you can move it to one side at the patient top, wherein you can see, like in all your urology surgery like TURP, HOLEP or anything, you can place the monitor comfortably. The neck is straight. You don't need to move your neck or flex or extend your neck. Again, same monitor placement in laparoscopy. You have a proper gaze down view, and the surgeon, target organ, and the camera. This is coaxial alignment. All those 3 things should be in straight line. And as you can see in this picture, everything is in front of my eye. The cautery is in front of it. The insufflator is at the patient height. Nothing should come from behind. Many times in the OT setup, we have cautery coming from from behind. It should not happen. Again, this is another picture where the distance from the eyesight to the monitor. See here, it should be 5 times the diagonal length of the screen. So, and see the posture of the surgeon. See how the posture is. He's extending his neck forward. So this is our natural reflex. When we try to concentrate on something, we'll bring our neck forward. So this should not be done. So these are the bad postures we acquire while doing this one. We'll extend our neck, we'll look down, we'll look one side, and all these maneuvers we'll do. We know that the screen is 2-dimensional. How much ever we bend, we will not be able to see anything extra. So we should learn to instruct our camera person to slow down, not to look down. And this kind of posture should always be avoided. Again, foot. So when you are standing, normally one leg is using the foot paddles. So what happens, all time the weight is on one leg and the knee is always locked. So that also is a problem. To fix that, what we can do, we should change our leg if possible, if we are used to it. Otherwise, what I do, I normally remove my footwear and I just use my great toe, as you can see in this picture. I don't think this is to activate my cautery, and I balance my weight on both the legs. Port placement. Again, all these are common things: triangulation, coaxial alignment, manipulation, and elevation, and azimuth angle. So baseball diamond concept has to be followed. In this, this instrument should be half in, half out. They should behave as type 1 liver. This is very important. So landmarks for port placement is not very correct. What we say, this should be done here and there. So it should it should be according to the patient, not according to the fixed landmarks. So elevation angle is around, this is the angle between the horizontal and the instrument. So it should be around 45 to 60 degrees. Second principle, this is azimuth angle between the optical instrument and the working port. It should be around 30 degree, can vary from 15 to 45. So this is one pelvic surgery. I visited INU there. I have taken this picture. So very nice ergonomic arrangement where sir is standing at the head end of the patient. And this can only be done in short length patient where the height of the patient is less. So he's standing at the head end and operating everywhere. See, the neck is normally placed all the principles are properly used. So how to maintain the manipulation angle? So this should between the two working instrument, it should be around 60 degree, that is plus minus 15 degrees permissible. So port position is not fixed. This is important. See, this is port position for pyeloplasty. All the 3 ports in a thin patient, it's almost at the level of just above the level of umbilicus. For a mid-sized patient, same ports, they are at the pararectal line. But for a morbidly obese patient of this type, the ports are quite lateral. So we cannot say that landmarks of port position can be fixed. It should vary according to the patient size. Just finishing last few. So again, many times sectoring is done. This also should only be done by experts who are good at laparoscopy, that camera is placed. And then grip position. Again, this is better. The thumb should be outside, and so that the fatigue is not there. You should place your thumb outside the grip. It should not be inside the pistol grip. For pen style grip can be used for instrument like hook and suction, wherein your wrist is normally placed. For this needle holders, always when you are starting your suturing needle holders, when you are holding the needle, you should ask to lower down the table again, because for suturing you need height to be even lower. Done. But if you want best ergonomics, please buy a robot. Yeah. Thank you. Very nice.
Yeah.
I would like to invite Dr. Parimal Gharia sir on his talk about flexible laparoscopy and ergonomics, how important it is.
I disclose no conflict of interest. Ergonomic is study of a workplace design. Goal is to maximize the efficiency, quality, and the quantity of the work, and minimizing the work-related musculoskeletal disorders, fatigue, and overexertion. RIRS is very demanding surgery because we tend to operate for a longer period of time. We are standing in a static position for a very long period of time compared to a PCNL where you are moving here and there. You are mobile in a PCNL, whereas in RIRS you are standing in a one position. There is a repeated action of stepping on a foot pedals. You put a you activated a laser for one period of, you are standing on a one hand, one leg. There is a continuous strain on the muscles of the wrist as well as the thumb while holding the scope, and we all have to wear a heavy protective gloves. And now the fans requiring repeated in and out movements, that is adding the stress to what we have already been undergone. So pain in urology is very common. Almost 60 to 90% urologists have a pain during their lifetime. Almost 80% of respondents of this survey had a pain in last 1 year, and it is repeated. It is occurring monthly, weekly, and the most common pain is at the neck, back, and shoulders. And in this paper, the most endourologists had a problems or orthopedic back problem, neck problem. So the ergonomics for an endourologist or a laparoscopy surgery was already bad, and now with all the we have the workplace which is designed not for us. We are working in many places where that is not is working in our favor. So this adds to more difficulties. What happens is we get fatigue, we get decrease the performance, our quality of surgery decreases, and ultimately burnout. And ultimately over a period of time, when you are having a subspecialty work or a single type of work, you tend to decrease your working hours, you tend to decrease the cases, and ultimately you will lose an economical loss also. So what are the at risk populations? Early learners or the residents who are in an early phase of their career, try to drive a car. Like when we are learning the car, we have a stiff grip, and that is a cause of a early fatigue. And when you are subspecialty or you specialize in a work, you are more work concentrated to one specific surgery, you get to that specific surgery related problems. So ergonomics is what? It is OR design and arrangements, a procedure that is RIRS, and a working person is a urologist. It all has to harmonize and it has to be optimized to work in favor of urologist. So this is the OR setup. You can see this is the OR setup for all right or left cases. I put my C-arm on the right side of the patient's. Irrigation stand is in the left side. Surgeon is standing at the end. The trolley, there are two trolleys. One trolley is behind, for a smaller trolley is just beside this, and there is a laser. So this is the working environment. What is seen. Now we have a two type of screen. One is a mobile screen or a pendant dependent. If that is available, you can see just in front of your, keep in front of eyes. You have a 0-degree view to this, but most of the OR has a trolley, so it is on the side. So in that case, your trolley should be mobilized. You have to keep your screen at certain angles where you are standing. So most of the righty persons can have a right side open, and you can keep a trolley on the right side, left side of the patient. So you are seeing directly to 0-degree to the trolley. Surgeon's positions. My colleague is doing RIRS in a sitting position. He is comfortable doing in RIRS in sitting position. If you are a longer surgery, steady hands, and you want to do a surgery, sitting is a better posture than the standing position. But if you are in a standing position, you have to keep your screen and your position directly 0-degree. No rotation of the neck and no rotation of the body should happen while looking at the screen. Monitor level should be either in the eye level or below the 15-degree. The distance is, Dr. Sabnis sir has written a paper that it should be a 5 times the diagonal dimension of the screen. So your working distance depends on the screen size. If you have a bigger screen size, you can keep it at a distance. The height of operating table. You can see two things happening in there. In this case, the height of the table is more. So the scope is going down, and then it is coming up. So the movement are not corresponding. You try to force it there. So your scope should be like this. Your scope should be in alignment of the seat, and your left hand, a non-dominant hand, working at the seat. You can keep extensions in the irrigation system so that your assistant does not come in between the pictures and you are getting trouble by looking here and there. Assistant position. If you have a single assistant, I keep it on the right side. If I have two assistant, I keep one assistant for irrigation on the left side of the patient. That assistant is outside the leg. That is outside the lithotomy position. Foot pedals. Your foot pedal should be in ergonomic position. Your foot should not be extending or having an outer rotation. It should be a neutral position. Try to loosen up your grip. Just two sides. Grip of the scope is important. Finger grip is more important, is more relaxing than the
ergonomics. Yeah.
The grip should be finger grip. The shoulder should be at the relaxed position. It should have, the arm should have slightly inward rotation, wrist slightly extended, and the elbow is flexed at 40 to 60 degree. The non-dominant hand should hold the other end of the scope for a mobilization, and the dominant hand use the scopes. Shoulder position should be neutral.
I think you can summarize the extra point what you wanted to highlight.
Another thing is wearing a apron. We all wear a lead apron. The lead apron should be tightly fitted and it should be tightly strapped around your waist so that your shoulder gets free. It should not be hanging on your shoulders, because once the lead apron is hanging on your shoulders, whenever you do try to movement of your flexible ureteroscope or extend your, you use shoulder muscle so much that after a 15-20 minutes you get fatigue. So the tight fitting apron is very important in this case. There are two types of apron. One is a skirt and shirt type, and another is a full length. I use all full length, but it is preferable to have a skirt type and a shoulder so that all the weight doesn't fall onto your only shoulders, and it can go down to your waist also. Material wise, there are 25 mm, 35 mm, and 0.5 mm lead aprons are available. But for a safety reasons, you have to wear a 50 mm only, because these are you are standing very near to a C-arm, so all the X-rays are coming from down. So you need to wear a proper full thickness gown. Your assistant can have a slightly thinner gowns, but not you. If you have availability of that, it should be it is very useful for that.
Ties back. Yeah, that doesn't.
So that is
straps.
Yes.
Straps on the back. You can put. Can we have presentation?
Just one slide.
Yeah.
Concluding slide. One thing I need to mention is the newer scope, which are the digital scope, does not have a camera attachment, so they are lightweight. So your scope choice should be digital if possible. Single-use scopes are lightweight, and sometimes the deflection mechanism also comes into play. The intuitive is more helpful. So ultimately, you have to devise your OT according to your height, your preferences, and your available equipment. If it is optimized, your overall strain is decreased. Thank you.
Thank you very much.
Hello. After this excellent talk, I would like to invite Dr. Shashank Dhanuka for his talk on ergonomics for percutaneous surgery.
Good afternoon, everyone. Please sit with your back straight. Pull back your shoulders and retract your scapulae. Thank you very much. So we've been talking about ergonomics in endourology. The previous two speakers have covered a lot of relevant points related to both laparoscopic surgery as well as RIRS. So the points are very much similar in percutaneous surgery as well. But in the end, I'll be emphasizing on one more additional thing. So there are various definitions of ergonomics. A science concerned with designing and arranging things people use so that the people and things interact most efficiently and safely. Efficiency and safety are the two things that we're looking at when we're talking about ergonomics. So about the survey that Dr. Parimal was talking about, I have some graphics related to that. In the US, urologists who've experienced work-related pain, 90% have. And more than once a week, about 32%. The most important problem areas, as he highlighted, 70% have problem in the neck, 66% over the back, and 48% over the shoulders. So please sit straight. Over the long term, degenerative lumbar spine disease and cervical spine disease, about 20% and 17% among urologists. And most of them have attributed an awkward position in the operating room to be the main reason for this. So have you ever received training in ergonomics? 83% said no in the US. So thanks to Youth Urology that we have a session dedicated to this to increase awareness across all age groups, whether it's the younger urologists or whether it's the youngest urologist sitting in the first row. So there are very few papers related to ergonomics in urology. This is one of the important papers that serves as a practical guide. For the PCNL surgeon, the ergonomic obstacles include prolonged standing and static positioning, disruption of the visual motor axis with the use of a monitor, abnormal weight bearing while activating the foot pedals with lead apron on, and challenges with maintaining a neutral upper extremity body position while operating the endoscopic equipment. So the operating room, PCNL operating room is always a very crowded space with a lot of equipment, and it can cause a lot of challenges in how we plan the things, how we set the things around us, and still maintain good ergonomics for our body. So first of all, the operating room design has to be a combined civil, mechanical, electrical, electronic, and biomedical effort. So from the very beginning, the operating room itself has to be of an appropriate size. The minimum that should be, the minimum dimensions should be about 6 by 6 by 3 meters. This is from the Smith's textbook of endourology. And the recommended ones are at least 7 by 7 by 3.5. The equipment booms or the trolleys that we use for the equipment, the ceiling mounted ones are much more recommendable. They reduce clutter, free up floor space, and allow more ergonomic placement of the display monitors. C-arm happens to be a very important component of PCNL, at least for the fluoroscopy guided puncture PCNLs. So the working space limitations created by the C-arm becomes a big hindrance and causes ergonomic challenges for the PCNL surgeon. The flat panel detector C-arms give some relief in terms of ergonomics because they increase the working space between the patient's surface and the image intensifier. They allow better maneuvering of the nephroscope, especially when you're dealing with posterior calyces in the upper pole or in the lower pole. And they also allow more field of view for the display monitor when sometimes you want both the endoscopic view as well as the fluoroscopic view. Monitor positioning has already been talked about by the previous two speakers. I just re-emphasize that it should be kept at or slightly below the eye level to prevent neck strain and maintain a natural line of sight. So either you use ceiling mounted monitor stands or one of the attachments that the first speaker mentioned about. This would greatly help, and your neck should not be extended or craning forwards while operating. The distance of about 80 to 120 centimeters has been recommended in various studies. So this is the image which emphasizes about the position of the neck. You should not be craning forwards a lot like you do when you're looking at your mobile phones. The neck flexion should be less than 25 degrees. The height of the table should be about 80% of the elbow height or somewhere around the pubic symphysis of the surgeon. So it is very important that the patient should also be positioned at the edge of the table towards the surgeon, thus reducing the need to lean over the table. And the X-ray generator of the C-arm, which is at the bottom of the table, sometimes becomes a limitation for how far low you can go with the table. So in that case, the simple platform or step tool should definitely be used even during PCNLs to make sure that everything is of optimum height. Lead apron, just been discussed. It has been estimated that a 15-pound lead apron can exert a load of 300 pounds per square inch on the intervertebral discs. So utilizing a two-piece apron, which allows for greater support of the apron's weight on the pelvic brim, is recommended. Stretching your back before or after surgery should be routine practice for every PCNL surgeon. So I cannot emphasize enough that regular exercise and stretching after PCNL surgery should become a routine practice for each one of us. I've got a couple of stretching exercises that I would like to share.
Healing thoracic extension stretch. This is what it looks like, right? So that's the starting position. And now what I want you to do is
this
just
is a very
sit back
simple
onto your heels.
stretch
Your
that you
elbows
can
are
do
going to come up. You're going to feel a really good stretch all
along
through your
any
lats
couch
right here.
to stretch
As
your
you
back.
sink down deeper into that stretch, repeat that about 5 times. Next, let me get into this position.
And
So
this
I'm palming
thoracic
in, my left
rotation
foot
stretch
out in
is
front of me,
very,
my right
very
knee's on the
relevant
ground. I'm
for
gonna
every
take my right
PCNL
hip on the
surgeon.
ground, or excuse me, against the wall.
You
and I'm
can
gonna
do
keep my
it
right shoulder against the wall as
with
well.
the support
What I wanna do
of
is get
any
into this
wall. So you just align one side of your flank along the wall and make a stretch. Do this on the opposite side. Please make sure that this becomes a regular practice. You can choose your own stretches, but we have to make sure that we last long enough in these challenging ergonomic surgeries. Some alternative approaches in the world of PCNL. So supine PCNL allows a more lateral entry. So it allows for a seated position and thus reduces the strain on the back as well as on the legs, and a USG guided puncture alleviates the need for a CM and its associated ergonomic limitations, including obstruction of the visual field and the need for a lead apron altogether. I was surprised when I visited Renji Hospital in Shanghai. Their PCNL operation theater did not have a CM at all. So no CM monitors, no CM at all. It was a completely USG guided system that they were following. So if one gets used to that, that alleviates a lot of problems associated with CM usage. So I conclude with endoscopic urology is minimally invasive for patients, but it can be maximally burdensome to urologists from an ergonomic standpoint. So make sure you take care of your back and make sure you take care of your postures and your equipments. Thank you very much.
I would like to, for next speaker, I would like to call Dr. Shrikant Jay, perineal surgery, ergonomic considerations.
Good evening, everyone. I'd like to thank my speakers who have came before me. They have made my job pretty easy for this. So myself, Dr. Shrikant, I'll be speaking on perineal economics on perineal surgery. So I'll be speaking on work-related musculoskeletal disorders, what has been talked about before, the prevalence, what is actually ergonomics is, and the ergonomical considerations of a perineal surgery, and it will be dealt in following topics, and then finally a conclusion. So work-related musculoskeletal disorder is basically musculoskeletal disorder in which the work environment or the performance of work contributes significantly to the disorders. It is divided into 3 stages where the symptoms relief after working hours, where the symptoms persist overnight after the day's work, or when the symptoms persist for rest at the rest and interferes with sleep and persist over months. So the prevalence of this disorder is very high in vaginal surgeries. It can be 54 to 87%. There's no particular data on male perineal surgeries, but yes, as we all know, the injuries are underreported by the surgeons. So to prevent these musculoskeletal disorders, it has been advised to take into consideration these 7 activities should be avoided. Repetitive movements, prolonged exertion of more than 30% of operative strength, body posture held in an extreme position, prolonged static positions, activities within vibrating tools, exposure to cold, or a combination of this. Now let's see what happens during a surgery. Small repetitive actions are must, and as seen in a difficult dissections, someone has to hold a retractor with all his strength. All the positions of the surgical positions are designed for with the patient safeties. You have to be static. Surgery cannot be done on a go. Now the ergonomics. The ergonomics is a discipline which deals with design of systems and devices to fit in the people. The concept of designing the work environment to fit the worker instead of forcing the worker to fit the environment. Now this can be true in industries, but not in surgery. In hospital, systems are already in place. You'll hardly ever find an OR designed only for a perineal surgery. You as a surgeon needs to fit in so that you remain uninjured. So being a urologist, the most common perineal surgery is urethroplasty. And there's a very little literature on ergonomics that is involved in urethroplasty. The following data is an extrapolation of all the studies done by gynecologists for the vaginal surgeries. All the ergonomics that we will be discussing will be for the urethroplasties. The correct equipments. So we'll be talking in further, talking much more in details on these topics. Correct glove size. Now, a smaller glove size can cause early fatigue and pain. A larger glove size carries a risk of damage because of the instruments. Now, the glove size changes with our company also. For Ansel, I prefer using a 7 size glove, button, micro optic, powder free glove. I prefer a 7.5. So this is not actually what is a written in stone, but yes, we have to follow what is comfortable for us. A plastic apron, it is a very cheap, reusable, available on Amazon, protects from spillage of urine and blood, keeps up warm and dry. Boots, these boots should be comfortable, well-footed, and waterproof. It is absolutely essential that they should be comfortable. Now, these kind of stools are like ideal stools. The height can be adjusted. There is a back support. They are small enough so that a second stool can be adjusted for an assistant. A good operative table, the height can be adjusted. The consideration must be given how low the table gets. A reverse tendon position should be is possible. There should be room available for a bucket there. If such extension is there on this side and the bucket is placed here to collect the blood and the blood and urine, the surgeon will be sitting far away, and it will be not ergonomic position for that. Stirrups, they are a bit expensive but very convenient, can help in changing positions intraoperatively. Now, what is an actual OR setup? Patient is in a lithotomy position, surgeon is sitting at the foot end, OT light is behind. So OT light comes from behind the right side shoulder. There is a patient card instrument trolley here. The scrub nurse stands on the right side of the patient. Then the assistant sits on the right side of the patient below the left side, left leg. We'll be discussing all these positions in a bit more detail. Now, adjusting the height of the table. The height of the table should be adjusted so that the neck flexion of the surgeon should not be more than 20 degrees. If a very low height will cause more neck flexion and strain, a very high table will cause more vertical extension, flexion of the shoulders and fatigue. Using a reverse tendon bed position of 15 to 20 degrees, especially while doing a posterior urethral dissection, is very helpful. Okay. The surgeon position, surgeon is always seated on a stool. The height of the stool should be adjusted so that his knees and hips are at 90-degree flexion. Both feet are comfortably placed. The surgeon sits in a square to the perineum. He's close to the operative side so that he doesn't extend his arms. The trunk should be straight without any twist. Slightly off center so that the assistant can have an access to the operative side. Assistant is also seated to the right side of the surgeon, just under the left leg. There should not be any twist in the assistant trunk. He is slightly facing towards the surgeon. The cautery and the section pedals should be placed right in front of the foot so that the pedal is reached without extending the legs. Light source, as I have already told, it should be on the right side of the shoulder. A headlamp can be used, but it adds to the weight and it can in the long run can cause straining of the neck. By using ceiling lights, the care should be taken that the light does not shine on the spectacles, which will cause glare and eye fatigue. The instrument trolley is usually kept between the surgeon and the scrub nurse, which is just below the right leg of the patient. Both surgeon and nurse has an access to the trolley. The scrub nurse should never be behind the surgeon, always be on the patient's right side. Table should be at the waist height of the nurse. The platform can be used if the table is very high for the scrub nurse. Now, the limited work space is a barrier for maintaining neutral positions while doing perineal surgeries. The assistant will have to twist his trunk, or a nurse will have to lean over the patient leg, especially while retracting. Using a self-retaining retractors as a Turner Warwick or Lone Star retractor are very helpful.
Dr. Can you just summarize?
Yeah, just last slide. So micro stretches, this has been given in the Mayo guidelines. To conclude, a neutral position should be maintained. We have to listen to our body. If there is any pain and stress, it means something is wrong that has to be addressed. A strong musculoskeletal system is able to withstand the stress of the surgery. The regular strength training exercise should be done, and stretching is also equally important. Thank you so much.
Thank you very much. Now may I invite Dr. Akshay Kriplani for his talk, long duration of open surgical procedure using the magnifying loop.
Good afternoon. I am Dr. Akshay Kriplani, and today I'll be talking on how in long duration surgeries, using the magnifying loops, we can protect our body by adopting correct ergonomics. So I think by now, after 3 lectures, we know that ergonomics is everything about the surrounding structures being there, and we have to cater to the surrounding structure for a proper posture and a long career. So ergonomic is basically fitting the job to the worker, and in our case, being surgeons, how human and inhuman activities around us are to be fitted for us. Now, all our OTs are being designed accordingly, the proper ergonomic way. But coming to the using in microsurgeries, using magnifying loops, the problem of these work-related musculoskeletal disorders come into play, because when you are using loops, the field of vision and the depth of vision is so limited that the surrounding structure is not seen, and you use the awkward positions. Because of this, we end up having these muscular-related discomforts, causing a lot of pain, and it is well documented in literature that these microsurgeries are having significant pain, although comparatively less in, compared to the laparoscopic surgeries. Pain in back, shoulders, fatigue, numbness, very well documented in literature, even in severe cases leading to degenerative spine disease. We know that after 4 talks, we know that these leads to missed work and fewer operations by the surgeons, leading to a short career span. Even some people have resorted to changing their jobs and even specialities because of the severe burnouts, the emotional exhaustion, lack of sense of personal accomplishment, and also resorted to early retirements. We know by now that a survey in the US has reported that urologists are the maximum burnout specialty compared to the other specialties, with 90% of urologists experiencing work-related pain, and not even 83% are aware of their proper ergonomics. So the problem with loops, coming back to the topic, is this fixed forward head posture and this bad neck posture with a hyperflexion of the spine and the rounded shoulder. This causes the back muscles to be in severe spasm and tension, causing altered movements of the scapula, leading to shoulder impingement. It is known that when a neck is flexed, and increasing degrees of neck flexion increases the apparent weight of the head on the spine, leading to muscle spasms, causing severe neck pains and even degenerative spine disorders. So how can we prevent them? So the whole idea is reduce the operative time, thereby reducing the amount of time which you are wearing the loops on. So basically a proper planning, meaning thereby proper planning of the steps, proper planning of the equipment needed. All the people in the OR know their job, thereby the surgery is quicker and shorter. Like in sports and musicians, it is documented that a proper warm-up before surgeries might help in reducing the neck spasms and the strains. So this is the crux of the matter. Ergonomic principles. A neutral position of the elbow. Neutral position of the elbow, the shoulders, the back. The muscles in these positions are resting and in the minimum stress, and the joints are naturally aligned and has maximum controls and force productions. Whereas any deviation from these postures is called as the awkward posture, where the muscles are contracted and elongated. In fact, there is a self-assessment formula called as the upper limb assessment, in which any deviation in the angle between the neutral positions, a score is given for every joint, wrist, upper arm, the elbows and shoulders, and eventually this score, the higher the score, total score, the poorer posture you are into, and it breeds immediate changes. In fact, these are the ideal recommendations that for a neck, neck flexion should not be more than 10 degrees. The wrist deviations should not be more than 15 degrees. The shoulder and the upper arms should be not more than 45 degrees away, and the elbows should not be around, should be maximum 60 to 100 degrees from the neutral position. So a continuous static position of the neck will cause spasms, and therefore it is recommended that you should have frequent movements of the neck. So if you have a proper exposure, if you have proper lighting, all the instruments are set, your musculoskeletal alignment will be proper and you will not fidget during the surgeries. These frequent movements will avoid neck spasms. You stand close to the OT table so as to avoid bending, and you will be surprised how much a good arm support can reduce the neck spasms, the shoulder spasms, and the elbow spasms. And this has been documented in experimental studies. Take intraoperative breaks, micro pauses, and short exercises during the breaks can reduce spasms. A good choice of loop. If you're starting initially, use the loops which have low magnification because they are smaller and lighter than the heavier with high magnification loops. The through the lens loops are lighter compared to the frame mounted loop, the headband loops, or the loops with the light attached to it, because they tend to shift the center of gravity forward and you lean in the bargain. So a steep declination angle of the lens will make your spine straight. Customize your working length, the working distance according to your focal length. The loop magnification, as I said, should be smaller if you are starting initially, and there are carbon and stainless steel frames which are lighter. Now with these prism loops, the deviation angle is automatically adjusted because of the prism inside, and you don't need to flex your necks even for a single degree. If you have a light on top, the distance, the focal length of the light and the loop should be matched. Otherwise, again, posture readjustments have to be made. Cannot overemphasize fitness and exercise because you have to strengthen the core to have a strong muscular strength. Short exercises and targeted exercises of the arm, neck, and the shoulder will strengthen your core eventually. And stretches, even single back stretches and neck stretches every day in the morning can ease your operative time. Now the technology has come where these inertial measurement bands are placed on the head and the different limbs, which measure the distance and the degree of your movements during your entire surgery. So your take-home message is: reduce your operative time by planning your surgery well, build your core, execute your plans well, choose the right loop, and posture is everything for a long career. Thank you very much.
Thank you, Dr. Akshay. The one point I would like to highlight for the long duration of surgery is that everyone we are trained during our residency, probably long duration must have experience, but the in-between breaks 2 to 3 hours, depending upon the surgeon's capacity, probably that will be for your long journey. I think that is very much important whenever you are planning for the long duration, even physical as well as mental, both capacities improve, even if you take micro breaks in between, what I feel. Anything else anyone wants to add? Thank you.
So they are yet to be launched in India, and this is the new thing which has come up. These prism loops, one need not to bend the neck at all. So all you have to do is look straight, and the loop has prisms which has deviation angles accordingly, and you can have your own customized loop according to your this thing.
Thank you very much. Sure.
Thank you.
We conclude the session.
So welcome to the next session. The next session is on training post MCH and DNB options and prospects. So this is absolutely relevant to our audience. And to convene this session, we have Dr. Ashwin Tamankar. And over to you, Ashwin.
So I think we are already running 20 minutes late. So this particular session was predominantly meant for residents who are about to start into fellowship programs or younger consultants who are still in a spectrum who can actually join some fellowships. So without further any delay, we will start with the first talk, postdoctoral training, glory or necessity. Dr. Khochikar is with us on virtual platform. We'll hand it over to him.
Thank you, Ashwin. Thank you, Abhishek. I'm just trying to.
Makran sir, you can go ahead, sir.
Yeah,
Are
I'm trying to share my screen.
Makran sir, are you with us?
Yeah, I'm with you. Can you hear me?
Yeah.
Yes, sir, we can.
Yeah. See, I had sent you presentation, but I can have a control from here. Is it okay if I share my screen from here?
Yes, sir, you can share your screen and go ahead, sir.
Yeah. So this is a new share. Just a sec. Can you see now?
Yes, sir, please make it full screen.
Is it okay? Hello?
Upper screen.
Can you see?
Sir, just a minute.
Or I'll just run it like that. Is it okay?
No, sir. Please make it full screen.
Just a second. I'll go to slideshow.
Makaran, have you shared your screen?
Yes, I have.
Okay.
Can you see now?
No, sir.
Okay. Fine. I'll
No,
do.
he's not shared it, sir.
Right.
So
I'll
we can
share
do it from here, sir.
Just a second. I'll share it again.
Okay, sir. Okay, sir. Please make it full screen.
See, the full screen is some problem here. So what
Okay,
I'll
sir.
do is
No problem. No problem.
do that without wasting any time.
Okay.
Yeah. Thank you, Abhishek. Thank you, Ashwin. Thank you, Sabnis. It's wonderful to be here in this youth conclave. And I think it's an interesting topic which is given to me, postdoctoral training, glory or necessity. Life is all about perception. And I think it's all for your eyes only. That's what I believe. I believe Abhishek has asked me because I've done a super specialty, a subspecialty within the super specialty, and probably he must have asked it. So I assume that. So just look at from my experience itself. When I did my national board, urology many years ago, it was really necessity. I went to UK for further training in diploma urology. I did it. I did sort of an emphasis urology, FIBU. And I think for me, it was necessity. And for my peers and my friends, they thought it's more of a glory. But unless you achieve something, unless you do something and you specialize, I don't think you can achieve a glory. And I think the proof is in the pudding. Over the period of time, you subspecialize, you do something extraordinary work, and then probably the accolades are going to be there. Previously, we used to think, whether you have your social websites or social platforms, is it necessary or is it glory? I think it's more of a necessity itself. We built this hospital 1998, Siddhivinay Ganpati Cancer Hospital. It was a dream. We wanted to have some specialty in cancer itself. This was a necessity. But look at many years down the line. I think you progress into this specialty, and then probably it will become more of a glory rather than a necessity. And the times have changed now. Apart from specialty, you require people to come together and have super specialty hospitals with multidisciplinary times. And this is how, at times when you think it is going to be something like a glory you are aspiring for, but it's not. It's basically the necessity which actually leads to pursue that kind of specialty, which ultimately would lead to glory itself. A lot of people contradict and say urology itself is a super specialty. So why do you have to go for a training? Yes, I agree, but I'm sure you all agree, we can't do justice to each and every aspect of urology, even though we are specialized in this branch. For example, you take transplantation. You get a rotation in your MCH training program or DNB program for a transplantation. You may spend about 2 months or 3 months in transplantation. But if you want to make a career, you want to specialize yourself, you want to contribute to this specialty, I think you require substantial time into this sort of specialty. It is just not the technique you are learning, but I think the whole science of transplantation, the nephrology, the complications, everything you need to learn. I can't overemphasize about oncology, and I'm going to explain you in my talk. I think just doing radical nephrectomies or taking small tumors out to the TURBTs doesn't make you a urological oncologist. It's a wide spectrum of specialty. You need to understand the science better. Same holds true for pediatric and neonatal urology. How many of you have been given a sick child with reflux and all other congenital malformations? How you are able to deliver a proper care? And same applies true for complex reconstructive urology, failed hypospadias, failed reconstructions, post-radiation complications. I think you require a proper training, specialty within the specialty, and for that you require skill, in-depth knowledge, specialized care, support system, and then we'll have a better outcome itself. I must give you sort of a background where the subspecialty started in India. And I must say, this is way back in 1986 when I got trained. Dr. Phadke was trained in USA and Canada, and he brought this concept of subspecialty within the super specialty. And at that time, it was a necessity. And I'm sure with the period of time, it has glorified into this subspecialty. Credit goes to Dr. Phadke, my mentor. He converted Bombay Hospital into teaching subspecialties because that time, even in 1985, we had a urodynamics, we had pediatric urology, we had uro-oncology, you had andrology as a subspecialties within urology itself. Coming to my subspecialty, I'm going to cover a few areas which will highlight the need of subspecialty training within the urology. I'm sure a lot of people do nephron-sparing surgery, but you get the endophytic tumor, solitary kidneys. Doing once in a while is not something important, but why this patient has a cancer? What's the further treatment? Can you do something different? Can be very well learned if you have enough time to be spent within the subspecialty. Doing a good job is extremely important for that patient as well as the final outcome. Now, complex cases can be done like IVC thrombus and all those things, provided you have spent enough time within the subspecialty itself. IVC thrombus, you need cardiac surgery setups, you need intensive care unit, and you can deliver this sort of care. Because I personally feel that if you're called as a super specialty, I think you should be able to give all that kind of care within your specialty. That gives you sort of deal with the complex situations like this, bleeding angiomyolipomas. Many times I see in my practice, patients, urologists take the tumor out, testicular tumor out, but no counseling done, no understanding about what's going to happen to these patients. And these patients do require post-chemo RPLND, a challenging operation, primary or secondary, that you can get only when you have a proper training within this subspecialty and having spent at least a year and a half or 2 years within this specialty. A lot of people do TURBT. That doesn't make you urological oncologist. You need to learn proper techniques of a cystectomy. It's not only one, see one, do one, but I think this is extremely important when you take new bladders or various pouches within the cystectomy and even for upper tract urothelial carcinoma. What this specialty also gives you, it gives you an entry or gate to the doyens in this kind of specialty. I'm sure you all know these people here, Richard Hartman, Mark Soloway. From experience, I can tell you, more you focus within one specialty, you get into the network of these people and your horizon also expands. Also true for a prostate cancer. I've seen many people call themselves as robotic urologists or laparoscopic urologist oncologists, but how many have understood the science of prostate cancer and you take it further? Same holds true for this common malignancies like penile cancer. How many of you can give a proper care for a penile cancer? Same holds true for children with Wilms tumor, complex bilateral Wilms tumor. So my philosophy is, I think moving with the science and the technology and keeping ahead of the times. So it appears to be a necessity to move with the times and then take the specialty further to deliver the best care itself. To take it further, I'm sure you all know Dr. Mahul Amin. Now we are sort of geared up doing more of a precision oncology and genomics in the cancer. And I'm sure you all know my fascination for pheochromocytomas and adrenal tumors. And recently we formed a foundation which is called as a PheoPara Foundation with Dr. Nalini Shah, who's a professor emeritus from KM Hospital. And the first foundation has been formed, first meeting we had just about a few months ago. And we are trying to learn the genetics in the pheochromocytoma. This all can be achieved if you have a team which can support your specialty within the subspecialty, spend enough time for a training, and also enough networking within the specialty itself. And I must say, there is a word of caution. Technology is not synonymous with subspecialty. And the common example is robotic urologists calling themselves as urological oncologists. and not delivering anything more than doing sort of nephrectomies and adrenalectomies. I'll just end by giving a few of my sort of glimpses from my experience. I started my career because this is a youth conclave and this is something inspiration for the young generation. My journey started in '89. Thanks to Dr. Fadke, after sort of finishing in Bombay Hospital, sent me to the Bedford Hospital for my urology training. And this was first training where I worked in Bombay Hospital, in Bedford Hospital, James Hatfield here. Then this is, all those people, you must have heard about, Charles, Rob Charles, who actually wrote the books on textbook of urology and general surgery itself. This is Nick Waterfall. So all these people actually helped me in doing more and more of a subspecialty within the urology, that is urological oncology, where I did my thesis in institute also. We brought back to India, and Dr. Desai kindly invited me to Nadiad itself. And apart from Bombay Hospital, Nadiad is another example where there are specialities within the subspecialties itself. And you can see Dr. Bapat here, and you see the young guys who have now become consultants at MPUH. Maybe the Arvind is sitting somewhere in that corner itself. So the journey from so many years, 1989 to 2024, gives you a glory, only when you think it is necessary to get trained within the subspecialty and stick to this specialty. Dr. Fadke always believed that you dream, it is subspecialty, it is necessary of that particular time or in near future, that gives you glory. And this is a picture which is taken in my hospital when Dr. Fadke came and Dr. Desai came. So it's tribute to both of them who have encouraged subspecialty within the urology itself. Thank you very much. And I must end my talk in saying that this specialty, which is bigger, which will give you sort of your name, is not your name which gives you a specialty. Thank you very much. Thank you, Abhishek, and thank you, Ashwin.
Thank you so much, sir. It was a fantastic and wonderful overview of the entire journey which you had since 1989. So I would, for the want of time, we'll skip the question, but I will request you to stay back for the next debate for a quick comment after that. Yeah. So with this, we'll move on to the next debate. The debate, the basic concept was again technology-based fellowship versus a subspecialization-based fellowship. So the first speaker is Dr. Deepak Kaddu. He's going to be defending on the technology-based fellowships. Over to you, Deepak.
Thank you very much, you Conclave, for giving me opportunity to talk on this topic. Actually, very interesting topic for the young urologists because they are yet to decide what to do after post MCH. And excellent talk by Makran Kochika sir. So I'm talking about the post MCH or DNB training in favor of technology. I'm Dr. Deepak Kaddu at Manipal Hospital, Whitefield, Bangalore. Robotic surgeon, consultant neurologist, and kidney transplant surgeon. Okay. So what to do after MCH or DNB? Establish own private practice or join a corporate hospital, join an academic institution, or then do a fellowship. So why the fellowship is necessary? According to me, it gives you a distinct identity over the others, improved skill set over and advantages over the others. Also, the mentor makes the networking and the recognition easy. Also, the publication and presentation keeps you academically alive and updated. So there is a confusion. What kind of fellowship after MCH? So technology based like robotic, laparoscopic, or minimal invasive, or subspecialization based. So what is the aim of these fellowships? So technology based, it gives you an added advantage over others in the private or corporate practice, making you to do something more than them. But whereas the subspecialty based practice makes you focus on a specific topic, very much dedicated, excluding the other topics. So technology based options in India, we have robotic surgery, laparoscopic, endourology, and both combined. Subspecialization options, uro-oncology is there, renal transplantation, pediatric urology, reconstructive urology, and endourology, of course. Andrology and femurology are not very much sort of in India at present. The options are not under control of very much urology. So the technology-based fellowships, there are many fellowships. I'm just going to number the fellowships because you can go through these names through the USI videos are there on YouTube about what kind of fellowships are there. So to name some is Dr. Anand Kumar's fellowship at Max Super Specialty Hospital, Manipal Hospital, Dr. Deepak Dubey sir, Dr. Kishore T.S. sir at Aston Medcity Kochi, where I did my fellowship, and also ANU. So there are many. So almost there are 10 fellowships of the robotic surgery in India, which are technology based. So also apart from the robotics, there are minimal invasive and laparoscopy fellowship like George P. at Lakeshore Hospital, Kochi, and ACE Hospital, Dr. Suresh Patankar, and also Dr. Chandramohan Vaddi, and of course MPUH Nadia under Dr. Sabni sir. So overall there are 14 fellowships. So subspecialty based fellowships in India, mostly it is concentrated on the uro-oncology. So there are Amruta Hospital, Cochin is there, HCG Bangalore, Kokilaben, TB Uraja, and there are many more. So overall there are 14 fellowships about the uro-oncology. And if you go to the only endourology subspecialty, there are again 4 fellowships at different hospitals. Also the reconstruction urology. So again, Kulkarni's Reconstructive Urology Center at Pune is there, then Varna Hospital, Kolhapur. So overall, there are 27 fellowships in the subspecialty group, including transplant, reconstructive, pediatric, and the uro-oncology. So is subspecialty really needed? So when our urology is itself a super specialty, do we need to segregate it more and make it more complex? And what about the other super specialty? Have they divided their super specialty topics into subspecialties, or is it the only urologist? When we are going through a 4 years of DNB or MCH program, can we just add up our knowledge after doing a fellowship rather than just considering that 1 or 2 year of fellowships? Then exposure might be less during the residency in certain section of urology. Or does your institute want you to perform certain kind of jobs? That's why it is not a choice, but a compulsion. So is Indian healthcare structure compatible with this? Because very few robotic cases, only 5% patient can afford robotic surgeries. It's difficult to limit your number of cases in the beginning of career. Also, the 2-tier and 3-tier cities, they need more wholesome treatment rather than the subspecialty based treatment. And very few cases like penile and testicular cancer. So again, newer robots coming into the market like SSI Mantra. In 2022, the scenario was Da Vinci had 107 robotic installation, SSI Mantra was only 1. Whereas in 2024, Da Vinci had 160 robots, whereas SSI Mantra grew up from 1 to 45. So the market is flooding with the robots. If this scenario goes on, it will be easily accessible as well as affordable for general public. So most of the people will be doing robotic surgeries because it is not a very difficult technique to learn as a laparoscopy. So this is my fellowship data. During my fellowship, I did 365 assisted and did 365 cases along with Dr. Kishore T.S. sir. So out of that, 120 were non-oncology. So that is almost 33% of the cases, which I don't want to miss. So which includes robotic transplants, the major chunk, also the post-gynecological or urological complication repairs, urological reconstruction, and other resective surgeries. So during my private practice, what I'm doing, in last 10 months, I have done 27 robotic surgeries. Out of this, 22 are non-oncology. Only 5 is oncology based. So I don't want to miss 81.5%, 81.9% of my surgeries, which will not satisfy my corporate management. And also doing this simple and non-oncological cases will boost your confidence and trust in the patients to get oncological cases later on. And I would suggest a robot isn't more of a technical tool which requires as in technology to do any surgery with precise dissection and intracavity need not to be oncology. So this is a data comparing India and United States. When people compare the standards of United States to be followed in India, we also should compare the data like 45,000 cases done in 1 quarter, whereas India is lagging behind in 2000. So we can't apply the same standards in India. So we have to cater according to Indian needs. We have to do wholesome based practice. So also the most records might be there by a specialist, but you know the crucial World Cups are won by all-rounders. You can have a depth of knowledge. I need not introduce these figures in India in urology, but you can choose your role model. So, so it is, your path is often guided by the guide you meet on your path. So this is with Kishore TSR at the end of my Matikuti fellowship. And also the people around you sculpt your life the most. This is with Dr. Deepak Dubey sir after completion of my first robotic transplant. So the technology based or subspecialty based, it depends number of cases, corporate expectation, patient expectation, place where you work, and also what you want. You should not be guided by the what other want. So it's easy to tell what is ideal, but we have to change according to needs. If the Dravid legions like Dravid can do a coach job, a captain job, a wicket keeper, why can't we? So take home messages: adapt to survive and change to excel. India is too early for a subspecialty. We can still do wholesome practice. You can't separate technology from a surgeon. At present, I would advocate technology-based fellowship. But at the end, all fingers are not the same. So you can cater to needs. Thank you.
Thank you, Deepak. Thank you for that. Thank you for that steamy discussion. With this, the next speaker is Dr. Shashank Agarwal, who is going to defend on subspecialization based fellowship. Just to introduce. We'll request Shashank to stick to the time. That's unfair, but that's practical. Sorry.
Good afternoon, everyone. Greetings from Kochi. Myself, Dr. Shashank Agarwal, is going to advocate for subspecialty-based fellowship, which is a focused approach to advanced training. I thank Dr. Kaddu for making my job easier. So, in contrast to my worthy opponent, Dr. Kaddu, who is a robotic fellow, I prefer not to be a slave of instrument. And here are my points. During the residency episode of 3 years, an average urology resident used to get exposure across all the subspecialties in the urology, gaining the breadth of the entire spectrum of the urology. This is the paper from one of our conveners that on a recently done survey on 85 Indian urology residents, and 61% of the urology residents found that they have got enough exposure during their residency period for taking the decision for focus-based subspecialty-based practice. However, majority of these residents opt for laparoscopic or minimal invasive surgeries to specialize in. Furthermore, around 2/3 of these residents were having inadequate exposure in the minimal invasive surgery, and their exposure in the robotic surgery was further less. So the question arises: are the residents are mature enough to take appropriate decisions for taking a modality to which they are not sufficiently exposed? Most of our residents used to adopt for the technology-based fellowship as a part of a FOMO, which is fear of missing out something new, evolving, and associated with glamour. Or they may be influenced by the bandwagon effect, which means the tendency to do the things because many other people are also doing the same thing. We should realize that we are the clinician first, and our aim is to treat the patient as a whole rather than in bits and pieces. And by adopting a patient-centric, individualized approach, we can serve our community in a better manner. So the fellowship means long-term commitment for one subspecialization, and the surgical funness comes after better understanding of the patient's symptoms as well as the disease complex. And with more exposure to the complex and neglected cases on a routine basis, our confidence in handling the failures increases. So unlike my worthy opponent, Dr. Kaddu, who is a robotic surgeon, if I consider job of the uro-oncologist is not to merely removal of the prostate in a patient suffering from localized cancer prostate, but he should also be knowing how to read the MRI images. He should be able to map the prostate cancers. He should tell to his patients that which modality of therapy or alternative therapy is best for him. He should understand the basic nuances of the surgery, when and where to go the intra or extrafacial level of the resections. He should be able to understand and explain to the patient that what should be the functional bearing of his surgery. And he should also be in the position to take the decision whether this patient is candidate for new adjuvant or adjuvant form of therapy or not. Being a uro-oncologist, you will be dealing with a multidisciplinary tumor board where you will learn that how to make a collaborative decision making, which will improve the patient outcome. And the patient will also gain the confidence because they will think that instead of a solo person, a team of experts is taking care of him. So technology is temporary. It will come and it will go. Many books as well as many articles has been published in the past and in the future also they will be published, showing that the technology is continuously evolving in all the spheres of urology. For example, if you take the management of the BPH, multiple technologies have evolved over a period of time, starting with the resection, then coming to the focal therapy, then coming to the laser vaporization, then coming to the enucleation, then coming to the balloon dilatation or simple prostatectomy with the help of a minimal invasive surgery. Following it, aquablation, urolift, rhythm therapy or prostatic artery embolization came into the picture. So there is always a fear that technology will evolve and it will disappear with due course of time. We must understand that every technology has a limited time span. When the technology becomes widespread and is performed by everyone in every nook and corner of the country, then the fellowship in that technology will lose its relevance. For example, in the past, the laparoscopy was such a big hype, but currently hardly few people talks about it. So the main core principle of the fellowship has to be to increase the depth of the knowledge and to become a king of one rather than becoming jack of all the trades, unlike Dr. Kaddu. Only three things are going to be constant. Number one, age, gender, organ, or disease. And any fellowship based on these three things are going to survive. Significant damage has already been done in the past because of the lack of this wisdom. And under the banner of USI, several subspecialties has been formed. And after the formation of these subspecialties, there has been tremendous increase in the knowledge as well as the opportunity for young surgeons like us. He was talking about the US data. So in US fellowships, none of the fellowships are offering technology-based fellowships. Everything is sub-specialized based fellowship. And an interesting example was shared by Dr. Kulkarni that a robotic trained fellow approached him because he was struggling for employment in the US because he was not having any expertise in dealing with a single kind of disease entity. So he came down all the way from US to Pune to learn the management of the urethral stricture, including the erythroplasty from Dr. Kulkarni. He was talking about the numbers. So the technology can just be act as a tool to enhance the subspecialty, but it cannot replace the subspecialty. Around 88% of 4,000 plus robotic cases which has been performed in the last 2 quarters across India, around 88% of these cases belongs to the uro-oncology. And I hope that all the REKTs belongs to the Dr. Kaddu. So if you plan to practice the subspecialty, I do agree that the start will be slow, but on a long term, you will definitely get recognition. All these prominent uro-oncologists had a similar story in the past in their initial stages. Nobody talks about the what after technology-based fellowship. Technology comes at cost. It depends on the type of the practice which you are doing. It depends on the place. Either you are practicing in the third or second tier of the city, and the reimbursement based on the Yojana or schemes is also major hurdles. So to conclude, technology-based fellowship leads nowhere, and subspecialty-based fellowship is the past, present, and future. Thank you for your patience.
Thank you, Shashank. We would ask Dr. Sabnis sir to give us the comments on the jury.
I think both the speakers have put their point very nicely. To really analyze in a very unbiased and realistic manner, we have to understand and accept that technology eventually, as Shashank rightly mentioned, that is going to disappear. New technology will come and the old technology will be replaced by the new. That is what we have seen. In our era, it was all open surgery and there were a lot of interest in pyelolithotomy, nephrolithotomy, which went away. Then came TURP. Then there were fellowships and people were interested only in learning PCNL. Now there is a talk going on that PCNL eventually is going to disappear. The Testicular laparoscopy is taking over, and the debate has already started in America that should PCNL be existing. So that is what is the thing. Laparoscopy similarly up till now in America the debate was whether laparoscopy is dying or not. Now that debate is over. The realistic thing is that laparoscopy is dead in America. So it is bound to happen because today we are talking of robotic. After 10 years, 20 years, the robotic also will disappear. Something new will come. So what we think today is impossible is very much possible sometime ahead. We don't know. So when you are talking of really specializing in particular thing, it is important to understand the disease, and therefore Matran rightly said that if you are trained in a particular specialty or particular disease, then you know the whole spectrum of a disease. It is not only that suppose there is a radical, there is a RCC, and you have to do it with the robotic surgery, or there's a prostate cancer, and then if you are master in the robotic surgery, you will do this. You have to understand everything. What is the pre-operative evaluation? What is the post-operative evaluation? Whether that particular surgery is properly indicated or not. So that is very much required, and that can happen only with subspecialty training. But at the same time, this part also is correct, that when you are having a technology, it is not only one disease, but it is the technology which can be used for everything. When we had discussion about starting the subspecialty in USI, there was a lot of discussion about starting various fellowships, subspecialties. And previously we had endourologists as a subspecialty, laparoscopy robotic as a subspecialty. That is not existed now. We did not do that simply because these are technique-based specialties. Technique-based specialties will not remain viable for all the time. We decided to have only disease-based specialty, and therefore there is no reconstructive surgery specialty. There is no endourology, because reconstructive can come in pediatric, it can come in oncology, it can come in andrology, it can come anywhere. Similarly, endourology is everywhere. It is not a specialty by itself, but this is a technique which is used in every disease, every specialty. So I think if you have to take a very rational view, it is bound to be a disease or a gender or the age-specific specialty, which will make you perfect, which will give you the edge. Ultimately, what is the purpose of doing this specialty training? Is to give you the edge in the whole society. If there are 100 people, if you have an edge over the others, you are bound to get benefited. And that benefit will come only if you focus on a particular specialty which is based on the disease or a gender or a sex. That is what my view is. But at the same time, I appreciate what he has said, that once you get the robot, you are not going to restrict only for oncology. But the other counterpart of that is that once you are used to get trained in robotic surgery, say for example prostate, once you understand the nitty-gritties of robotic prostatectomy, I am sure you are bound to use robot for various other things, which you are also going to use it. So that will come automatically. But if you want to have an edge, it has to be a disease special.
Thank you so much, sir. We will have a quick comment from Desai sir as well on this.
Right, Sabnis and Shashank and Deepak. I think wonderful talk. We talked about technology. You know, it is increasing and technology saves life. We talked about the surgeon. Surgeons are getting trained, and America also people are there, but half of them are Indians. So surgeons are trained. What is the difference? Why they are doing it? Deepak showed they are doing a 17,000 radical prostatectomy as against 1,700 radical prostatectomy. Now who's doing this 17,000? Vipul Patel. Why? Because the patients are different. The patients are aware of their disease and they come to the doctors earlier. By here, we do not. Patient come late unless until we do teach them. So what is the difference between this scenario? I think technology here to come here to save lives. There is no doubt about it. And technology is going to change. But moment the awareness will increase, the treatment will increase. The same thing happened with the stone disease. The stone disease was highly prevalent in India. But when the new technology came, more patients came. 8 MPH, we have done more than 37,000 stone treatment. And we are considered in the first 10 hospitals in the world to treat a stone disease. Why? Because the patients, we have a more stone disease and we have more patients are aware that here the minimal invasive surgery can be done. And there the stone disease incidence is a little less. So there are less people are there. I think technology is going to be there. What is our aim at this moment? We have to be ready for the patient to come and then treat them at the best of our ability, make them treat so that they go back to the work and their life much quicker than what it is now. So what we now need is an awareness by the patient, and we should work on it. Then our training, our effort would be beneficial. Thank you.
Thank you so much, sir. So we will move on to the next half of the session. It's more for technical aspects of applying applications of fellowships. We have included US, UK, and Southeast Asian fellowships. The first speaker is Dr. Anup Kumar, sir. So, sir is going to talk on American fellowships, how to get them, and make most out of it.
Good evening, respected chairpersons and my dear colleagues. We're going to talk about American clinical fellowships. Now, after listening to such excellent debates, we know now that the fellowships are important. But how to go about these fellowships? Where should we go? So, urology is expanding and subspecialization now is the need of the hour, and we cannot deny that. 3 years of residency is not good enough to be trained in all aspects. Some centers, they might have all training facilities, like Nadia is one of them, but still resident cannot be trained in all the aspects in 3 years. And therefore, you have to go for fellowships to have some additional exposure for the mastercraft training. Now, if we go to abroad, international fellowships, why they are important? We have focused fellowships. These fellowships are given by stalwarts who have polished their techniques and they have already passed their learning curve. These are basic research in most of these fellowships, and they give you special facilities for that. You get a perspective how to build your career, or you might also settle down in some of these countries. And of course, networking, I think, is very important in today's era. If you have networking in all the countries, you can grow faster in your career. So your American fellowships, I feel, is, I think, one of the best in this area to provide you fellowships. Dedicated subspecialization, as we are talking about, you name a subspecialty, it is there. And there are high volumes in most of these good centers. And the directors are all well-known stalwarts in their own fields. And this step-by-step training is given. Every fellowship has got a curriculum, and most of those who are accredited fellowships, they are regulated by those curriculum. Now, as we're talking about two kinds of fellowship, accredited and non-accredited. When I say accredited, it is not accredited by the American Council of Medical Education, but it is associated with some society like Endocrinology Society, AUA, and Society of Uro-Oncology. So these are societies which accredit these fellowships, but still it is not ACGME accredited. So these fellowships are 1 year or 2 year, because less than 1 year, there is no need of going to that fellowship. It cannot be a clinical fellowship, very clear. In 2 years, 1 year will be pre-clinical and 1 year will be clinical. You have to clear all MLE steps that is mandatory for you to get into clinical fellowships in America. Some of the fellowship centers will allow you after step 2. You will get J1 visa. But if you want to go to bigger centers and to have the bigger reach to all the centers, it's better to have all steps 3 cleared. Step 3 also, then you can have access to all the centers of the America. As I said, J1 visa and H1 visa are depending upon your MLE steps. When you apply through a proper site, and it is very good that AUA has taken that responsibility, that AUA is going to be the common platform where you match with all the societies. Therefore, it is a reliable institution, and therefore you are not going to be disappointed by this platform. And then finally there will be match. So let us say I will start with the Endocrinology Society Fellowship. It has got 3 subspecialties: stones or endourology, technology based like laparoscopy, robotics. They call us advanced robotics fellowship or advanced minimally fellowship, and a combined in which you have both. Now you must have completed your residency from India. It can be DNB or MCH, doesn't matter. And then you apply through a AUA. There's a link on the society. You apply to that. You have to send your CV. Now, 3 letters of recommendation are very important. You should choose your mentors who are going to write down your letters of recommendation, because that really matter. And of course, the CV. The more papers you publish, more presentation you make, that makes you a better candidate for those institutes. Now, this is the schedule. Some of you, if you are planning to apply, it starts with the December, ends by 17th May, and they run always 1 year prior to the fellowship starts. And then you have to submit a rank. Now, what do you do when ranking? They will give you a list of institutes. So to select which institute you want to go. 1, 2, 3, 4, 5, you can give up to 10 ranks, and then you submit this rank to AUA. So at every step, AUA is there, so you don't have to worry because it is going to take care of all the issues. And then the deadline will be by 24 June, and then for 18 July, you will get the final match. So the institutes will also choose the students as per their scrutiny. They take interviews, and all interviews they happen during AUA. So like suppose this AUA will happen this 2024, already has passed, next AUA will be 2025. So your interview will be taken in 25 and you will start your fellowship 26. So these are the said minimum number of cases you should be given. Now when I say given, either to assist or do, there is no clear description, but yes, you will be exposed to these number of procedures: endourology, laparoscopy, robotics, and combined. Now, each student has to enter your case log through an online case log site monthly. So therefore, this is very standardized now. And therefore, if you're not getting enough exposure, they will know. The society will know, and they can cancel the fellowship from that particular institute. And research, I said, one paper should be submitted to the Journal of Endourology and one paper should be published in some other journal. This is a minimal requirement for 2 years. And I think that encourages your publication capacity. Now, most of this training, when I say, let us assume robotic training, they assume a standardized protocol. They start with a dry lab, simulator training. They graduate you to wet lab training. Some of them have cadaver training. Then they start with the bedside assistant and then the console training. So I'm just giving example of one such. There are a lot of such curriculums in those trainings. Next society, which I feel is one of the better societies in America, is Society of Uro-Oncology. And almost all you name institute is there under this society. Again, you have to apply to this fellowship on the website of the society. And again, most of the requirements are same. You have to pass MLE. That is no, you cannot escape that. And most of the programs are 2 years in this because this is dedicated to uro-oncology. As we're talking about your subspecialty, this is totally uro-oncology based fellowships. And again, letter of recommendation is very important. You should choose whom you're selecting your mentors to write your letter of recommendation, but that really matters. And again, they have standardized curriculum, and the match again happens during the AUA. Now, these are some individual fellowships I have listed. They are very good, but they are not accredited. They are individual institute fellowships, but they are very good. You can see their names. They're all stalwarts in their field. Dr. Craig Rogers in Henry Ford, Vipul Patel at GRI, A.K. Himmel at Wake Forest, Ashutosh Tiwari at Mount Sinai, and Jihad Koch in Cleveland. So these are individual fellowships, but they are really good. So you can aim for these if you cannot get through the society fellowships. And I finally want to add that in USA, you have added advantage. You can actually choose your career. You can actually choose to settle down in this country. If you compare it with the UK, UK cannot settle down, very difficult to settle down. In US, you can settle down. That gives an edge over other countries. So these are pros of you go for American fellowships. You get good case loads because of the high volumes, variety of cases. You have the top most technology available in your institute, most of them. You name it, like AR, VR based training. They have all the 3D models. They have simulator trainings. All of them are available. And structured proctoring in most of these institutes. Networking, as I said, very important. And you also have opportunity to settle down in US. But of course, there's some cons because if you go to some particular institute, they're only doing a prostate. Let's say Dr. Ashutosh Tiwari, he's mainly focused to prostate. So you might be trained in only one organ. And therefore, when you come back to India, you might find it difficult to just prosper in your early phase. So these are some cons of doing only one organ fellowships. But I think in long run, it will help you. Again, in India, if you go to any fellowship, we have overlap. Like one of my previous speaker was saying, you will do uro-oncology, you will do non-oncology cases also. There, they are very strict. So you have to stick to only oncology. So these are, you can say, cons because you're only exposed to one specialty. But yes, I can say once you're trained in that particular field, you will master in this field and this is going to pay you in the long run. Thank you so much.
Thank you so much, sir. We'll move to the next one. Fellowships in UK, are they now easier to get? Rahul Jina, he's going to join virtually. I'll request the speakers to stick to time, please. Rahul, go ahead, please.
Yeah. Am I
Unmute the Zoom
audible?
screen.
Yeah, I'm doing that.
Virtually,
So,
please.
yeah. So thank you for giving me this opportunity, and especially thank you to Abhishek sir for letting me speak virtually. I had a personal mishap; I couldn't make it there in time. So I have only 10 slides, but I have a lot to
Rahul,
speak
unmute
about.
yourself.
Rahul,
You're muted.
unmute.
Yeah, we can see your screen. Just unmute and go ahead.
Okay.
Yeah, you are audible.
You
are
can
audible.
Yeah.
Not a problem. You can see that.
Right. So thank you again for letting me speak virtually. I couldn't get there in time. I had a personal mishap. So this is a topic very close to my heart because every week I get a lot of calls from young career urologists and residents asking me about career choices. So it's important to know that there is no single way that works for everybody. And you ultimately have to find out what works best for you. So, right. I'm sorry, I'm not able to change my slides. Yeah. So, a lot of these people who call me, they expect that once you go to the United Kingdom, it's all about reputation. All the institutes are very good. And in every institute, there is going to be massive hands-on training on the robot, and you'll gain a lot of mastery in a very short time. When you come back, corporate hospitals in India will be keying up in lines waiting with giant salaries for you. And in the UK, a lot of jobs will open up. It's very easy to get into UK fellowships. But these are all myths. The reality is that across the UK, there are many institutes scattered which advertise their fellowships, and not all of them are good. The hands-on experience across all of these institutes, it's very inconsistent. And in some cases, you may not even get any hands-on experience on the robot. Fellowships can be very specific only to certain organs. For example, the one I did at Royal Marsden, I was doing only robotic prostatectomies and I was doing open RPLNDs. And in most places, when we think of a fellowship, in most places, these fellowships are not certificate courses. They are jobs in the department of urology of that hospital. And those jobs are known as senior clinical fellows. So you are working as a fellow in the department of urology. Good fellowships can be very difficult to get into because there is a lot of waiting list for these fellowships. And even if you get into a good fellowship in the UK, once you come back home, the struggle to land a good job which is up your alley is very, very real. So how do you get into these good fellowships? I won't stress much on the technical aspects because they're self-explanatory. You go on the website, you will be guided on how to go about the next steps. But the very first thing, evaluate your own goals. Decide whether you're going to UK because you want a good work culture, a good work-life balance, or you want to go there, experience something, come back and work in India. Find out centers that you like, zero in on centers that are doing the work that you like. For that, you have to go on to Twitter, you see their social media presence, you read about them, you see their advertisement on websites like track.jobs or NHS jobs, and then you contact the fellowship directors. It is surprising, I don't know how many of you know it, but a lot of these fellowship directors have very deep roots in India, and they keep on coming back to India for conferences, for various workshops. So you have to follow them on social media. You have to be in touch with them so that when they come to India, you go and you meet them, you strike a rapport, you start a conversation, stay in touch with them. And that really helps you get into these fellowships. You ask them if you can go and visit them in the UK for an observership, and that's a bonus. And I think Ashwin would agree with me when I say this. The technical aspects, they're very self-explanatory. Once you start the process, you'll do it. Suppose your fellowship director tells you, I'm advertising this job, you apply for it. There's an interview. You're expected to clear your English language tests. You're expected to get your primary medical qualification, that is your MBBS degree, verified through ECFMG EPIC. You need police verification, certificate of good standing, letters of recommendation. And then you need to do your GMC registration. So if you have cleared your MRCS step 1 and step 2, you can do it easily. Otherwise, your trust, that is the hospital where you're going to work, gives you a certificate of sponsorship. Once your GMC registration is done, it usually takes about 2-3 months time. You apply for your visa, you look for houses, you pack your suitcases, and you land in the UK. What I would recommend you do before choosing a fellowship in the UK is that you speak to the previous fellows in that center, ask them about the caseload, how much they're getting to work, what are their working hours. You approach these program directors very, very early. Most of these good fellowships, they interview for posts 2 years in advance, a year and a half in advance. You check for accreditation, whether they're accredited to the Royal College of Surgeons, whether they're accredited to the European Robotic Urology Society. You see whether they're organ specific, whether they're focused on the upper tract or the lower tract, and always have realistic expectations to avoid disappointment. Most centers prefer people who have previous experience in that field in which that fellowship is being done, and those with a good academic record, with experience of audits and publications. So I have listed out a few centers. So you can see that the top 3, I've listed them in blue. So these are the centers which have a Royal College of Surgeon accredited fellowship. And the other centers, so this list is not exhaustive. These are just those centers in and around London where you get a lot of robotic exposure from stalwarts in their field. I did my fellowship from Royal Marsden Hospital, and I was trained by Declan Cahill, who is UK's highest volume robotic prostate cancer surgeon. So what did I learn from my UK fellowship? So this is very important because you have to understand a lot of people before me have spoken about technology versus philosophy. And it's important that you realize that a single fellowship, whether it is a robotic fellowship or a uro-oncology fellowship, either in the UK, US, or India, that is never going to be enough because this is a continuous process and you keep on doing the same thing over and over again. You keep yourself updated, you study hard, and that is when you find that over a course of time, your outcomes in that specialty are probably better than others. And that is when you realize that your fellowship has helped you. It's never an instant gratification. So if you look at the timeline I have shown on the right of the screen, I went for my fellowship in Royal Marsden 4 years after I passed out of MCH in SGPGI. In that time, I did a postdoctoral fellowship in uro-oncology at SGPGI. I was a consultant in AIIMS Jodhpur. The point is that I didn't hurry into my fellowship. I took time to decide what I liked. I continued working in uro-oncology. I continued making my concepts better. And that's when I realized that I probably need to make my robotic skills better. So I went there. So you need to develop a philosophy, and that philosophy should be that you love uro-oncology and you find gratification in it, and you should try to become better at it. The other thing I learned from my UK fellowship, although it was a pure robotic fellowship, is that a robot is just a tool. Just because you have access to a robot, that should not be a factor in making a decision on whether you operate and do a radical prostatectomy in a person with metastatic prostate cancer, or you do a radical prostatectomy on somebody who can be better served by radiotherapy or maybe doesn't need treatment at all. The other great thing about UK fellowships that I learned was that I watched a lot of stalwarts in their field. I shared
Let's conclude. We are running out of time.
Yeah, this is the last slide. So I watched stalwarts in the field like Nick James, Chris Parker, who are medical oncologists, radiation oncologists, and really respected what they do. So that helps you understand how to treat a disease better. And you have soft skills and compassion, which help you talk with your patients better when you come back. So immense gratitude to all these centers I trained in. And the last 2 people are my fellowship directors, Declan Kyle and Omar Karim. Thanks for letting me speak.
Thank you, Ravi.
And that will be all from my side. Thank you.
Thank you so much. So let's move on to the next one. For the Southeast Asian fellowships, we are going to have a talk from Dr. Rajat Mahdi.
Respected chairpersons, respected seniors, and dear friends, I am Dr. Rajat Mahadik. I'll speak on fellowships in Southeast Asia, getting the logistics right. मंजिल मिल ही जाएगी भटकते भटकते ही सही, गुमराह तो वो हैं जो घर से निकले ही नहीं. So the first thing is to decide, take out your time, go for a fellowship. Life you get it only once. We have a famous movie, Purab aur Paschim, of Manoj Kumar, and the eternal debate, West versus East. And as we all know, we discussed that West is more about materialism and East is more about spirituality. So Western and Eastern fellowships, West First, we start with what fellowships. You give USMLE, PLAB, TOEFL, get the GMC registration, board exams, recommendations, and in the end, long waiting list. The Eastern Fellowship fee, just let's keep it simple. Select type of fellowships, select a high volume center, give your interviews, join the fellowship, early return to your home, and start serving the society. Know the exams. I'll start urology fellowships in Southeast Asia. There are many fellowships. I'm trying to cover few of them. Prototypical fellowships. We can have them in Singapore, Korea, China, Taiwan, Malaysia, and many more. I would like you to just take a click of this slide for more information. Singapore, to start with, SGH, where I was for a good 8 months, the oldest hospital in Singapore, almost equivalent to AIMS, ranked by Newsweek in world ranking as 3rd, 8th, sometimes 11th, and the last 2 consecutive years. Fellowships offered, endourology, female urology, uro-oncology, around 6 to 1 year, you have both options. Economic aspects, that's most important. A person who has just passed out, that is the most important consideration. The tuition fees is around 9.5 lakhs INR. Stipend is not offered. Monthly expense at Singapore is around 60 to 1 lakhs. The other countries might be a bit cheaper. How to reduce your budget? Pre-search for accommodations, use of the transportation, selecting budget food and grocery shops. Application process, apply through online official website, give a Skype interview, and fellowship is offered as per selection board's decisions. So that is the official thing. Now, factors which help in gaining fellowship, as sir mentioned before, a strong CV, then letter of recommendations, who is recommending you, and past observership at SGH, that also definitely helps. Your guides, they knowing you by a 7 days or a 10-day small observership there. It will take around 6 months for the process to go on. You'll get all these documentations, temporary medical registration, training, employment pass, indemnity insurance, personal health insurance. All of this you will be helped by the department secretary. You just have to swipe your credit cards. Advantages and tips, full hands-on training from first month. As it happens in India, they recognize as all programs, your work starts from the level of skills you have achieved. So first, I would say first 2-3 weeks, you have to prove yourself. After that, team-based system is there where you follow your guide along his entire week. Something like we join a unit here, so you follow your professor. So whatever might be the official title of the fellowship, if you get a dynamic guide, you can have equal exposure to endourology, lab, and robotic. Try to link with all consultants. There is no bar. You can go into any theater if your time is free. And there is freedom to join other teams, surgeons, surgeries, chance to take part in various research activities. One more great advantage is it's 100% English speaking population, Singaporean population, availability of Indian food, presence of large Indian community, and it can be a base for trips to various South Asian countries. Advantages I had personally, RIRS, supine, deep hernia repair, lap renal surgeries, you get good hands-on. Robotic RARP, as I had enrolled for an endourology fellowship, still I got some exposure. In Singapore, you have to be careful about punctuality. It's not like you reach there at 10 o'clock. It doesn't work like that. Singapore laws and culture, they're very different, very strict. And of course, finances. Next I come to Tan Tock Seng Hospital, Singapore, contributed by Dr. Himesh Gandhi sir. It is the oldest hospital, around 2,000 bedded. Applications are routed through this gentleman. Everything goes through the Skype interview. No additional exams are there. Salient features. Fellowship generally starts in April, so you plan accordingly. Recognized fellowship by Singapore Medical Council, FMIS. There's no tuition fees. There is a stipend offered, 2,500 Singapore dollars per month. So the one more good thing is 4 days OT slots are there. They have a good volume, 2 to 3 robotic urology cases per day. 1 year involvement in procedures, approximately 450 to 500 cases you will be involved. All international conferences are sponsored by TTSH, South Korean fellowships in Seoul, the Yonsei University, Severance Hospital, Seoul, oldest university of Korea. They have 13 Da Vinci robots. I think that number might have increased by now. 4 to 5 robotic cases per day. key person, professors, the name mentions. All applications course through these gentlemen. Include in your letter of intent which type of fellowship you want. If slot is vacant, you will be informed. 1 year formal hands-on fellowship is offered. There is no tuition fees. Salary availability depends on your mentor and subspecialty. The more sort of the subspecialties will have a tuition fees. You will not be offered salary in that. Lodging as per your convenience. There is dry robot lab exposure around 3 hours a week. Some Malaysian fellowships are there, not very sought after. Fellowships in urology offered in 10 prominent public hospitals in Malaysia, mainly endourology fellowships with 1 fellowship in transplant and robotics. They're short fellowships. You apply through the Ministry of Health, Director of Medical Development Division. Nominal fees paid to the government. So thank you. Let's keep it short as my presentation. Go there, get your fellowship, come back and start working. Thank you.
Thank you, Dr. Rajat. It was a wonderful presentation and an eye-opener and gateway to Southeast Asia. With that, I invite Dr. Ashwin Tamankar to speak on getting maximum out of your fellowship. As we all know, he has done that. Over to you, Ashwin.
Thank you so much. So good afternoon, everyone. My talk actually was a complimentary one to my previous mentor, Dr. Gagan Gautam. The talk was getting maximum out of a fellow from mentor's perspective and a complimentary one from my side. Unfortunately, he couldn't make it. So I'll try and get the mentees bit here in next 6 minutes. I've kept it very simple. It's more of slides and just the theoretical material. But probably would be invoking for a resident who is just graduating from the urology training. So obviously that decision for fellowship starts from the days of residency. It does not start when you already become a consultant. It should start as a pre-planning. Aim and decision making has to happen. A lot of things come into picture: family perspectives, financial perspectives, your age. We have a lot of need systems here, so you cannot have all the candidates at the same age. Sometimes you waste some opportunities in the NEET exams and you're already older. So all these things will count in decision making for your fellowship. The path in which a lot of colleagues ask us about, junior colleagues ask us about which fellowships to join in, and my first question to them is what city you want to settle in, and whether you have enough opportunities in that city, and what is your family perspective, and what is your hospital type of attachment which you would want to envision yourself into. So city wise, obviously first tier, second tier, smaller cities, everything will have different ball games. Hospital wise, you have at least 3 to 4 kinds of hospital: trust hospital, corporate hospital, and your own setup or a freelancing setup. Everything will have decision making into your fellowship. It's not just one FOMO attitude, which Shashank said, that fear of missing out for a robotic fellowship. If you're settling down in Satara and you're trying to hunt into a robotic fellowship, it's a waste of time. So we need to understand that, pre-plan it properly. Subspecialty versus techno, let's not waste time here. It's already been discussed enormously. Choose mentor wisely. Important is to get feedbacks from the previous fellows. There are a lot of blogs. I have myself written a blog on Verticality Fellowship website, Royal College of Surgeons of website, where I've done both the fellowships. And a lot of junior colleagues read those blogs and call me to ask about the details. So there is enough material available. Only thing is our inquisitive attitude is important for us. Always write to your mentor. They are approachable. They will give you a feedback. You go and observe the particular center before you join the fellowship. One quick bit is those who have been following, those mentors who have gone through a structured fellowship programs, they will be better mentors as well. That is one important point as well. Structured versus non-structured fellowships, and most importantly, realize about the struggle which everyone has to go through. It's not a piece of cakewalk, which Rahul just mentioned. Important is to have Shoshin mind, openness, eagerness, without any preconceptions. There are phases of learning. Very important slide. In fact, it was given to me by Gagan Gautam sir. So when you enter a fellowship, you are in unconscious incompetence. When you actually start off, you know that you are incompetent on many of the bits, and you start realizing about it. The aim is to walk towards the path of upslope of conscious competence, where you know that what domain you can do in a better way and what domains you're going to be lacking. And ultimately, the unconscious incompetence should follow in life path. So what to extract out of a fellowship is on 4 fronts: clinical, surgical, research, and academic. So I'll just brief through all those four slides and I'll sum up there. Clinical, learn the topic well. Important is to have that decision making. It should come on a spinal level, wherein the subspecialty fellowships come into picture. Counseling of the patient is very important. Patient-centric approach. You have to take as a fellow, obviously you have to come out of that residency path. As a resident, you're just managing that particular case and pushing off that particular day and coming as a fresh for the next day. But as a fellow, you should start taking that onus for the patient, which you will be. It's a one step before your consultant career. So always remember that. pre-operative to post-operative, and of course intermediate follow-up. Of course, many of the residents even do not know when they were washed up for a case, what is the pathology like. But as a fellow, you should be aware of everything, including the PSA failures, margin rates, everything. That will help you to get your things done correctly in your consultant career. Early exit from a residency mindset, that's important. Read your mentor's mind. All he wants is to be a safe fellow for his patients who will be looked after well, who will be taken care of with adequate onus from your side, and then the reciprocation will obviously build in. Initial 2-3 months are always going to be an observation period. Don't be impatient. In initial 2-3 months are investments, and the later part of the fellowship is always going to be a encashment for your clinical and surgical work. Surgical, it has to be a stepwise progress. Complications always happen. Do remember those, but do revisit those. Any complications, go back, have a discussion with your mentor, why this happened and how can I prevent it for the next occasion. Genuinely put your log into the picture starting from day one. It doesn't happen later on. So starting from day one, you should put your log, including the timings. Revisit periodically, mark your goals. Sorry, I lost my screen here. Revisit periodically and mark your goals. So have a candid discussion with your boss. If 3 months time you're putting your maximum efforts, but the reciprocation not happening, it's a good time to have candid discussion with your boss about what your perspectives are for another 9 months. Video libraries are important, which you can actually encash upon, and visiting observerships are also something which are important. Most important, primum non nocere, that should be culminated. For the research, important is to have day one goal, that to put something in the IEC, as Dr. Anup Kumar sir was saying, some publications are mandatory into the fellowships. So IEC projects, RCT, something you need to do. It's not something which you should start at the mid zone of your fellowship. It has to happen on day one. Prospective data maintenance, collaborative data maintenance, especially Verticity Foundation offers VCQ database. All these things are important. Take help from your colleagues, anesthetists, PG student, observers, rope them in for some collaborative work, and you will be able to pull out some papers and discussions. Shorter the time of realization for this, important it is for a better culmination. Academic wise, important is to have presentation. My boss was very clear, Gagan sir was very clear. You send a paper for submission. If it gets selected, you are free to go for n number of conferences during the fellowship. I actually ended up presenting 18 papers in that fellowship, including working on the robot as well. So and other works as well. So art of presenting is something which you need to be learning. It's a wholesome event. I remember me and Dr. Abhishek were discussing about this. I always used to look forward to him for all my career path when I was a fellow, and we used to have candid discussion always. He always used to say clinical and academic has to go hand in hand, or surgical and academic has to go hand in hand. If any of the domain is lacking, you need to improvise on something. Publications are obviously the end product. So do not end at presentation. Culminate into a complete publication at the end of it. That is the completion of the job. Important is to have video editing, which I just saw a fantastic video from someone who was an edited video, which was animated format of video, which is an easy way of showing it to your patients for a better understanding. That these are all soft skills which you need to understand as a part of your consultant career, as a step before the consultant career. Book chapters. I remember we are sitting at the Mecca of Urology. Dr. Ganpule had written a monogram series, and as a fellow in robotic, early fellow in robotic in India, I had written a book chapter on robotic instrumentations, draping, and everything. So all these things will start as a picture. You will understand about how the draping is done, how the sterilization is done. These are all small points which will help you for a better understanding as a consultant. Guidelines. Try and culminate yourself into the guidelines. Try and reciprocate into something or the other. There are a lot of opportunities available. If you have a landmark publications, it's always better to write to the editor of the guideline that we have this publication. It's my own story, that's why I'm putting it here. I wrote a paper on transperineal and transrectal biopsy comparisons, and that was one of the good papers. We wrote to the EAU prostate cancer panel guidelines, and they incorporated in which is cited in my name. That is one lifetime opportunity, I would say. So all these things are important and counting for your important bits of the fellowship. And last slide on the career path. Important is to have accreditations. Very, very important. Again, I'll give you a quick nuance of it. When we were the initial fellows of Verticity Foundation. After I ended my fellowship, I wrote a log. I submitted it to the Verticity Foundation. It was certified to Bhandari sir, and then we submitted to Intuitive. Until then, the Intuitive never used to certify as a fellow, as a complete fellow for a year. But after that, every fellow started getting a certification as a fellow when I had put in efforts in the beginning. So all these things would count because you have invested your time, culminate into a better understanding for that subsequent use. Mentors' recommendation are very important. So these mentors are going to stay with you forever. It's not just one year job. They are going to be with you forever. Everywhere they are going to be behind, taking your, as in supporting you for all your decisions. Next timeline I will say is after that fellowship, you need to choose a professional mentor for your career as well. That's my last slide. Important is to have patient footfall. Years of investment is very, very important. So stick to what you're doing. Focus on your city, focus on your type of practice, and try and put your efforts as best as possible. Be patient initially. Leadership qualities and educational contribution, all these things go hand in hand, and I think that's it. Thank you so much.
Very well put across, Ashwin. That is how two people doing the same fellowship or two people doing the same MCH program differ. So the race is really of millimeters, and unless you are ready to extract, people are not willing to give it to you. So with that, we proceed to the star talk of the session. So can we have the Zoom screen on, and can we have Dr. Bhandari sir's screen? So for the last talk, I call upon Dr. Mahendra Bhandari sir. He needs no introduction to this august audience. All we can say, he is the real Bhishma Pitama in terms of teaching the younger urologist. And he will be deliberating on developing a skill set or developing a philosophy that will last you for life. Sir, over to you.
Thank you, Pankaj. Am I audible? Am I audible,
sir?
Okay. Pankaj, Abhishek, Ashwin, Mahesh, Ravindra, what a pleasure and delight it is to be talking to you guys. Only my anguish is that Abhishek did not give me enough time to be there physically, because I have no qualms about travel. I could have, with the name of Nadia, I would have jumped in the next flight and come there. Anyway, I've been watching this Young Urology Association, and some of you may recall my earlier talk, Abhishek, and I'm sure you were there when I said that you need to define what is young. And I'm looking forward to many of you, when age will catch up, you would still continue to have the same enthusiasm as you are having now.
Mm-hmm.
I heard this discussion with great interest, and Abhishek had given me a shopping list of what he would like me to talk about. What we are talking is about fellowship, training. Let's get to the fundamentals. Fellowships have two objectives. One is accreditation in your CV, which is mandatory. Like US, if you want to go for academic position, you need to have a fellowship. It wasn't that before. So that objective, let's keep apart. And I'll remind Mahesh of our times, there were no fellowships. I was just made to think about. And how did it work? It was a designer kind of decisions, you know. I'll give an example. In 96, 95, I was at SGPGI, and the molecular biology was creeping in, which we were never taught in the medical schools. And I said, really, I was upset that I was not able to understand most of the journal clubs. And I predicted that if I don't do it, maybe I won't be able to understand my own specialty, and decided to do 1 year lab fellowship with Perinch Narayan in Gainesville. So that was the designer concept. Now, let me take you out of the well of urology. I get it that specialties have been designed to scale depth, but the mentors never thought that we lose the breadth. And if you see the urology in the perspective of life, it's only a one event, you know. I don't think I'm trying to dissuade from your dedication to the specialty on, but it is to be taken with a pinch of salt. Besides what the people talked about, there is one thing I'll tell you. The basic is that you have to build, besides your skill set, the credibility as a person. I'll use my own example. It may not work in. I went to Europe first time in 1979. I was already associate professor at Zipmar, and there was a fascination for going. I had my shopping list. I wanted to learn workbench surgery. I wanted to learn transplant. I wanted to see the craze in 79 was long-term transmission of the surgical procedures in technology. I wanted to learn oncology at the Royal Marsden, and I had an opportunity to go, but most of it was done, it happened, because I created a mentor in Lennart Anderson at Karolinska. I never worked with him, but he was the chairman of the department. He gave me contact wrote letter to Lars Roll, who taught me the workbench surgery. And from there, he wrote to Meyer to go and watch the thing. So one thing I would like you to say, differentiate between developing skill sets and doing a fellowship. I'm not trying to pit one against the other. And I think most of the speakers talked about the quality. Ultimately, there are two players in the whole game. One of them is the surgeon himself, and the second player is the patient. In my career of 50 years, whether it's US or United States or UK, no patient innately comes to you with the dictation. Do percutaneous for me. Do IR and RIRs for me. If they ask for robotics, it's not because they know anything about robotics, even I can tell for American patient, but they have read it in papers, they have heard from other clinicians, and they are in rat race. Particularly in India, they come with a very simple problem that I have this stone, you remove this stone, and they come because of the credibility of X, Y, or Z. We make it complicated by telling, oh, you have a staghorn stone. Now, after that, the ball is in your domain. And I would rather go as a patient to somebody who has all the options with him. If there is a stone, I would like to go to Nadia, where they are proficient in open surgery. They can do anything percutaneously. They can do robotically. They may even decide not to do anything. So my advice to the youngsters would be develop as many options as possible with the focus to give the best to the patient. Anything debate that this is better and that is better. I don't remember with the story of stricture, any technique has gone out of vogue, which worked at some point in time. And same thing is true. Tell me any surgeon in the world where I worked with the best, where they never needed to do open surgery or refer the patient for the open surgery. Yes, spectrum is becoming. So what you should do should depend upon what kind of what is that appropriately needed for that patient at that point in time, which will really answer the question what he requires to be done to take care of his ailment. Period. Besides that, it's all story. Now, let me talk a little about what I said that, can you see my screen?
Yes, sir. Yes, sir, we can see your screen, so please share the presentation.
Yes, I'll show you just now. Now, let us come out of rat hole. That's very important for me to tell you. If I have understood surgery, or anything in the life, I have understood that we should see something which nobody could see. Not even that, we should see something which we would not see with a normal eye. Don't trust too much on vision. That statement has no value that I have seen with my own eyes. You are talking of a very lopsided, two-dimensional vision of a camera. If you will trust your eye, you trust the camera, which you don't. So the point I want to say is that if you want to learn the urology, the best places to learn is not in the operating rooms, learning the life as it is. And you have to find stimuli. Don't make life flavorless. This is, we are very fond of trekking and we go for trails. And then you see the beauty of nature. Nobody asked this tree to break at this point. Another tree supporting it and giving you a gate. So that is the beauty of the nature. Now, how much time I can spend talking on this slide without any nonsense, because I don't know what is the basis of age and this. This is a STEM, but nature is so beautiful. It teaches all the spans of your life. Look at every piece of the nature. Look at it as a totality. And again, I'm bringing you, urology is not in isolation. God never created these specialties right when we came to this world. We created them for the convenience and for solid reasons, but don't ignore nature. And I was very happy to see one of the sessions in which people are talking about photography, cycling, business, entrepreneurship. If you want to be a complete person, you need to not isolate yourself as a urologist or a trans. Look at the beauty of the nature. How many of us have really appreciated time? We may spend time watching Kallenberg or some beautiful gardens in the world, but have we ever spent time to see the creation of the God? And we can just pass by telling, oh, this is one of the fungi, but really you see how much time you can spend watching this. This slide taught me the best lesson of my life, that how your life merges with the dust. There is a tree, and very soon it cannot be differentiated. My message to you is, have life, live life as a full, and family is very important for life. Learn from nature. And one question which I'll address, Abhishek, thank you for putting me in the company of Mahesh Desai and Amitabh Bachchan. He wanted a recipe that how we could keep his figure. I can't talk about Amitabh Bachchan, and we are no comparison to him, but I can talk definitely about Mahesh Desai. Mark my words, we never did anything to become something. We did at that point in time. Only thing what we did was we had the passion, we had the enthusiasm to do what we were doing, and we reached where we are. I don't even know where we are. It's only you guys remind that we are somewhere. So please keep your enthusiasm on. Try and not get formatted into this fellowship or that fellowship. Still, I would recommend designer thing is better, particularly with AI. Try and create your own menu, that what you as an individual would like to have. And have, has anybody ever asked a doctor who has done a good operation that whether he's an MCH or he's an FRCS? I don't think so. Ultimately, what matters is what you deliver to the patient. I would once again thank you for inviting me, and it was a pleasure participating in this session.
Thank you very much, sir. Just to bring this to audience notice, the last discussion sir was alluding to was an answer to the question that I put to him.
One more slide, I'll tell you.
Yes, sir.
Observation. any one of you would recognize that this is David's sculpture, made one of the famous sculptures. And David is a young warrior. But you see that only this hand shows his mood. An artist has tried to bring in. Learn in the life to develop non-body language. You should develop a power. I don't mean to say that I have that power, that without your speaking, people should have your aura before they open their mouth. Yes, sorry. Yeah, you can go ahead.
Thank you so much, sir. That was a wonderful deliberation, and I think every time the audience listen to you, they take home very valuable points, and therefore this lecture in the BioU meeting. So the last deliberation was actually an answer to the question that I put to sir, was what mindset do people like Amitabh Bachchan, Mahendra Bhandari and Mahesh Desai have that helps them last a career of 5 decades. So that is why he is trying to put it into perspective. But sir, one question still remains unanswered. If I, as somebody who's developing into a particular technology, what makes me take a bet at technology? Okay. So yes. Like if the Da Vinci robot came up in 2000, I had an access to it. But what made the people who believed in Da Vinci hang on to it? It was just gut, chance, or they actually thought about it?
I will quote Paris Castro here from Madrid, the father of ureteroscopy. And I was in the early days when we were using 14 French ureteroscope, and he had a fat nurse, anybody who was visiting, would sit on a water bag to give vision to him. And at that time, I spent about 2 weeks with Paris Castro, and I found him a very interesting guy. And one day he was using a 27 centimeter long scope in a percutaneous cystostomy to do antegrade transurethral resection of the prostate. So I said, he was working very closely with Karl Storch, and they were making prototypes for him. So I said, Paris, what is it, this nonsense? He said, we have to do a lot of nonsense to come out with the essence. The answer your thing, that nobody can answer which technology can work. I talked to Money Menon many times. Why did he think that the robotic surgery would be a reality? But it is definitely a gut feeling. And mind you, now gut has a brain of its own. If you read about microbiomes and latest, so gut feeling is no more a hoax. But all I would like to say, keep your eyes open. There is a difference between frontal vision and temporal vision. Keep your temporal vision as wide as you. You should know what is happening where. But when it comes to using a particular technology or adopting it, you have to have the filters, very rigid filters, because you are dealing with a living patient.
Right, sir. So we'll have some comments from Desai sir, and then we'll close the session.
Mahendra, it is so nice to see you. Wish you were here, and we would have given a lots of our experience and talked to the young urologists. You know, you've been pioneer. I would like to tell you, the last you did the course on AI in Hyderabad, and I joined the online classes and I passed the exam.
Congratulations.
Thanks to you. So hope to see you in Diwali time. I'm going to be there.
Right, definitely.
Thank you, sir. Indeed, you made the difference to this meeting. Thank you very much for sparing time for us, getting up early Saturday morning and spending time with us. Thank you very much, sir.
God bless you all. You will reach wherever it is, with fellowship or without fellowship. Don't worry.
Thank you very much, sir. With that, we close this session. For the next session on technology and interaction with the industry, I call upon Dr. Rohit Joshi, Dr. Tanuj Paul Bhatia,
and Dr. Parimal Garia.
Hey guys, this is for you. When? Where all are you going? This is for you. This is industry session. You guys need to come back after having a cup of tea, because this is what ultimately makes a relevance to you. Whenever you buy a new instrument or a new technology, this is going to make a difference to you. Anyway, let me invite. This is a session wherein it's named as Hard Talk. Yeah, I'm inviting everyone, sir. Yeah. So this talk is all about the hardships that a buyer faces from its vendors. Don't take it seriously. This session is about hard talk, so we'll be talking hard. So let me first invite Mr. Tyagi from IPG, Nirav from Quanta, Raymond from BioRed, Kishore from Boston Scientific, and Bhupen from Teleflex. Can I have my slides, please? Thank you so much, gentlemen, for accepting our invitation and being a part of this hard session. I know it is going to be a little hard on you, but that's what is the aim of this session, as Abhi and Sapni sir has conceived this to be. So first of all these 5 gentlemen, I am in the list of their buyers, so there is a conflict of interest, but I am only here to moderate things. My 2 friends, Tanuj and Parimal, are gonna asking you, rather screwing you with different questions. So I'll be there whenever I feel the talk is not as hard as that. So moving forward, there is no conflict of interest. First of all, Tanuj set up a new hospital recently, so he had some queries in his mind. Tanuj, over to you.
Yeah, so there is a lot of advertisement, there is a lot of promotion, and things happen. But if I have to buy a new equipment, what are the licenses that a equipment needs to have in India so that we can use it on our patient?
Tyagi, you to take this question.
See what happens, maybe before September 2021, we were all following the certifications of the different countries. But see, after this pandemic, the Indian government has been issued that every company either is manufacturing medical equipments in India or importing the medical equipments in India, then that has to be registered as a CDSO. So CDSO, basically, they have the 2 different categories. They have categorized ones to the manufacturer and another to the importers. So at the moment, basically, this registrations is mandatory for every company. Even without the registrations, no one can basically pass on these registrations. One thing, even some of the cases also some refurbished equipments which also been promoting in India. So after coming this certification, that all the refurbished promotion has been stopped. So I think now no one has to worry that's what certifications will be required from your end. So government already made it easy to everyone that they have made as a uniform certifications,
For refurbished, you said?
Yeah.
Refurbished?
Yeah, refurbished. In fact, I think now you cannot import.
You cannot import it. No. I think that clarity is important.
One question: this IPG machines trial happened in Russia and France, and you launched this machine in India. Yes, sir. But it got approval in the primary investigator, the lead investigator's country, far later than India. Yeah. What are your thoughts on that? Sir,
when we launched this machine, basically, that same was applicable in our case also. Like when we launched this machine, that certification was not being needed basically. But when this mandatory certification came, so we have also gone through the same process and we have obtained the certifications,
Right. Raymond and Nirav, you guys are into flexiscopes. So are these scopes manufactured by your company? Yourself?
No, sir.
Let's be honest about it. No problem. Yeah.
We are not manufacturing the flexible URS right now.
There is 3 things you can manufacture, you can market, and you can actually assemble. So let's be very clear about this and let us give this message to the listeners. So are you manufacturing? Yes, no. Are you assembling in India or are you just marketing?
I think there is one more component to it, sir.
Yeah.
Getting things, assembling and doing some R&D and making it more friendly for the Indian market. I think that is what some companies are doing. You can tell better.
So as a Welltech India Private Limited or Unique Medical Devices, we are not manufacturing flexible URS. Currently, we are importing things. But yes, that is the future planning. But right now, we are not manufacturing.
Okay. Parimal.
We are currently.
Raman, please.
Yes, we are currently importing the parts and we are assembling it here.
Sound.
Assembling it here, yes.
Correct.
You are only assembling it.
Okay. So Parimal, you had some the issues about different prices for different gentlemen. So what's your take here?
So are the prices are uniform for all the customers across India, or a senior or a junior or a high users or a low users, the prices are different?
Not exactly.
Raymond, what is
No,
the price
not
for KP? What is the price for me? What is the price for Aditya?
Sir has installed it in his hospital here at,
I think
at Ahmedabad, and it is the same.
Problem is only with one company.
Yeah.
Regarding this, so we should address this to that.
No, but
particular.
let's be very
Yeah,
clear. We
yeah.
accept whatsoever you tell. There is no. This is a forum. This is not recorded.
We are
Again.
giving
Right.
the
So we
same
can
price
give
across.
answers.
And there are, sir, urologist groups which are available wherein everyone is talking to each other and know the price openly. I don't think that anyone here will disagree that we have been given an
Correct. Gentlemen, the problem lies in ourselves. Tomorrow, if someone asks me price at which I bought a laser or a resume or urolip or a scope, I myself will not be inclined to share that prices. So let's introspect ourselves before this gentleman take advantage of that thing. We need to be transparent. We need to share our prices. Tyagi, your machine is sold out to different zones of India at a vast different price.
Sir, basically, now the basic question is, what is your pricing strategy? See, basically, we always tries to maintain the uniform price everywhere. And our efforts also basically as a doing the same efforts, like we have the uniform quotations. So we never change the quotations. So either the same quotations we are sending to the corporate hospital, and we are also sending to the private clinicians. Yes, there will be the the different structures may be different for the corporate hospitals. Basically in the purchase there are the certain involvements. But see, ultimately, if we talk about as an end user or for the private clinicians, I think that is as a fact that we don't like to any price disparity actually.
Okay, so there is difference in dollar and euro and in INR. So are your companies, I'm talking about all 5 companies, so are you sensitive about the Indian market as compared to the Western market? Because things are different there, and we are economically sensitive country.
Yeah,
so
sir, see, IPG is basically when they decided to launch this product as a globally. I think we launched this product before the launching the IPG through the Olympus in US. And 2018, we have launched this product through the IPG in India.
So IPG has no difference whether Mahesh Desai sir wants an IPG or whether Nitesh Kumar from Bihar wants an IPG machine.
Sir, our efforts basically. But see, one thing I would like to request you, see, always be at the regard. But in the regard and respect, that may not be the much difference actually. It may be as a little bit like sometimes maybe some thousands of the amount which we can try to oblige. That's all, nothing else.
Friends, I'll give you a small example. One of my teacher of my general surgery, he is in love of surgery. So he is a very good surgeon. We all know from Ahmedabad, Dr. Pankaj Modi. But his love for surgery is so much that he will at times do surgery is complicated for free of charge because of the love of surgery. But because of that kind of love for surgery, the next person who is sitting next door may suffer. So that is why this regard, respect, I understand, full due respect to sir and everyone. But that has to go to his residence as well.
Sir, we like, for example, will you not believe, specifically like MPUH and specifically all the alumni of the MPUH also, we try to maintain as the same pricings to them.
So thank you so much. So let us note this down. Now henceforward, whatever price he is going to offer to the faculties or the respected the Amitabh Bachchans, same will be offered to a newcomer. Yeah. So let's make it a note. Kandarba, you had something to tell. Yeah, please. Very brief.
Okay. I disagree with this, Mr. Tyagi, and I think we have to be very, very honest to ourselves. Maybe it is Rohit who is buying, Sir is buying, or me, or any of you. This is a competitive world. We have to understand one thing. There is theoretically, it sounds very good that one India, one price. And for the junior colleagues, I think that sometimes the price quoted are very high. For some senior people, like if I want to buy RIRS, probably my prices will be slightly different because the kind of the numbers I'm doing and the purchase I make. I may be buying 100 scopes in a year or maybe 50 scopes in a year. My price will definitely be different than somebody buying only one scope. So I think we have to understand that. Of course, there should not be a very wide gap between these. Theoretically, it is very fine. Everybody will say that we have got only one price, but everybody put your hand on your heart and tell that the day the company people will come to you when you negotiate, he will say, sir, this is the price for you. Don't disclose. And sometimes we do not disclose also. And we want others to know the exact price he wants to buy. He will do the same thing. So I think let us understand that theoretically it sounds excellent. Philosophically it is very good, but practically it is not possible. And
Yes,
this
yeah.
problem, this is going to stay.
So when
I'm
Nirmala's-
sure that Rohit,
yeah,
you bought a resume at that price. I know the price, okay? That price, but
This is the problem of having
but
a-
that price I think you will not disclose, and I'm sure that nobody will get that price also. So you have to understand that, okay?
So
Sir,
that is also very,
do
very
you agree with
relevant
this point, sir?
Yes, yes. KB, we have got a lot of things, so we'll just move forward. But whenever, yes, sir. All to you, sir. Yeah, please.
I think they all know that we are a charitable hospital, and whatever we want, we love technology, and then they also know that not only because they also have a love to the patient if they done. Secondly, we get a donation to buy that machine, and third thing, we do the clinical trial on this patient and come out with a paper which is published nationally and sometimes internationally. So all the advantages at both the party, and then if we tell them, and for example, I have 2 machine of it.
Correct.
Because I'm asking a 3rd machine for a clinical. So I mean, why it is given to us has
It is rational.
many purposes. So sometimes they identify with our cause and they give us something.
So friends, this is a lesson that, probably tomorrow, if you want to buy a machine, you might get a little higher price, but because, sir, he's supporting academically to the company itself. So there are so many reasons. Yeah, Tanuj, something on this?
So this question is mainly for the laser manufacturers. So how much warranty do you offer as a standard after purchase, and what all is not covered in the warranty for a laser?
Nirav.
Yeah, for any laser, as a market standard,
Generally, sir, company provides 1 year warranty.
1 year warranty.
1 year, there is standard warranty. Now it up to the customer how much warranty they required. So based on that, the price will fluctuate. So a company provide 1 year warranty, and above whatever warranty we provide, that is a Indian company provide, and they will take all the responsibilities. Now, what is covered in the warranty? If you say about contact
What
laser
is
machine,
not covered in the
what
warranty?
is so
That
only
is more
consumable, only consumable that comes the fibers and blast shield. These are 2 things which comes under consumables that not covered under warranty. Rest all the items covered under warranty.
Okay.
Yeah, Parimal.
I would also say the same thing, but any apart from manufacturing defects, things will not be covered. So if there is a damage, physical damage there, which we have also seen in our, then there is
Physical damage means
if,
wear and tear.
If the screen breaks or something due to person error.
So there are complaints about a flexible ureteroscope or a laser or things that the decision of a physical damage. Who decides that what is a physical damage? This is done by a user, or it is done a manufacturing defect, or because there are complaints about things that once things goes wrong, the company blames to the person or a urologist that you have done a physical damage, whereas a person thinks that it is not a physical damage, it's a manufacturing defect.
Sir, the answer is
Make it clear, if your
yeah,
scope goes down the first case,
I
you
tell you,
replace,
sir.
but if it goes down in second case, would you replace?
No, sir.
Say it no.
So-
For example, whenever something goes wrong, your scope first case it is on them, second case onward it's on us.
So at times, from their aspect also, Nirav has faced this situation. Let me share this with them. He has, been in deep waters. He had been, supplying certain companies scopes, and there were some issues with the scopes. And we should actually, appreciate him that he probably exchanged so many scopes, and then he stopped getting those scopes. So there are instances, but at the same time, there are a couple of urology friends who use it for say 5-7 cases. In the 8 case, the scope goes. The other person who is using it for more than 20, he will complain that why my scope is not lasting more than 7 cases. So we have to introspect ourselves. We can't do everything to the company. Am I correct, Nirav?
Yes, sir. Thank you so much, sir.
Yeah, sir. Sir, you want a question, please, sir?
Regarding the pricing, they should, all of them, you are businessmen. You will want profit. Disagree with that. But there is a basic price which has to be there, which includes your profit. That price has to be uniform. If you are giving to MPOH for charitable purpose, you are losing on your profit and giving. That's agreeable. You can cut down on your profits or whatever, that is agreeable. But you should not increase the price above your profit. That's not happening. The price is definitely not uniform because your margin of profit will differ from what you give it to a senior or what you give it to a junior.
Whom you want to answer this question?
Anybody, all of them do
Is there
that.
any?
No, all of them do that. All of them. I am telling you, all of them do that.
So who will volunteer to answer? Open, you have been quite silent. Please answer this. Yeah.
It's like the price of a defense equipment. You never know what is the real price.
No one knows.
You only see the quotation and you get discount from the quotation.
I will get what Kishore is asking. No company is going to give to any institute or anywhere at loss. That is for certain. Even if they tell you that we are making a loss on this, you don't have to believe it. Now they will give you at certain. Only thing is margin of profit is going to be different. Now it is completely dependent on your ability to negotiate. See, if you have ability to negotiate, they will reduce the profit margin.
Yeah,
if you have no ability, if you have no power, if you have
join
nothing
finance con.
to this, your ability to
Hello.
make sure that they reduce the price, you will get at a higher price.
That is what I am telling, that the juniors will not have the power of negotiation than the seniors. So that is what I am telling. There should be a basic price at which they offer to all of them. For the people who have the power of negotiation or charitable, they can come down on their profits. So it does not vary too much.
This discussion we had, and I had a meeting with a lot of people. We were thinking of this what is the price, and we had you were also part of it. And all companies said that our price is absolutely uniform. Now, whoever is the junior most person who has no ability to negotiate, that price is a basic price.
Correct. So
you understand? So that is the maximum price you get. So that is a basic price.
So Sabni sir, we
Now,
need to
there is
have
no way.
two things: MSP, that is minimum selling price, and the maximum selling price.
There is nothing like minimum.
So
what basic price you are deciding
yes,
is what the junior most person is getting.
Sir, there are some PG packs. If you make the total of the PG packs price, it's cheaper than individual cost. Person was with me, he bought a PG pack and I bought same scope from the same company. I got it at a higher rate.
Sir, but in that pack, even I got a 9.8 French urethral scope. What use it is?
They work on numbers.
They are
See, the
just
PG pack, they work on numbers. There are 400 PGs who pass out or 500 PGs who pass out. So they are looking at numbers. They are looking at numbers. If they are selling 400, if they are selling 400 equipments, obviously their prices, they are making money in numbers.
So friends, yeah. So friends, you want to wind up? Yeah, fine. Yeah. So friends, a little lesson is, if at all you want to buy a laser, ask Mr. Tyagi, Mr. Nirav, and Mr. Kishore all at the same time in your OPD. Make them sit in your waiting room side by side and call all of them independently. Give them check ready for you. You fill the amount. You fill the amount. You fill the amount. Get the best possible price. Ask your faculty. They will share the price at what they get and the minimum profit. Once you freeze that price, then you get back. Don't pay. Don't get the check. Don't give the check. Then you get back to the minimum disposables he will supply to you.
how many delays if ever 2 से 4 करो 4 से 5 करो 6 करो उसके बाद get back to the warranty. Now your machine price is fixed, this many disposable you were given, now you give me 5-year warranty, and after that 5-year warranty you still get something more, that now you will be required to give us some educational grant to conduct academic program. So this is how you should be bargaining. Am I correct, sir?
Yeah, I think no, sir, but
This is how, so always call all of them together and always, you know, make them sit together, and if still you are not convinced, then you can, otherwise, still if it is not okay, then you please join the Eurofinance group and then you will learn better. Okay, next thing is the most relevant part is once you buy the machine, at the time before you buy the machine, you are the boss. The moment you buy the machine, they are the boss. So इनसे पहले मेरे 10 फोन पे त्यागी जी तुरंत फोन उठा लेते थे, मैं उनके 20 फोन नहीं उठाता था, लेकिन the moment I bought this laser, अब वो थोड़े खींचने रहते हैं, फोन नहीं उठाते हैं, तो ये सब चलता रहता है। कभी-कभी सीनियर लोग के फोन उठा रहे, तो मेरे को फोन करते हैं, चवलानी साहब ने बोला कि रोहित यार त्यागी जी फोन नहीं उठाते, बोला सर मेरा भी नहीं उठाते। So this is ultimately, you know, it boils down to once you pay them the rupee, now they are your boss. So how about service, Parimal?
Only one thing if I may add, to a wider audience. When we are buying some heavy equipment like laser, ultrasound machine, etc., always buy with an extended warranty.
Correct.
That point of time,
see, that's what Rohit sir said. It's a whole exercise. The take-home message is, it is going to be exercise. You have to do it. You have to, you know, spend time with them, understand their issues also. That way you can get a good deal. If you're a teaching institute, if you are a research institute, you can definitely.
it's very difficult for you beginners and
Yes.
Correct, sir.
Yes.
There are subspecialty training program in this also, sir. So
Yes.
we can add one
So,
subspecialty. Last question, Parimal, this is
sir,
about you.
regarding service backup, I think we'll let Dr. Mr. Kishore answer that, because Boston is one company where everyone is facing this issue. Service is a major issue with Boston right now. If service is available, parts are not available, fibers are not available. There are a lot of issues users are facing with Boston. So can you answer that? And this is after Luminous has been taken over by Boston Scientific.
Yes, yes. So again, yes, sir, we acknowledge and apologize for whatever inconvenience has happened, and it's majorly because of the transition from Luminous to Boston Scientific. So there's a lot of transition which has had to happen, cultural changes, team changes, training changes, a lot of processes have changed. And so also, like I've been with Boston Scientific for 13 years now, and I can tell you Boston Scientific is not primarily an organization which has sold high-level capital equipment for a long time. I mean, we are more of a consumable company. So again, now Boston Scientific is understanding now that business as well, the service, importance of service and all. While we acknowledge and apologize for what happened, you will see a lot of change in the next 6 months. And because we have put in processes for that, we have trained our service personnel. Now there are 12 people across India who are service engineers who are based in different cities. And in those cities, you will see within 24 hours, the first response will be there. And for those cities where they are not based, it will be at least between 24 to 48 hours, there will be a first response. And this is the assurance which we are going in, sir, going forward.
So
And
friends,
you will definitely see
so
improvement.
whenever you buy a new machine, you have to know your machine. You need to know the spare parts which are in your machine, because many times the spare parts are not available. So you need to know each and every part, whether it is available or not. If it is not available, I can complain to Government of India. My cath lab has a problem, so cath lab's part was not available. I filed a grievance in Government of India. They had to make it available. For first 5 years, they have to make the spare parts available. Last questions, I know about it. One question, Bhupen. See, our USI registration rate for us as an Indian urologist, maybe in 10,000s or 8,000 or 12,000, but the same thing is for a non-resident Indian or some outside, from somebody from USA, maybe $600, $800. Same thing is your Teleflex has come a big way with Urolift. Now those implants, you may be selling in USA at certain price, but if those implants are 1 lakh per implant, will it be challenged in India? So please.
Sir, you need to look at the regulations. So our prices in India are not decided by what we sell in US, Europe, or anywhere. It is basically decided what we are saying to in India. It's a consumable product, so you need to know that as a company, we need to fix a MRP for that product. Once we fix that MRP, we cannot change that MRP for 1 year. So 1 year that price is fixed for you. Then we need to look at the fluctuation of the dollar also. So for us, if I'm fixing up a price on 1st January 2024 for a euro left, it is fixed for 31st of December 2024. We are not going to whether dollar fluctuates or it goes out the roof or anything. The price of that will not change because I've already fixed up the MRP and which has been communicated to the government of India and they know that what price I'm selling it. So that is where we cannot kind of like,
But
as
then-
you asked for the pricing of the, you asked me previously, every company is here to make profit, everyone. At the end of the day, hospital owners, company owners and everything, you're looking at a bottom line. It is not customer specific. It is at the bottom line, what profit I'm going to earn. And that is how the companies do the business or any hospital do the business. So it is not, specific to the people. It is always look at the bottom line. Thank you.
I thank every participant. This was a very, very innovatively planned concept, and then it actually got executed in a way what Abhi and Sabri sir wanted it. I thank you all for participating and facing these hard questions. I think we all took certain questions from you. Because of the lack of time, we might not be able to take it. Yeah.
Company people are sitting here. One question: the thulium fiber laser is available in 35 watt in only one machine. Why is it not available in 35 watt in different companies? Like all the other companies have got a 60 watt or higher watt machine. The urologist, young urologist, who are doing mainly the stone, want a 35 watt machine, not a 60 watt or 100 watt machine. Is there any technical reason behind that?
Actually, I would like to clear it here. In fact, I think everyone should be aware about the thulium fiber technology, which has been invented by the IPG. And the IPG is not like as a company which are being outsourcing the source of the laser. So the important things we have to understand here, basically, the IPG is a manufacturing company, which is not as a marketing company. So they manufacturing basically the source is starting from 35 watt, 60 watt, and 120 watt, basically. So that won't be possible. I'm damn sure if in future it happens also, so that will be only possible if someone maybe collaborate in terms of the technically with the IPG for the laser source. So yeah. So
I'm sorry, I won't be able to take any questions. Please understand.
Yeah.
And Tagiji, I'll have to close this session. But on a note that this entire session was planned as a confidence building measure between the urologist and the industry. So I really appreciate your contribution. This will just build up the confidence between the buyer and the seller. Thank you so much. Thank you. And Dr. Parimal, Dr. Tanuj, and Rohit sir, this is a wonderful effort. Thank you very much.
आपके बाजू में मेरा वैल्यू बढ़ जाएगा। हाँ ये भी है, मैं फीका पड़ जाऊंगा।
Thank you.
Thank you.
For the whole day long, we've been speaking, and the senior faculty member have been listening to what we have to share. But this is the last but the most important session of the day, where we'll get the nectar from the experience. And that is how this session is called the Wisdom Corner. For the first deliberation of this session, I call upon Dr. Rajiv TP sir to speak on what I would have done differently if I were to choose my subspecialty again. Sir, over to you.
Respected Chair, my seniors,
and dear friends. First of all, at the outset, I would like to thank the youth of USI for inviting me, and they have assigned me this talk to say that I have to speak on this. So the topic assigned is what I would have done differently if I have to choose my subspecialty again, and why so. Why choose a medical profession? First of all, it's a deeply a personal decision, which is influenced basically by perseverance and genuine passion. Now, how you can give back to the society? It's a desire to touch people's life with opportunity to heal and alleviate sufferings. Again, there is an intellectual challenge here because medical profession is a continuously evolving field with new research, technologies and treatments every fortnight. And this is quite appealing for an intellectual stimulation and skill challenge. Again, everyone has the feeling that medical profession, there is a lifelong job stability and security. It's an essential service. Hence, there is a stable employment opportunity in all time frames. Again, most of all on this financial rewards, there is a constant financial stability and a potential for comfortable competitive income compared to all other professions. Again, there is a respect from the community, patients' gratitude over and above, and again, a professional pride. Wherever you go, this goes hand in hand. Again, personal gratification, sheer interest in one's life's decision, standing firmly with it, happiness, and this brings a profound sense of fulfillment in your life. Now coming to broad surgical specialty, what making of a surgeon. General surgery is the broad mother specialty for all of us. It's a central core embracing anatomy, physiology, pathology, there is wound healing, intensive care, and all this are carried forward into our surgical super specialties. There is a versatile knowledge in diagnosis, pre-operative, post-operative care. Few career paths offer the same personal and professional satisfaction like that of a surgeon. Now coming to the transportation or migration from broad specialty to super specialty. Broad surgical specialties encompass a vast array of medical disciplines, each with its own unique focus and expertise. There is a comprehensive understanding of surgical disciplines, which is crucial to navigate surgical complexities and also determine specific areas with one's niche. A shift from broad surgical specialty to subspecialty, this helps us to embrace exclusivities with complexities. Now, why need of a super specialty arose? This is because of aspiration to address complex diseases with expertise, providing a sturdy platform for advanced research, desire for advanced clinical training and teaching experiences, and exclusivity in the field, which will translate to ultimately to a lucrative remunerations and profits. And it also helps deliver focused and extensive care in opted specialized field, which can translate into good clinical outcomes also for the patients. Why opt for urology as a super specialty? It's a specialty with a wide spectrum of surgical opportunities, which range from office practice to minimally invasive endoscopies, to minuscule circumcision or DJ stenting, to exhaustive radical cystectomy and all demanding renal transplantation. Paramount demand due to ever-increasing urological problems throughout all age groups. It doesn't exclude a single age group, and with no dearth of patients in one's field of interest. Attraction again for state-of-the-art technologies and new age developments, and it is ranked highest amongst the surgical specialty when you count on the happiness index by various lifestyle reports. Educate professional and personal life balance is there if you quite take care of it. Hence, urologists are termed as the coolest surgeons to hang out with. A super specialty with innumerable branches. When you compare with all other surgical super specialties, urology is one of the branch which has got various sub branches like neurourology, minimally invasive urology, renal transplant, endourology, reconstructive urology, uro-oncology, enterology, urogynecology, pediatric urology, etc., etc. Why did I choose urology first of all? Starting of the 21st decade, being a young urologist, amongst the toughest stream to get into, when I applied for the AIMS New Delhi, there was only one seat and I have to compete and get selected to the All India Institute of Medical Sciences, which was my dream. And I embraced that with challenge. Priorities early in my career, early settlement, professional gratification, lesser mortalities, morbidities, fewer emergency calls, good results, and higher patient satisfaction. Balancing career opportunities with family commitment, financial stability at a quite young age, flexible practice, choice to go all in or stay at a low level. Factors weighed in for choosing a subspecialty: high reward, low risk stream with limited morbidity, limited investment, yet manifold outcomes, place of settlement, easy acceptance, potential frame in small tricks. You can settle in a rural area, you can settle in a taluk, you can settle in a small town, and you can settle in a place like Delhi or Bombay. Start of family life, desire to carry family along with career. So what was in front of me? Subspecialties that snugly fit my criteria or conditions. These were at that moment of time endourology or uro-oncology. So market shift from at that point of time from open to minimally invasive procedures. It was just started shifting from open to minimally invasive. Revolutionary technology started pouring in, like PCNL. I think the workshop on PCNL or minimally invasive way back in 1989 in Nadiad was a shift in India or in the South Asian countries to shift from open surgery to minimally invasive urology for the management of stones. Concept of RIRS and laser was gaining momentum then, embracing technological challenges with precision, which India ranked above the other urologists across the world, where the PCN punctures under fluoroscopy, later by ultrasound. Indian urologists were very precise, whereas in other parts of the world, it was the interventional radiologist who was doing this work for the urologists. Unmatched patient satisfaction with favorable outcomes. Settlement in a stone belt. I settled in a stone belt, Northeast India. No dearth of cases for professional growth. Kick-started freelancing. Fulfilled early settlement, ensuring stable financials. Complex and institutional management. Why uro-oncology? Attractions noticed in uro-oncology. Complex and intensive management ideal for an institutional practice. Intellectual stimulation and higher gratification. It provides high quality specialized healthcare, ensured longer follow-up. If you have research interest, testing updated guidelines contributing to advancements, employment of cutting-edge technologies for improved outcomes. It basically was an institutional practice with enhanced experience in intricacy management. And when you are an institution, you master complex surgical procedures, which again enhance professional fulfillment, because I was in a government setup which allowed private practice. So I had the combination of both. But other subspecialties at that point of time lacked attention. Why? Tedious subspecialties with complex and cumbersome outcomes. Reconstructive urology, renal transplantation, this demanded time and constant attention while lacking supportive framework in early 2000s. If you do a long reconstructive procedures outside your institution in the private setup, it is a headache till the patient goes home well. No desire to become jack of all trades. I was a young urologist, hence anchored on well-versed, well-accepted loco-regional subspecialty. Conscious avoidance of chunky subdivisions like neurourology and transplantation early in my career, I was trying to attempt at achieving a work-life balance. Basically, a technological enthusiast was captivated by new and upcoming innovative technologies in the field of interest. Retrospectively, as I think, demand of other subspecialties was nascent when my journey began in urology. And as a doctor ages, several changes can occur. It often occurs too. It is influenced by basically both personal aspirations and professional factors. Natural career progression, each stage offers you opportunities for continued learning, leadership, and contribution to healthcare system. Now comes when you age, there are certain roles and responsibilities which come into you. Specialized and leadership roles as experience and expertise sets in. It shifts from clinical work into administrative policy makers on teaching responsibilities. I have to take the administrative responsibilities as the head of the department. And I roamed into the Urological Society of India with more responsibility. So I have to switch over some part of my clinical work to administrative policies. Work-life balance again seeks role with more flexibility and reduced clinical hours while still meaningfully contributing their expertise. Because in my house, when I was the secretary, I shifted out from my finish. My wife was telling me, now no more USI in at home. Health impact, aging brings physical and mental health challenges, preventive healthcare measures, and personal wellness practices while continuing to serve. When I was a young urologist, no one used to go to gym or other thing. Everyone now, see the young urologists, they keep some time for the maintenance of that. Go to gym at 8:30 p.m. in the evening. Sorry. Legacy, it's 15 minutes. Legacy and mentorship, upliftment of younger healthcare professionals and contributing to research to improve. I'm very happy to see my baby has come into adolescent now. Paradigm shift into today's world. This is a quote by a urologist. For many of us, we enjoy spending time in the operating rooms, discussing in WhatsApp what I have done today, what big surgery I have done. I have removed 8 kg tumor. After all, we are surgeons, but many of us also enjoy interactions with our patients. I love to seek my folks, especially the ones I have been seeing for the past 25 years, come back every year to chat about all kinds of things. It's a nourishment. As I ventured into depth of urology, tackling agonies of patients, long-term relationship with patients and colleagues I built became my rewards. Priorities shifted with experience. Craving to explore other interests started gaining foothold. Now, paradigm shift, experience and acceptance, reasons to embracing shift, elect sense of fulfillment in well-versed fields, joy of exploring upcoming fields and adopt enhanced technology and interesting surgical techniques, down gear focus on better work-life balance, and again supporting spouses career too, and contributing to my family affairs. My wife is doing MBA at the moment. I am supporting her to do the MBA. Look out for low risk, high reward fields, safety guided selection to avoid unnecessary stress, contributing to research and advancements in treatment modalities, desire to deliver best healthcare and expertise. Now, reconstructive urology and renal transplant have been extensively dealt with in recent years at par with centers of excellence. Untrust issues pertaining to female urology, neurourology is catching attention with intensive research work and collaboration interdepartmental efforts are going on. Institutional framework has been built. Currently, enterology and minimally invasive advancements have caught my attention. Looking forward for gaining depth in these fields. Developing interpersonal relationship with growing awareness amongst patients and to support learning of residents. I profess to provide high quality care while building long-term relationship, flexible ergonomics with strong understanding of melody, adopting novel modalities to better deliver best of care, handling professional and emotional growth of residents with dexterity. Now, mentoring new generations. I'm an advocate for mentoring young urologists in this vast branch for refining their skills, something not possible just with individual effort, but needs help from all strata. Mentors and support networks foster a collaborative environment for professional development. Professional associations, USI provides resources, guidelines, and networking opportunity for urologists. Fellowships, these are the various fellowships and other things which has been offered by USI at this moment. Now it is my last one, I promise. What has recently caught my attention? Enterology. There is an increased public awareness and acceptance of sexual problem. This has led to increment in help-seeking patients. Current lifestyle leading to gross increment in patients count. Solving male infertility, which affects over 60% of all married men worldwide. Unmeasurable patient satisfaction in this field. Collaboration with IVF specialists for holistic infertility management. Overlooks diagnostics as well as therapeutics. Effective nature lacks emergency procedures. Ideal white-collar time-bound job, adequate time for self, growing field with evolving technologies which are here every month, newer drug modalities, which is an area for knowledge enhancement, psychosocial counseling for a range of sexual health problems, from fear of sexual intercourse to psychogenic erectile dysfunction, premature ejaculation. So to conclude, urology is a lucrative field offering various levels of financial compensation with great job and personal satisfaction. There is a flexibility to offer small procedures. One can survive even during meatal calibration and circumcision and to cystolithotrypsies, or exhaustive operations like robotic assisted radical prostatectomy and RPLND and other things. But what matters is adequate mulla at each stage, contributed to Gregorianus of urologists who was known as Mutra Rog Visheshagya, sheer patient volume, strong factor for young graduates to opt no dearth in any subfield, and even the NEET has proven that it is one of the only super specialities where seats are not falling vacant even in remote DNB centers. Thank you for your patience.
Thank you, sir. So these are orations, so we'll not take any questions. Thank you very much, sir. That was insightful. That will help people make decisions. Moving ahead to the next talk by none other than Professor Mahesh Desai, sir, on crossing the bridge of insecurities, embarking on a new procedure. And he's not done it once, twice, but innumerable times in his own career.
Thank you, Abhishek, Abhijit, and friends. It is so nice to see the auditorium full. You know, it's been a wonderful day listening to all the people. It has been a tremendous pleasure. Now, he gave me a title, Crossing the Bridge of Insecurity, Embarking on a New Procedure. Thank you, Abhishek. That made me work a little bit. Today I'm going to talk about the journey we all have taken at some point in our lives. Crossing the bridge of insecurity. The bridge represents the uncertain terrain we face when we venture into a new experience, relationship, or a pursuit. As we stand at the edge of the bridge, we often feel the weight of our insecurity bearing down on us. Fear of failure, fear of rejection, fear of unknown. These doubts can be overwhelming, but it is precisely in this moment that we have a choice to let our insecurities hold us back or to push forward, embarking on a new procedure. Crossing the bridge requires a courage, self-reflection, and willingness to grow. It means acknowledging our insecurities and confronting them head on. It means recognizing that our worth and value come not from the external validation, from our own resilience and determination. As we take our first step on this bridge, we may stumble, we may face setback and disappointment, but with each step, we grow stronger, more confident, more self-assured, and we begin to realize that our insecurity do not define us, but they refine us. So let us embrace this journey. Let us cross the bridge of insecurity. Everyone will have this experience. And whenever they have experience, you have to determine yourself. The insecurity with the faith in ourselves, in our ability. Let us learn to reframe our fear as an opportunity for a growth and our doubt as a catalyst for an innovation. Crossing the bridge of insecurity is not a destination. It is a process. It is a journey of self-discovery or preservation and of transformation. So let us take that first step and then the next and then the next. For it is in the crossing this bridge that we discover our true potential and unlock the world of possibilities. So I would like to give you one example, and you can stop me at 15 minutes. So, so crossing the bridge of insecurity, what you need is excellence. I mean, to look at the bridge, beautiful bridge. And then what is excellence? Excellence is the quality of being excellent, state of possessing a good qualities in an eminent degree, and exalted merit and superiority and in virtue. So what do you need to cross that uncertainty? You need a courage. And then I would like to tell our story. So it was in 1978 we are established, and at that day we started. There was no dialysis machine in the Western India, and we had a 2 dialysis machine, and we started a dialysis program, and then that was the actually preparation of the transplant in the mind of Dr. Virendra Desai, who was an initiator. And in 1979, 1 year after that, he sent Dr. Rajapurkar, nephrologist, and Ajwani, the pathologist, to Denmark to learn the pathology. And he himself was on the bridge with some of the technicians who were in the theater and who were helping, and he took them for a prepare. And in 1980, 2 years after we established, he decided to cross the bridge. On the 6th April, the first transplant was done in our hospital. And then what he did was he collected all the urologists of Gujarat, Dr. PC Patel, Dr. Satish Shah, Dr. Snehal Patel, myself, and 2 nephrologists, Dr. Rajapurkar, who was full-time, and LJ Shah from Ahmedabad. And then we started. And then we did the first 10 transplant, and then 10 transplant, and then survival was only 40%. What was the good point? To one patient who survived 27 years, there must be something good we have done. Patient survived for 27 years. So let's make sure that our success predominates the failure. So that gives us a conviction that we can do. And that's how we started. We started with the help of pathologists. We started doing the biopsy. We acquired the ultrasound machine, because I wanted to do the PCNL. Ultrasound machine came with a biopsy, and they learned the ultrasound, and then they did a biopsy. And the pathologists, they helped us to define what is the problem in immediate transplant. And slowly we treated that thing, and then our survival rate increased to 60%. So then we started doing the critical evaluation. We look at the ureteric opening, because ureteric implantation, because there was a lot of urinary leak. We were using a cortisone quite high, so we had an infection. So we reduced the cortisone. We developed a technique by seeing the other people, how they do it. And we did anastomosis, a modified Leach-Greger technique, and then we only use a digestant in only 5% because of the infection. Similarly, if there is any problem because of the ultrasound, we could, if there is a leak, we could do the puncture, and then we can use a guide wire, and then we can put let me go further, and then we can aspirate the the urine and put a digestant, and then control the leak. And then, of course, we use ultrasound during the operation to see the RI, and then we adjusted the patient position, kidney position, and then made sure that the resistive index is normal, so patient output comes, and then we check. And what happened? Our survival rate for 1 year has increased to 83. And then that was a concept. Now we realize that time we were doing the transplant on Sunday. Dr. Trivedi said it is a picnic transplant, because we were doing on Sunday. And then we said it is a good concept that we should have a different department of transplant, and we built a new hospital, and then we built a new department of the transplant, and then we had this concept of separating the transplant OT also separately, the donor and the recipient, and then we had faced the criticism ourselves because we had arterial bleeding and arterial thrombosis, where we could not save the graft. So we were looking at how we can avoid those. And we found that's when we removed the kidney, we found there was a infection, fungal infection, and then we found the source of fungal infection was the duct of the air conditioning, and we changed it, and then our survival improved. And all the complication, each and every complication, we looked at it, lymphocyl, surgical complication, and we try to improve it. We use ultrasound quite frequently to monitor the kidney all the time. And then we found that the power Doppler, the contrast enhancement in ultrasound, and then that how we criticize ourselves to find out why we had the thing. So this was a journey over the bridge, and then continuously the quest. Then we used the triple transplant patient who had we didn't stop. What this patient had a first kidney transplant for 8 years. Second, he had somewhere else, and then he didn't survive. And the third one, we did it, and now still he is there. That daughter, which is now, she's 5'18", and then she's in college. This is a patient from Nigeria. We did a triple. We did a children transplant, and then that was the challenge we created. Then, of course, the creativity, because most of the donors were the female, the mother, the wife, or a daughter. So we looked at why we give them such a big scar. We asked Dr. Gill if he can come and show us the laparoscopic donor nephrectomy, and we did. Dr. Gill did too, and then there was the first time the donor nephrectomy was done in 99 or something, 98, and then after that we have picked up the donor nephrectomy. And ever since then, we have not done a single open surgery on the donor, and we have all done the laparoscopic surgery. And then we how to achieve the climate. So we had a team now. We had a surgical team. Not one person did a transplant. So the whole team did a transplant. And now we have nephrologists, the urologists, anesthetists, the staff, and everything. This is all the transplant team which was that. And then we had a curriculum. We have a DNB exams, and then we have taught the students the transplantation. And then now this is all the students who's been taught in the transplantation. And the strength of any structure is only as strong as the sum or compilation of the individual component it is comprised of. It is the design, the model, and the precision of the assembly that allows the seemingly unimaginable fortitude. And all the students which has passed from here, nearly 100 and urologists are 146 and they have spread out everything. We have done about 4,000 transplants at this MPH. But if you see collectively all those things, as so many people who are doing the transplant after passing out from here, total we have done about between the 9,000 to 10,000 transplants we have done, and we have made sure. So that bridge of uncertainty which we started in 1978, we wanted to do a place like Nadia, which was a population of 1.5 lakh. And that time there was no facilities, nothing available. But Virendra Bhai has a dream that we will create an institute which will serve the people. And that was the uncertainty of doing a success within. But we went through the process, and this is the process we went through. And today we are known as one of the pioneers. And today he is heading the, he and a submiss is heading the transplant department with all the team. And then and now routinely they are doing two transplants a day. And we feel so proud that that bridge of uncertainty has become our strong heel, I mean, strong power, where we have got a determination that any problem which we have, we can deal with scientifically, and we should not go back. Thank you.
Thank you very much, sir. Everybody is wise in retrospect. Everybody is wise in retrospect. But how do you choose when you're going forward? It's just based on your gut, destiny, or karma, whatever you might call it. It's a wonderful journey, very well shared, sir. Thank you very much. Going forward, may I call upon Honorary President, Urological Society of India, Dr. Lalit Shah, sir, to deliberate on young urologist and USI, his vision.
Good evening, friends. After a wonderful day of all activities and causing activities, learning and sharing, what we are going to talk, I am going to talk is just a simple heart-to-heart chat with our friends. There is nothing very scientific, nothing very big into this, a simple chat on that. So who is a young urologist? When we talk about young urologists, roughly speaking, it would be the, of course, you are the youngest one, sir. I am not talking about the youngest. I am talking about young only. So for this talk purpose, the young urologists will be the residents of urology and who have passed out in 5-7 years of urology. So we would be discussing about that. And youngest, we will come in the next U conference. And then what is USI? Basically, if you see, you are USI, I am USI, each and everyone is USI. After all, what happens is many times that we see in the various of the WhatsApp chat that USI should do this, USI should do that. But who the hell is USI? Each and every one of us is USI. We have been just elected to do some job, that's all. Nothing more than that. We are just as good or as bad as you are, every one of you. So every one of you is a USI, that you have to realize. And then how USI is working. There is a system, there is a protocol, there is a constitution, that things are running. 1 year is too short a period for any president or whosoever is coming to make a very great change. But fortunately, in general, the continuity is maintained and the thought process moves on. So if there has to be any change for whatever reason, for any policy decision, that has to be brought to the general body and then only it can be changed. It can, on my whims and fancies of a president, we cannot change anything. So for changing, there has to be a system, there has to be a protocol, and that has to be followed. And that is what is very important. So what are the issues of the young urologist? And how the USI is able to help or try to help and to get the suggestions that how more we can help. So it will be either residents or new pass outs. So the residents problem is, in general, what we have found in interactions with the juniors had been that sometimes there has been a lot of harassment by their faculties, and especially more so ever there has been misbehavior. Certain times there have been complaints that this one. So of course it is very, very difficult as a USI to intervene into that. But at a personal level, whatever is feasible, we are trying to do that. And there have been certain instances where we have been able to sort it out. But officially, there is nothing much that we can do. Another issue that is comes out very commonly in last 5 years, it is coming is an inadequate training. So few centers are good, but there are few centers where there may not be good training and it may not be an adequate training. I am so very happy to say that because of USI, ISU, Indian School of Urology, somehow the other I feel it is running an MCH course or probably more than an MCH course. Because there is so much of the training, so much of the teaching, so much of the hands-on, this Euromed programs are there, the urodynamic workshops are there. And in addition, of course, there are so many conferences that the juniors are getting with this. And in addition, these students get an opportunity to take the fellowship, which we never had. During our time, it was only GM Falke Travel Fellowship, where you can go to 2 centers for 1 week each, and the honorarium that I had got received in 1983 was 1,500 only. And nowadays, there are about 50 fellowships available for going to AUA, EAU, BOUS, and so many other countries and all that. And it costs about 15 to 16 lakhs to USI because to sponsor the travel fellowship. So when we passed out in 83, that's more than 40 years ago, there were about 500 or 600 members all over the country in total. And today, every year, we are getting 500 to 600 new pass outs are coming. So then, obviously, it is bound to have, see, during our time, whatever was happening, we had the difficulty of having urology as an established specialty wherever we are going. But there was enough in the plate, always coming enough in the plate, unless until you have a very big stomach. There was always enough in the plate. So it never mattered whosoever is pickling up from the side, left side or right side, it didn't matter too much. But the things here today, it is very difficult because the competition is not only with a healthy competition among the colleague urologists, but unhealthy competition with the so-called non-urologists as well. And then another question comes is about the job opportunities. After passing out, where to go, how to go, and all this and that. Fortunately, we have a group here in USI, which is putting up wherever is the opportunity there. It is put up into that so that the juniors can take the advantage. If they want to join there, they can do that. Another problem which is happening is that during our time, see, I'm practicing since 40 years, initial 30 years, I would like to repeat in any life of mine. But in last 5-10 years, the things have changed. And the Yojana and Ayushman, the payments have become so very squeezed and tightening that it is becoming very, very difficult. Very, very difficult. So they have to work out in a methodical manner. And then another question comes with the fellowship. But we already had a big session on fellowship, so I would not say anything about the fellowship. And what happens is by the time, because you do MBBS, you are on the street, again you enter a door, you do MS, again you are on the street, you do MCH or DNB, again you are on the street. And by that time, because of the family pressure and peer pressure, of course, most of the time, good number of the people are either married people, they may have the kids and all that. And it becomes very difficult still to ask money from the parents. So that becomes a very difficult as soon as they pass out. They feel a moral responsibility that they have to start earning at that point in time. So if they are going for the fellowships and all that, it all depends. Everybody's situation is different. Everybody has to realize whatever is their personal circumstances, whatever is the family responsibilities, and what exactly he wants to do. Because then after coming out from this one, the job opportunities can be everywhere. One can go into the private practice, one can go to the medical colleges. Now every district and probably every Gali Mohalla is going to have one medical college. So there would be plenty of opportunity as far as attaching to a medical college is concerned. Or maybe going to the corporate. So these are the various things are there. Another thing comes is the equipment purchase, that is what they say. And we already had a big discussion, so we will not touch upon. And for the service, the equipment services, we have a service cell, but fortunately or unfortunately, nobody complains to the service cell and nobody is found. Dr. Kanda Parekh is in charge so far as that is concerned. And he must have received a very few things. People try, maybe the people have not a very good experience of all that, but we should still try to see to it because it is definitely possible when a man representing the USI is going to talk to two, it would improve. And he had done whatever. So whenever it was required, it was done. So what is the expectation of USI? See, we always say unity is the strength, but where is the unity? We talk about here, I said every year 500 plus urologists are coming out, but how many are becoming member? It's less than 200, 300 members, it's less than 300 members. Why? Because they also become member because it has been made compulsory to put a number when you want to present in the conference, otherwise you would not be allowed to present. So that's why they are becoming member. So others are not becoming member, and those who become member, trainee member, after passing out, they don't have to pay anything, they don't have to do anything, just give a pass certificate to the central office, but they do not convert themselves to the full membership also. So where is the unity? That unity will, see, unless until there is a number, a big number, any society, how will it grow and how will it have weightage? And active participation. Like there had been certain issues which we wanted to put that, but in Patna meeting we saw that there were not too many young urologists there. They were not there. It was this issue, whatsoever was there, was going to work out for the youngsters. It is not going to make any effect on me or any of the people of our generation. But who were there? See, मरे बगैर स्वर्ग नहीं मिलेगा, मरना तो पड़ेगा. नहीं मरने को तैयार हो तो स्वर्ग की इच्छा करने का कोई मतलब नहीं है. So that is very, very important. And another very important thing is, our days were different. Like I said, there is enough on the plate. Depending on your stomach, there was always enough in the plate. But now because of this squeezing, Ayushman Yojana and all this and that, jiska payment nahi aa raha hai, uska package kam hai, you have to have an alternate source of income. We already have a Eurofinance group. Everybody should learn and do that. That is one point. Another thing that I would be saying is, sometimes a very unfortunate situation happens and there is a tragedy for a young person. So USI has started a benevolent fund. I request everybody, whosoever is not a member should become a member. Those who are members should motivate one more person at least to become the member, because as the number of this benevolent fund would grow, the payout will be better, and that would be helping some junior, unfortunately, who would be needing all this. I had to pay 4.5 lakhs for myself and 4.5 lakhs for my wife for this one. And I do not need whatever is there. But I did it with the understanding that at certain point, some family which will be requiring, who are not prepared for it, it would be helpful to our younger brothers and sisters. So similarly, I would suggest, because for the youngsters, it is going to be few thousands only, isn't it? So everybody should become a member. And I'm sure that together we can and we will. Thank you very much.
Thank you, sir. With the leadership like yours, surely we will. So moving ahead, can we have the Zoom link on? The next talk will be by Dr. Pankaj Maheshwari, sir. And the topic would be never say never, but if you had to, when and how would you? The art of saying no. Sir, please unmute, sir. Yes, sir.
Are my slides visible, Abhishek?
Yes, your slides are visible. We just need to go on the full screen. Perfect, sir. We are on.
Okay. Abhishek, I sincerely thank all of you from BioU for this kind invitation. I really loved the topic you have given to me. I really do not know whether I'm the right person for this talk. I'll give you examples why I have said this, because I'm quite convinced that I'm probably the most inappropriate person to give this talk. Friends, when Abhishek called me last week to give this talk, maybe we spoke on this week on Monday, that time I had 4 manuscripts for review on my table. I had at least 2 of my manuscripts which had come down for review. I had a couple of talks later in the next week in Hyderabad. I have to visit SIU, WCA. So a lot in my platter, but I still ended up saying yes. I have two very good friends, Dr. Sharat Shah and Dr. Gyanendra Sharma, with whom I discuss whatever lectures, whatever academic things we have. And when I told both of them that I'm likely to give this talk, the first response from both of them was they laughed. So surely this, I'm probably not equipped for this talk. But still, this idea of saying no was instilled in me way back when I was a child. When I was in 11th, 12th, as every parent does, even my father would tell me to study because he thought I should be a doctor. At that time, there were some functions in the family, some marriages where everybody was likely to go and attend that wedding. And I also got tempted to go there. My father had just one sentence to say that if you miss medical college by 1 or 2 marks, you will not get any extra bonus for dancing in your mama's wedding. That has stayed with me. And I have learned that there are times when you need to say no, irrespective of how hard it is to say no. Why is it hard to say no? And why do we end up saying yes most of the times? We are conditioned in saying yes. Our mind says that saying no may really aggrieve somebody. They may not appreciate it. So instinctively we say yes. Since childhood, how were we defined as a good boy? Good boy is a person who listens to everything that his parents say, who listens to everything that his teachers say, who follows all rules and is not a rule breaker. So since that time, we have been conditioned to say yes to everything. What friends I make, which school I go, which musical instrument I play, all decided by my parents. It didn't end there. I was good in mathematics, wanted to go to IIT. My father said, nothing doing, you are becoming a doctor. Once in medical college, I liked one girl. My father said, nothing doing, you are marrying in the society. So after that, society also plays a big role. Society dictates us what we need to do, how we need to do. Once married, I realized that me and my wife both have a similar philosophy. And that time, this philosophy was just coming up of DINK. And we said, yes, it would be good to roam around the world, be free of any commitments. But society said, no, if you don't have kids, you will be lonely in your life. Who will you share time with? So our DINK became single income cute kids. There is also a lot of peer pressure. Things as simple as which car I buy. My hospital and my home is just 200 meters. For me, walking is much faster than driving. So I do not need a big car. But all my friends in the hospital said, you are a senior consultant. You should own a BMW. Why do I need to spend 50 lakh rupees and keep it in my driveway? And last and for most important is something which is on my mind. There is always a fear of missing out. If I don't go to this party, maybe my friends are enjoying. If I don't accept this invitation to a talk, maybe I miss out. Maybe somebody else gets a preference. Maybe I stop getting invitations in the future. If I don't say yes to this review, maybe this journal doesn't send me reviews in future. So this fear of missing out is something which makes us say yes. If we say yes to everything, yes, it is easy, but you will be as normal as a normal crowd. If you want to stand out, you need to learn to say no. Is saying no selfish? Recently, I got a call from one of my very, very good friend. We have been friends for probably more than 40 years. He said, you write so many articles. Can you write one article for me? Should I say yes? Should I say no and break his heart? I said no, because that was something he needed to do. The second request was, okay, don't write my article. The next article you write, please include my name in that article as a co-author. Is it right thing to do? I said no. Am I selfish? I don't think. We should remember that our time is limited. After the necessities of life, where we need to sleep, we need to work, we need to have bath, we need to eat, there are hardly 3 to 4 hours left every day to do our other things which are likely to improve our quality of life. Here I would suggest to you a very beautiful book by Randy Zuckerberg, which says pick 3. Everybody needs to sleep, everybody needs to work. But in between friends, family, and fitness, you need to choose one of the 3. If I do more than 2 of these 3, say if I spend time with friends, spend time with family, my work may suffer, my sleep may suffer. If I try to do friends, family, and fitness, definitely my work and sleep will suffer. As a doctor, we have many more things just than these three. We have to study because our field is moving rapidly. We need to attend conferences and workshops. We need to publish our work. We need to do review work. And there are so many things that come up. So we need to choose how we spend these 4 important hours of the day. So it is important to keep your list of commitments, keep your to-do list. Make a to-do list of what things are important to you, stick it on your head table. Before saying yes to any new request, go through this list and decide which is more important to you. Do not run somebody else's race. Let it be your own show. It is no use me reviewing 100 manuscripts and not writing my 15 manuscripts, which are there on my table. So how do I say no? A brilliant book, again, The Art of Saying No, where it tells you how to stick to what you have to say. By saying no, reclaim your time, reclaim your energy, and people will stop taking you for granted. Sorry. You have to find strength to say no, and you have to say no without angering people. So how do we do that? You need to realize 3 truths. Saying no is not selfish. By doing things which are important, you are indirectly helping the society, helping the world. If you are more energized, more healthy by doing your regular exercise, you will be able to probably help more people. You have to say no for the right reasons. I can't be saying no to a patient because I want to watch a cricket match, but I will definitely say no to doing a PCNL if I have to travel tonight for attending the AUA, because who will take care of this patient in the post-op course? Also remember that every yes you say, you are probably saying no to things you love. This is very, very important. Every yes you say, you are saying no to something you value, which is important and which is really, really plays a role in improving your career. So how to say no? It could be a categorical no. You could reference a commitment, or you could give a counter offer. When you say no, the categorical commitment should start with, I have stopped, I don't, I have a rule. Don't give people a chance to negotiate. Examples, I won't come for a drink today evening because evening is my swimming time. I will not come for lunch with you on this Sunday because Sunday is the time I spend with my wife and my daughter. I don't operate in this hospital which is near your residence because I'm not happy with the equipment there. Or I don't do this particular surgery. There is somebody else who does it better. If you don't follow these rules, you will end up accepting something which you will regret. And if you say this, most often the person will say, not only say, never mind, may also thank you for giving you the right advice. You can give a counter offer. I can't come to Jalandhar for a workshop because I will end up traveling from here to Delhi or Chandigarh, then a 3-hour drive. Instead, why don't you call somebody from North Zone? He's equally good as me. I will tell my friend who asked me to write a manuscript, I can't write your manuscript, but please write it. I will help you edit it and draft it. Or there are 5 things that somebody requests me to do. I'll say, okay, I can't do all these 5, but I'll definitely do 1 for you. So I can say, Abhishek, this time I can't travel to Nadia. Next time I promise I'll be there. I cannot do ABC for you. I will definitely do A. This time I can't come in person, but I'll definitely talk to you on Zoom. And if I say this graciously, he will accept it. Finally, remember, time is short. When we say no, it increases our generosity, increases our efficiency. When we say no, we value our time, people value our time. And when we say no, we find time for things which we love, people which we love, and things which are really going to improve our quality of life. Say no with commitment, say no with a commitment reference. So occasionally you can give a counter offer. Before signing off, there are 2 comments from Godfather that I remember and that I love. You cannot say no to people you love, not every time. But the secret is when you say no, it should sound like a yes. It should sound like a yes. You need to make time. You need to take trouble to do this. The best thing would be if you help people itself to say no so that you don't land into difficult situation. But if you still say no, don't worry, people will not mind it because people respect people who tell the truth. Thank you for this patient hearing, and I thank for this kind invitation.
Sir, if you would have said no, it would have been a big loss to this meeting. That is what I can say. Your yes has made a beautiful evening for all of us. Thank you very much, sir. Your diligence, your proficience, and your work on the presentation is for everybody to see. Thank you very much, sir.
Thank you, Abhishek. I really enjoyed, and I'll be there online to attending rest of the talks.
Thank you, sir. Moving ahead, may I invite Ravindra Sabnis sir to deliberate on financial mistakes that he made.
Well, after those lots of philosophical talks, this is a completely different talk. And ultimately, all philosophy and all everything ultimately ends in finances. And therefore, probably Abhishek has put this talk at the end. Well, financial mistakes which I made. Did I made any mistakes? Everybody makes mistakes. But instead of what mistakes I have made, it is the financial mistakes what youth makes. That is what I'm going to talk, because this is a youth conclave. And there are many mistakes which young people do it. We understand and we know it because we have passed that era. And we know what we could have done it at that time, what mistakes we did at that time. And that is generally done by almost every young person. Young in the sense, what Lalit Bhai said, young means not particular age, but young at heart. And so what mistakes generally youth makes, that is what is the talk. Well, the first mistake, and this is very, very important. If you understand first mistake, we can all go for the dinner, there is no problem. You have understood everything. First mistake is not understanding the power of compounding. That is very, very, very important. This is the one important thing which nobody realizes. You realize only after certain age is crossed. And that time you repent. Arey, I should have done that. I should have done this. I should have done in this particular way. But the time is gone. The time is extremely precious. And what is power of compounding is time. So let me just give this example to you. That this is a person who at 35 years of age starts investing 12,000 rupees per year. Nothing much, just 1,000 per year, and invest for about 30 years. This person starts at 20 years, invest only 5,000 per year, very meager amount. Invest only for 15 years. After that, he stops. When he starts investing, he has already stopped. Now, at the end of 65 years, he has 32 lakhs, and what this fellow has accumulated, 36 lakhs. This is the difference. This is the example. This fellow starts at 25 years, he invests 5,000 per month, same return, and this fellow starts at 30 years, same amount, same investment. He invests 18 lakhs total, he invests 15 lakhs, little bit difference. What is at 55 years of age, how much he has accumulated? 2 crore 21 lakhs. And what he has accumulated? 1 crore, almost half. Or this fellow has doubled. Everything is same. What is the difference? Just the 5 years difference. So 5 years early is the biggest difference which you cannot make up. So that is very, very important. If you are trying to invest tomorrow, that is wrong. You have to start investing today. That is what is the message. If you understand that, all mistakes subsequently are nothing much. This is the power of patience and power of compounding. What is it? If you start investing, quite often you will realize that, oh, 3 years are over, 5 years are over, 7 years are over. Nothing much has grown. There's hardly any benefit, hardly anything. Then you start losing patience. That is the biggest mistake. The power of compounding starts only after 5, 7, 8, 10 years. Now you see, it's almost the same, nothing much. This is a power of patience. If you cross this barrier, you are in this barrier. What is the difference at 20 years? This is a difference. See the difference. It is almost 4 to 5 times difference. What is it? Just patience, nothing much. No great thing, just patience. That is very important. And that's so Mistake which everybody does, that is what you have to understand. Mistake 2 is selecting the selection of insurance policies. Now we see lots of advertisement. I am sure many of you must have taken this insurance policies, that combining insurance policy with investment, completely wrong. Biggest mistake. You will see all these advertisers. They are all fooling, cheating people. It is wrong. If you get into this advertisement, it is a financial mistake. Buying ULIP, everybody is very fancy about ULIP. I am sure many of you, your relatives, your parents, they must have said buy ULIP, because it looks attractive, but it is not. Whatever is attractive is bad. So you will realize it. Not that way, don't take it the other way. Don't take it the other way. But you will realize it. So 95% do not understand the difference between term insurance and endowment policies. They are victims of advertisers and agents. Most often the agents are known people. They will come to your house, they are from your relatives, some Kaka, Mama, something, somebody, say buy this policy, and you are victim of that policy, and you end up in destroying your money. LIC is not LIC, the full form LIC is Loot India Company. You have to understand that. So what is the tip for the insurance? Avoid ULIPs and traditional plans. Buy insurance, buy term insurance only. Simple, very, very simple, nothing fancy. Start insurance only when you have dependents. There is no point. I have seen people taking insurance for their children. It's nonsense. Absolutely no logic at all. If you are people who are dependent on you, you need insurance. If there is no dependent on you, there is no need of insurance. Very clear. If your wife is earning well, if your earning is much more than you, then you don't need insurance. She needs insurance. That's very clear. So if you build wealth when you do not have any dependents, stop insurance. There are people who buy insurance policy and they give attraction, the excellent premium, very low premium, lifetime policy, 95 years, 100 years. What is the logic? There is no point. Once you build your wealth, you stop insurance. There is no need. You are unnecessarily paying that amount, even though it appears small. But over a period of time, for that much period of years, you have destroyed your money. Mistake 3, investment mistakes. This is the biggest mistake. Delaying investment for tomorrow. This is what we saw in the first mistake. Quite often, what youth people do, young people they do, they earn money, they are in a good practice, they spend a lot of money, they go here and there, holiday, this, that. And whatever is left out, they say, no, I will invest. So this month they will invest good amount. Next month, no, I had a lot of this expenditure. This time I will not invest. Is that? So that is wrong. In fact, this is where the mistake occurs. Investment is not the amount which is left out after spending. Investment is the amount which you have to invest, and whatever is left out, you have to spend. You have to understand that. Lack of patience, which we saw, is the biggest mistake. Depending on others for investment decision. This is what, Anil Alliance has done this. Lalit Shah has done this, so I will do this. Wrong. You see, their investment thinking may be different. Your investment thinking may be different. Your objective may be different. Your goal may be different. You cannot have same investment policy as somebody else just because he is rich and he is investing in that. Do it. Wrong. That's not correct. You have to understand your own objective, your own goals, and invest into that. Getting too greedy with investment. Quite often you will see that in a WhatsApp group and this, they will say, I did trading on this and I got excellent this. For 4 years, this is a return. For 3 years, I've got double money. And then you also start jumping into it. And what happens? Whatever you invested is gone, completely gone. So attracting that this money's return is very good and very fast, avoid it. There is nothing which will give you very fast. Slow and steady only is the correct income. Otherwise, that investment is not proper. That's very, very sure. Investing for tax saving is another mistake. Quite often people do, and this a lot of people advise. No, this is a policy, this is a thing. You invest, you will get this much benefit, this, that. Investing for saving tax is the biggest mistake. Never, never, never do that. So don't invest to save tax. Tax saving happens by the way. If there is some good policy and it is a tax saving this, it happens. So invest what is the best policy. Forget about tax. Pay the tax. But if there is a best investment option, put into that. Even though it is taxable, it doesn't matter. Over a long period of time, that will be much, much better option than putting into this. No investment is perfect. Fault can be in all investments. Nothing is 100%. So don't get frightened that I have invested that money. Is not, doesn't matter. Everybody does that mistake, but on that mistake, you will learn. Saving will not make you rich, but investment will definitely make you rich. So just saving the money is not enough. That saved money, putting appropriately into a proper method and proper plan will definitely make you rich. That's very important. Fourth mistake, taking loans. A lot of people, young people, they take loan for instrument, for personal thing, for car, for this and that. All these loans, very bad. This is the biggest mistake. Except the home loan, you should not take any loan. If you want to buy certain high cost thing, you invest, and when you accumulate money, you buy that. But don't buy and then keep paying EMI. You are going to lose a lot of money. Interest rates are high. That's a destruction of your wealth. Home loan, definitely yes. You have to take home loan because Government of India's policies are such that they give a lot of benefits on the interest, on the capital, on the investment, on the capital, on the interest, and there are so many options which are there. So home loan, definitely yes, because the interest rates are least with the home loan and not with the other loan. So any loan is bad except home loan. Home loan, you must have the home loan on your head all the time. If you are not having home loan, any one of you, you are making a big mistake. Have a home loan on your head all the time. If I don't have home loan, I feel restless. There is no home loan. So that much is the benefit. So I have to keep buying home. I have to keep buying. So what is mistake? What is the number 5 mistake? Becoming victims of lifestyle inflation, which Pankaj Maheshwari also said. That when you start earning more, you do robotic surgery, or I go to Max, I'm Apollo, I'm this, advocate, is that, and you start earning good amount of money. So now I'm earning, now how can I go in Alto, Maruti Alto? I have to have this Mercedes and this. He said, my status symbol. So moving from a 2-3 bedroom flat to bungalow just because you have started earning more. Upgrading car from your hatchback to sedan to SUV, Audi and this that. Even though your hospital is only 1 kilometer away, but you want that Mercedes and BMW. That's a lifestyle inflation. This is just to keep the status symbol. This is destruction of money. Multiple cars. Oh, somebody said, he has only 1 car. No, I have 2 cars. There are 3 cars. There's no need. Changing mobile. Every year, iPhone Pro, iPhone what? something keeps coming. So there is advertisement. मेरा resident के पास वो है. अरे मैं क्या करूँ? मेरा तो खाली ये है. So I have to buy. No, that's wrong. See, there are several such examples in day-to-day life. So buying things just because they are on discount. This is called as mall effect. You go to mall and you are gone to buy something, and there are hundreds of things which are discounted, and then you keep buying things. So what they have said, and they have found that this Amazon, Flipkart, this mega discount week and this that, 40% of the items which are sold are actually not necessary. You buy it is out of not necessity at all. So that is what is the lifestyle inflation. Vacation on exotic location. Somebody is putting some photographs. There is no need. Chandramohan will put some photographs. I want to go there. There is a need. You are going to Bali, you are going to some Mauritius and this. There is a need. You go to Igatpuri, you go to Lonavala. So simple vacation also is okay. Understand the purpose of vacation. Just because somebody is gone there doesn't mean that you have to go there. There is no need. This is not for you. This is for us. Spending huge hard-earned money on children marriage. It is all right that Ambani has spent 8,000 crore rupees, but that is not hard-earned money. We are earning hard money. Urologists are earning money out of very, very hard work. In spite of Yojana and Ayushman and this, that money, if you earn and save and invest, and if you spend huge money on children marriage, it is a wastage of money. There is no need. Step 7 is lack of understanding between what is asset and what is liability. Very, very important. What is asset is the one, suppose if you lose job, suppose if you have got accident, if you are debilitated, assets will feed you, but the liabilities will eat you. So you have to have more and more assets than liabilities. And there are a list of lot of assets and liabilities. When you are young, try to create assets over a period of time, because building asset is not 1 minute job. It takes many years. If you understand that what are the assets which will feed you at particular age, start building that asset from now itself. Because when time comes in, those assets will be the only thing which will help you, not the liabilities. Other thing mistake is the lack of discipline. That's what I said, that on first month you do this, second month no saving, third month loss, fourth month gain, this, that. That's not correct. You have to have discipline investment. Lack of discipline, not having a mindset, that is very, very important. What is the difference between the person who is wealthy and person who is rich, person who is not earning well? It is the lack of mindset. They have done one interesting study. You may put well, but I'm just going to tell this. But this is very important for every you to understand this, because there was a survey which was done, and a rich person, his all money was stolen away, it was taken away, and there was a poor person who was given lots of money. And after 10 years, they found out what has happened to them. The rich person, who actually was a rich person, whose every money was taken up, became much more richer after 10 years. And the person who was poor and he was given lots of money was much poorer than what he was. What is the difference? Is not money, it's a mindset. If you have that mindset to become rich, you will 100% become rich. But if you have a mindset which is not of that kind, you will remain poor, whatever. Even if you get 10 lakhs of rupees salary per month, you will remain poor. But if you have 1 lakh of rupees salaries, you will become rich, provided you have discipline and provided you have that mindset. That's very, very important. So that is very important. And lastly, which Lalit Bhai also said, the biggest mistake, if you have not been the member of USI Benevolent Fund, it's no-brainer. I'm telling you, there is no scheme in whole, you search anywhere, there is no scheme which is better than this Benevolent Fund. If you show me that scheme which is much better than this, slightly better than this, I will give you 10 lakhs of rupees. It is not possible, because this scheme is done by Urology Society of India. Everybody who is working for this scheme is working voluntarily. There is no commission, there is no hidden thing, there is nothing. It is purely for the benefit. As you rightly pointed out, for young person, it is only 8,000 rupees, for which you are getting the benefit, which is worth. I have paid a huge amount of money, 2.5 lakhs rupees, but still I have paid, because in spite of that money, I know it is beneficial. That benefit you are getting only in 8,000 rupees. So if you are not becoming a member of USI Benevolent Fund, it's the biggest financial mistake which you should avoid. That is what I wanted to say. Thank you very much.
Thank you very much, sir. Yes. Mike, sir. Sir, if there was a memoir of Urological Society of India, the credit of financial literacy would go to you.
I know Dr. Sabnis for last 35 years. As a urologist, I never knew as a financial man.
Moving ahead, we are looking for the icing on the cake, and therefore, okay. Okay, may I have your attention, please? Thank you, thank you. So, looking for the icing on the cake, we have Dr. Prashant Madhavkar's talk on turning wounds into wisdom.
So friends, good evening. जसप्रीत बुमराह, लास्ट ओवर बाकी है, 15 रन निकालना है, आप पे है। कैच आ गया जो छोड़ देना भैया, पकड़ना मत। So the topic that is given to me is
turn your wounds into wisdom.
Turn your wounds into wisdom.
Oprah Winfrey.
So what are the wounds that we have? A surgery that fails, major complication in surgery, the fellowship that you work for, that you desired for, that you prepare for, and do not get it. The job which you desired but could not get. And the job which you love, which you do not love and have to work. So ये सब जो है, these are the wounds. But all these wounds are basically turning points in our life. Now, before I go further, what is the biggest turning point in your life? कोई भी बताइए. Biggest turning point in your life.
Parimal.
Parimal bhai. Life. Yes, sir. Sabnis sir, biggest turning point in your life.
Become a urologist.
Yes, sir. Kishore bhai. ये सब जो है ना सब मिथ्या है. The biggest turning point in your life is ये. This is the biggest turning point in your life. This will make you or break you. Guinness World Record, urology और यो क्या अल्फाड़ा बोला था आपने? कोई मजा नहीं है. So the biggest turning point in your life is your marriage. And if you talk of bride and groom, the biggest turning is for the bride because she changes the family. So whenever there is any lafda, you have to do bridal makeup. So to turn your wounds into wisdom, you have to do bridal makeup. And what is this bridal makeup? That I will explain. First B, take a break. Calm down. Take breath. Then analyze. That is B. R, review your strategy. Review what you were doing. Review how you could have done it better. Review how you can improve your resume. That is the R. That is the second component of the bridal makeup. I, you improve your skill. You improve your surgical skills. You improve your interviewing skills. You improve how you interact with people. That will turn your wounds into wisdom. That will add to your life. D. Sometimes it may become easy to divert. Try some other arrangement so that you get enough time to think. Another component of the bridal makeup is accept. Accept the world. दुनिया जैसी है वैसी है, आप दुनिया को नहीं बदल सकते. Accept the world. Change your mindset. accept something lower, accept temporary defeat. वो कहते हैं ना, सर सलामत तो पगड़ी 50. So accept defeat sometimes, although that defeat will be temporary defeat. I cried because I had no shoes. Then I met a man who had no feet. Accept. दुनिया में कई ऐसे लोग हैं, उनको आपसे भी ज्यादा गम है, आपसे भी ज्यादा दुख है, आपसे भी ज्यादा परेशानी है. वो कैसे रहते होंगे? एक्सेप्ट करो. L. Listen to your instincts. Listen to your intuitions. Listen to your friends, so that you have long-lasting solutions and you have long-lasting vision. M. सबसे इंपॉर्टेंट है M. M बोले तो सबनी सर वाला नहीं है, मनी नहीं, मोटिवेशन. What is your biggest asset? Your biggest asset is yourself. So you have to motivate yourself. Take a very small step every day. छोटा सा पौधा है, रास्ते में उग रहा है. Take a very small step every day. Read self-help books. Believe in God. भगवान सब ठीक करता है. Another M is mirror. Morbidity, mortality rounds, discussing the complications, analyzing our own actions. This is the mirror that we have to see for ourselves. The biggest motivation that I got is from this.
I did something terrible. I don't want to talk about it.
Look, kid, we've all made mistakes. There must be something we can do, right?
Not unless you can change the past.
Well, that's a lot to ask.
That's pretty
if I'm
hard.
being honest.
That's
I mean,
a biggie.
change the past that already happened.
Yeah, so
But-
you can't change that.
You can change the future. That's our specialty.
Kind of roughly.
How can you change something that hasn't happened?
Well, to change the future, you got to put your past behind you. When the world turns its back on you, you turn your back on the world.
And only embrace what's next.
And turn the what into so what. Repeat after me, kid. Hakuna Matata.
एक बार सब लोग बोलते हैं हकुना मटाटा. यार आवाज नहीं आई. हकुना मटाटा. हकुना मटाटा. Next component of the bridal makeup is A. A is analyze and act. Too much analysis leads to doubts. You have to act. And in analysis, you have to be frugal. Don't spend much time, much money, and unnecessary energy in analysis, because actions matter. Next component of the bridal makeup is K. K is knowledge. You have to keep up with the knowledge explosion. You have to get schooled. You have to learn. At this age, sir learned AI and passed an exam in AI. So there is no age limit to gaining knowledge. लेकिन knowledge मिलने से कुछ नहीं होता है. You have to show your talent to the world. ये कौन है? शांत से. काफी टैलेंटेड था, लेकिन कहता है कुछ दिन ब्रेक लेता हूं, थोड़ा आराम करता हूं, फटीग हो गया, दुनिया आगे चली गई, वो वहीं रह गया. So being talented is not enough. The last button component is you. Understand. Understand the situation. Wait for the right time. And when you get the right time, get in. P. P is people. The non-physician components, the non-physician members of our team are people. Hillary has said in this book, it takes a village to raise a child. That means the whole society takes part in bringing up the child. So the people around us are important. So we have to praise the people who our parachute. With this, जो टर्निंग पॉइंट मैंने आपको बताया था, you will reach this stage and you will be happy like this in your life. Married life, active life, urology life, financial life चले गए.
चले गए.
Home loan लेने गए. So, friends, behind every successful man, there are many unsuccessful years, many failed attempts. दोस्तों, असफलता एक चुनौती है, इसे स्वीकार करो. क्या कमी रह गई, देखो और सुधार करो. जब तक न सफल हो, नींद चैन को त्यागो तुम. संघर्ष का मैदान छोड़ मत भागो तुम. कुछ किए बिना ही जय जयकार नहीं होती. लहरों से डरकर नौका पार नहीं होती. कोशिश करने वालों की हार नहीं होती है. तो एक बार फिर से कहते हैं, कोशिश करने वाले की हार नहीं होती. कोशिश करने वालों की हार नहीं होती. थैंक यू.
Sir, you are truly the showstopper of every event and this event also. Thank you very much. You are the designated lateral speaker of Urological Society of India, and you do it so wonderfully every time, sir. Thank you so much, sir. Thank you, sir. So please stay put. We'll start the inauguration. You gentlemen, you cannot move. You're important for the inauguration. So I call upon Dr. Raisa Shetty to start the proceedings.
Good evening, one and all. On this special occasion, let me invite all the dignitaries on the dais. Dr. Lalit Shah, sir, President USI, Dr. Mahesh Desai, sir, the chief guest for today, Dr. Abhishek Singh, sir, YOU chairman, Dr. Abhijit Patel, sir, organizing secretary, and Dr. Rohan Batra, sir, co-organizing secretary.
Amit, Lalit,
Abhijit Patel.
he is coming.
We are absolutely honored to have all of you here. May I now request Kajal and Prerna Ben to felicitate the dignitaries on the dais with a small token of love. Dr. Lalit Shah, sir. To Mahesh Desai, sir. Dr. Abhishek Singh, sir. Dr. Rohan Batra, sir. Billy Stargell said, that's where the future lies, in the youth of today. On this note, I, Dr. Raisa Shetty, wish a very good evening to all the dignitaries on the dais, guests and delegates with great joy and immense exaltation. I feel privileged and extend my warm welcome to all present here for the 5th Youth Conclave at MPUH Nadiad. So Kajal, could you please felicitate Patel, sir? So let's start the inauguration by introducing someone who is a fountainhead of illuminating ideas and an idol of inspiration. The entire conference is his brainchild. Let us all have the pleasure of listening to the chairman of YOU, Dr. Abhishek Singh, sir.
Honorary President, Urological Society of India, Professor Mahesh Desai, sir, my Guru, Dr. Sabnis, sir, senior dignitaries, faculty members, and dear colleagues. It is indeed my proud privilege to welcome you to this August gathering. It was conceived in 2020 as a brainchild of then President and Secretary, Dr. Madhusudan Agrawal, sir, and Dr. Rajiv TP, sir. That made this organization see the light of day. Our first chairman, Dr. Dilip Mishra, conceived the first program done at Kochi. Subsequently, he had a online webinar during the COVID era. Then came the turn of Hyderabad. Dr. Zishan took up the role, took up the reins. He took the organization to newer heights. Where Dr. Dilip put the organization together, Dr. Zishan helped this organization move forward. With the last conference that he conducted at Goa, he set up a new benchmark that even when young colleagues try to do an endeavor, the entire industry stands by them, which was exemplary. He handed over the reins to us, and it was our turn to do something which was worthwhile for the young urology group. The objective of two-day meeting primarily was to put up skill sets that everybody could adapt and would be worth everybody. It would be worthwhile in everybody's careers. That is how came the concept of basic laparoscopy and ultrasound. The sessions like Wisdom Corner and Out of the Box were conceptualized so that we start thinking laterally. The ideology being the life, the race is only a few millimeters. You've covered all the big kilometers by doing MCH, but why do two students passing from the same institute, having the same degree differ? This race of millimeters will be covered when we learn lateral aspects. That was the objective of training, of keeping sessions like Wisdom Session. What I envision for our organization is that each one of us has disciplined imagination for whatever he does and a grit to follow that imagination. Thank you for being here. I hope you were able to live up to your expectation.
Thank you, sir. We would like to appreciate the goddess of wisdom for the blessings by kindling the lamp. We pray she bestows upon us academic and future prosperity. I request our faculties on the dais to please light the lamp and inaugurate the function.
या कुन्देतु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Now, I would like to invite a person who's not only a leading urologist with several years of experience, but also a medico-legal expert. I would request the president of USI, Dr. Lalit Shah, sir, to share a few words of wisdom with us.
dignitaries on the dais and off the dais, and friends. I must compliment the council of you and the organizing committee for a wonderful, wonderful arrangement and inviting us to be here. It's a great learning and sharing experience. Like I said in my talk also, the youth is the future of any society. So similarly, the Urology Society as well. So once again, I would like to repeat the same thing again and again, because I know good number of the people are probably still in this hall also are not the members, or they are not the full members, or not the members of Benevolent Fund. So I request each and every person again and again to become the member, to become full member, to become Benevolent Fund members, and motivate at least one of your friends to do so. Because the more the strength we will get, more effective we will be. Not only for this, even for whenever we need to negotiate with the government for the so-called present-day problem of the Ayushman rates. Because if it is bad, and I'm sure in another 5 years, it is going to become worse. So unless until we are able to work out with that, today nobody listens to us. So unless until we have a strength, nobody would listen to us. Dr. Rohit Joshi had been in one of the meetings. He did present whatever is there, but घड़े पे पानी फिरता है वैसे ही चलता है. With that, I wish you all the best and for the wonderful conference. Thank you very much.
Thank you, sir. In recognition of the exceptional achievement, it gives me immense pleasure to introduce you to the winners of the practice-changing publication session, Dr. Tarun Parikh and Dr. Naveen Kumar. I request our USI President, Dr. Lalit Shah, sir, to felicitate them. Dr. Tarun Parikh has joined us through the Zoom link. I request Dr. Vivek Barekar to collect the certificate on his behalf. Dr. Tarun Parikh is with us online.
The best practice changing publications.
Now I request the chairman of YOU, Dr. Abhishek Singh, sir, to please come and appreciate all those who helped the YOU section of USI to bud and bloom like it has today.
Thank you, Reza. The present council of YOU would like to recognize the efforts of the gentlemen who've taken this organization to the point that it is. May I call upon Dr. Dilip Mishra for his contribution to YOU.
Please pin this badge to Dr. Mishra.
May I call upon Dr. Zishan BM, who's actually set up this trend of having meetings on our own.
I don't have a pocket. I'll put it myself.
Now, in the order of them bearing the office at the central USI, and in the chronological order of years, may I invite Dr. Rajiv TP. It is basically Sir's brainchild that this organization is where it is.
Thank you, sir. Thank you very much.
It is on.
Thank you.
It is only appropriate to recognize the contribution of late Professor Lakshman Prabhu sir for helping YOU develop during its initial years. I call upon Dr. Ravindra Sabnis sir. It was his third tenure that the YOU started developing under leadership of Dr. Zishan. I call upon Keshav Murthy sir. He is the person who taught us to adhere to time, perceive and get things done by continuously hammering onto whatever you needed to get done. I recognize contributions of past council members who worked tirelessly to get the institution to the place that it is today. May I call upon Dr. Rohit Joshi?
Thank you.
Dr. Ravi Jain.
Yes.
Dr. Tanuj Bhatia.
No problem. Just check.
Dr. Debang Sarma. Dr. Zaid Raza. Dr. Raman Tanwar. Dr. Milap Shah. Dr. Abhijit Patel. Now, this is an inception meeting of SARC YOU, and there's one person who's categorically responsible for development of this international organization. And of course, from our side, it was Madhusudan Agrawal sir and Rajiv TP sir, but it is Dr. Pawan Raj Chalise sir who has brought this entire SARC YOU group together. And we'd like to welcome you, sir, to Nadia. Our colleague members in the SARC YOU, Dr. Manish Pradhan and Dr. Munipriya, please come onto the stage. And President sir, from the Urological Society of India YOU group, I would like to welcome you to Nadia.
Today, I have the privilege to introduce a person who is a true visionary and a leader in the field of urology. He has dedicated his entire career in finding new technologies and solutions to make easy the urology for us. I welcome our chief guest for today, Dr. Mahesh Desai sir, to say a few words and enlighten our youth.
Thank you, Raisa. Dr. Abhishek Singh, Dr. Lalit Shah, Abhijit, Rohan Batra, and all my young friend, young urologist, Dr. Sabnis, and I'm also young, only 80 years old. So, what I feel today, and I must congratulate you because the way it has been conducted, there is a two part of it. One is knowledge acquisition. We've been listening to everything. And in the beginning, in the morning, we had the skill development. We could see the surgery, and there's some of them beautiful talk on laparoscopic surgery, and then there was a hands-on classes were going on, and simultaneously, I think every aspect of the urology was incorporated in the conference in a different hall. I think I was very much. Both the things are important: the knowledge acquisition and the skill development. And I think I won't take much time, but there is for young people, it is most important is evidence-based medicine. Stay updated with the latest research and clinical guidance, and continuous learning is most important. And this is what this conference is doing. And then we must have a collaboration with radiology, pathology, and other disciplinary work. Now, today we saw the minimal invasive surgery, the laparoscopy, and talked about the robot and the endourology. And what's important, somebody gave a very good talk on a personalized medicine, tailoring treatment to the individual patient based on the unique characteristic. And that includes the genetic and comorbidity, and I think everything should be taught. And of course, we show the telemedicine. We had a connection with the USA. We had a connection with the different part of the India. I think it has got a lots of points, and I really congratulate you and your team for organizing everything. I think people would be much more richer going home tonight, listening to all the things. And again, thank you for inviting me here. I started feeling young again.
So, thank you.
Thank you, sir. While thanking the Almighty for His countless blessings, we are here to speak out words of thanks to all those who made this event an auspicious one. I would like to invite Dr. Abhijit Patel, sir, to deliver the vote of thanks.
Good evening, everybody. I, Dr. Abhijit Patel, as the organizing secretary of 5th Youth Conclave, would like to thank beloved USI President Dr. Lalit Shah, sir, USI Secretary Dr. Uttam Mete, sir, for the guidance. I would also like to thank the YO Chairman Dr. Abhishek Singh and YO Council for the contribution towards scientific content. I would take this opportunity to thank our mentors Dr. Mahesh Desai, sir, and Sabni, sir, for the guiding light, and hospital administration for their excellent support. I would like to thank our colleagues Dr. Rohan, Niramya, Nishant for their tireless effort. I would do injustice if I didn't thank the endless efforts of our residents, which have led to the current shape of this conference. I would like to thank JPAC team, Mrs. Purnima, Anil, Meet and his team, along with our audiovisual team, Kalpesh, Manoj, for the excellent live operative workshop and scientific face that you have seen throughout the day. A big round of thanks to the pharma industry for their generous support for this conference. Finally, I would like to thank all the lovely audience who have taken efforts to travel across India to make this conference a huge success. Thank you.
Thank you, sir. We shall now indulge in few moments of reverence and unity as I request everyone to stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
The dinner is at Boulevard Resort, which is a few kilometers from here. There will be vehicles down to ferry you, otherwise jump into a friend's vehicle.